that. So now we are going to initiate the paper presentations. The judges will be Dr. K.K. Noria, Dr. M.R. Gupta, Dr. Kaushik and myself. So there will be 5 paper presentations. So hand over the dice to the comparer to call the paper session.
Our first paper will be presented by Dr. Shaminder Singh from GMC Patiala.
Good evening everyone. My name is Dr. Shaminder Singh, Junior Resident from Department of Pulmonary Medicine, GMC Patiala. My topic for today's presentation is Navigating the Nexus, Weight Radiology and BMI in Tuberculosis Therapy Outcomes. Tuberculosis caused by Mycobacterium tuberculosis stands as one of the deadliest communicable diseases globally. Its primary manifestation is pulmonary involvement. Many researchers have established a link between active TB development and malnutrition. Malnutrition has the potential to suppress T lymphocyte proliferation and hence hindering cell-mediated immunity, leaving the host more susceptible to tuberculosis infection. Weight loss at TB diagnosis is a risk factor, while weight gain during the treatment indicates treatment efficacy. The aim of the study was to explore the correlation in radiological outcomes, body mass index, and weight fluctuations in pulmonary TB patients. It was a prospective cohort study comprising of 110 patients aged over 18 years diagnosed with pulmonary tuberculosis on both microbiological and clinical radiological basis. Clinical and radiological evaluations with body mass index and weight measurements were made at initiation of ATT, at 3 months of ATT, and after completion of ATT at 6 months. Pregnant females and drug-resistant cases were excluded from the study. In this table we can see that at initiation of ATT, the average body mass index of the patients were 16.47 kg per meter square, while at completion of ATT it rose up to 19.11 kg per meter square. The average weight of the patient at initiation of ATT was 42 kg, which rose up to 48.74 kg at completion of ATT. In this table we can see that out of total 110 patients, at end of 3 months of ATT, 101 patients gained weight, while at end of 6 months of ATT, 106 patients gained weight. In this table we can see that the patients with better radiological outcomes had better mean weight as compared to the patients with poorer outcomes on the chest X-rays after completion of ATT. In our study, the patients between age group of 30 to 40 years gained maximum weight, that is 12% as compared to initiation of ATT, while patients in age group of more than 70 years gained minimum weight, that is 7.98% as compared to initiation of ATT. At 3 months of ATT, 91.81% of the participants had weight gain, while 4.55% individuals experienced weight loss and 3.64% individuals maintained stable weight during the ATT. At 6 months of that is completion of ATT, 96% of the participants had weight gain as compared to initiation of ATT, and 0.91% patients experienced weight loss and 2.73% maintained stable weight. Wasting is a prominent characteristic of tuberculosis and a contributing factor to disease severity and outcome. It is partially attributed to increased expression of plasma peptide YY, leading to reduced appetite. Weight loss is also attributed to bacterial endotoxins in TB due to dehydration from decreased water intake and anabolic block causing poor response to food intake. ATT had a pronounced positive effect on BMI and weight, indicating its therapeutic efficacy. Weight gain during the treatment correlates with favorable outcomes. TB patients should be advised to maintain a balanced diet, encouraging the cultivation of kitchen gardens for fresh seasonal produce. Collaboration with government agencies, social welfare departments, public distribution systems, agriculture department, NGOs and philanthropists can bolster nutrition support. PM Nikshay Poshan Yojana, Nikshay Mitra and nutrition app by the government are the commendable steps toward TB patients' nutritional welfare. The patient adoption policy under Nikshay Poshan Yojana effectively uplifts the nutrition of TB patients, leading to improved prognosis. And then we would like to express our sincere gratitude to the participants who took part in the study and generously shared their personal health information with us. We also extend our thanks to the healthcare professionals who assisted with patient recruitment and data collection.
Thank you. I have two sort of queries. Number one, see how much you can depend upon the weight gain, see, as far as the efficacy of a treatment is concerned. I've seen a lot of patients that still don't put on weight, but clinically if they are all right, the fever is not there, the cough is not there, and the general well-being is there. So see how much you can depend upon your weight gain all the time.
Sir, in our study, we have compared the weight gain with the radiological clearance. So the patients with the better radiological outcomes, the clearance of opacity, heterogeneous opacities on chest X-ray were found to have better average weight than the patients with poorer radiological outcomes.
The other thing is, you see, extra-pulmonary tuberculosis, you just mentioned tuberculosis, and then again you said pulmonary.
Sir,
because extra-pulmonary tuberculosis probably behaves differently than the pulmonary tuberculosis. I've seen a lot of patients, they still don't lose weight, still have this tuberculosis. I mean, again, you see the weight gain or weight loss again doesn't come into that picture, you see, to justify our efficacy of ATT treatment.
Sir, in our study, we have only included pulmonary tuberculosis patients.
What heading was tuberculosis? In conclusion.
So, okay, tell me one thing. What do you expect when you treat a pulmonary tuberculosis or any tuberculosis case? According to your title, please go to the title. Yeah, navigating nexus, weight, radiology and BMI in tuberculosis therapy outcomes, right?
Yes.
So if you treat a tuberculosis case, take pulmonary tuberculosis, what do you expect? With treatment, radiological improvement is there or not?
Yes, sir.
It is there. Weight gain may or may not be there depending upon comorbidities, because you have not mentioned that how many pulmonary tuberculosis patients were diabetic, malnourished to start with, or any other comorbidities like inflammatory bowel disease or nutritional status, you have not mentioned.
Yes.
So even if you don't mention, generally we expect weight gain with tuberculosis treatment.
Yes.
So what new you are getting out of this study? They are established facts. For any problem, for any disease, if we treat, we find improvement in the investigational parameters as well as general well-being as well as health of the patient. Right?
Yes.
So what new inference your study is driving or contradicting or supporting things? These are well-established facts. So yesterday also I was telling the students, go for the study to contradict the established facts or do something new. If a patient comes to me with weight of 40 kg and patient is, tubercular patient, I treat. Next month it will be 42. So we are expecting that. Right?
Right.
So yeah, study, I don't know whether you discuss the title of the study with your guides or, senior teachers, that what is happening?
Sir, actually in this study we have compared the weight gain in relation to radiological outcomes.
That is what I am asking you. What do you expect to radiological status with ATT? What do you expect? Worsening, stable, or improvement? Improvement. What do you expect for the health status with ATT? Worsening, stable, or improvement?
Improvement.
If both things are going to improve and these are established fact, why compare? That is my point. So we need to do, yesterday only one paper on COVID was good, because that is going to give us insight of different mechanisms. Right? So please try to do something new. आप इसको गूगल में डाल के देखो कि established facts क्या क्या है. आपके पास तो जेब में किताब है यार. हमारे ज़माने में तो नेशनल लाइब्रेरी में लिखना पड़ता था, 1 महीने बाद आता था, फिर हम रेफरेंस फिर भेजते थे. It used to take 6 months to write a paper. Now you can write a paper in 6 hours. So go to the research engine and ask what is the nexus between radiology, weight and BMI. They are going to tell you. AI लगाओगे तो वो पूछेगा कि what a foolish question. Everybody is expecting improvement. Why do you are going to study these facts? Right? तो थोड़ा सा यार young बंदे हो, आपके दिमाग में तो आनी चाहिए new ideas. So those ideas should be encouraged.
Vitull said, you see, from 40 to 42 kg, suppose it doesn't increase. So I mean, where will we stand? That means our treatment is not efficacious?
So that can be attributed to various comorbidities.
Yeah, that's why we have not mentioned that. That means only weight gain, your nexus, you see, doesn't prove anything, you see. What is the established fact?
Dr. Shaminder, 4% of your patients lost weight.
Yes.
What was their X-ray picture? Did it show no improvement or? Isn't it 4% you mentioned, the lost weight?
So actually, the patients who had bilaterally extensive involvement in their X-rays, their weight gain was poorer.
They lost weight also, I think. 4% you mentioned.
Sir, 0.91% of patients lost weight.
Okay. So they were further considered for the resistant tuberculosis?
Yes, sir. They were taken up for the bacteriological status of the patient under CB9.
Okay, thank you.
Okay, thank you.
Thank you, sir. The next presentation will be by Dr. Steffi Girl from GMC Patiala.
Good morning, everyone. I am Dr. Steffi Garg, Junior Resident from the Department of Pulmonary Medicine, GMC Patiala. My topic of presentation is Beyond the Cure, the Hidden Pulmonary Aftermath of Pulmonary Tuberculosis.
तो बेटा बुला दो ना यार आप.
Globally, most assessments concerning TB rarely factor in the long-term pulmonary repercussions following TB treatment. By not accounting for these residual health challenges, we underrepresent the true magnitude of TB's effects on survivors. Pulmonary tuberculosis, even post-successful therapeutic intervention, can lead to enduring health implications. Aim of our study was to investigate the risk factors linked to the development of pulmonary issues following tuberculosis. Our research focused on a series of 100 consecutive pulmonary TB patients, out of which 71 were males and 29 were females. Once they completed their treatment, each participant underwent rigorous spirometric assessments accompanied by a comprehensive clinical and radiological review. In line with the guidelines set by the American Thoracic Society, we meticulously administered the 6-minute walk test to gauge their physical endurance and lung functionality. To obtain an accurate measure of dyspnea experienced by the patients, both the BOG rating scale and the MMRC scales were employed. A notable 62% of the research individuals manifested signs of pulmonary impairment, showcasing the lingering effects post-TB treatment. Obstructive lung disease emerged as the primary form of lung dysfunction, accounting for 35% of the total impairments. A significant 62% of participants exhibited compromised pulmonary function. The mean distance covered by all patients during the 6-minute walk test was 512 plus minus 15 meters. Specifically, patients without impairment covered an average distance of 526 plus minus 16 meters, whereas the patients with impairment covered a mean distance of 489 plus minus 11.47 meters. The intensity of dyspnea, as gauged by the BOG and the MMRC scales, exhibited an increment corresponding with the progressive deterioration of lung function. Factors such as smoking habits, sputum status, the time span from the onset of symptoms to TB diagnosis, and the recurrence of tuberculosis emerged as significant contributors to PIAT development. Out of the 62 subjects with pulmonary impairment after tuberculosis, 46 were smokers and 16 were non-smokers, with a p-value of 0.02, which was statistically significant. Out of the 62 individuals with PIAT, 42 were sputum positive while 20 were sputum negative, with a p-value of 0.004, which is statistically significant. The predominant form of impairment seen was obstructive pattern, which was seen in 35% of the individuals. Restrictive pattern was seen in 15%, mixed pattern was seen in 12%. There was a strong correlation between the severity of X-ray findings and pulmonary impairment. Out of the 62 individuals showing impairment, abnormal X-ray was seen in 54 individuals. Cavitatory lesion on the X-ray was seen in 32 individuals, and predominantly moderate severity of chest X-ray was seen in 32 individuals. Most of the patients in the impairment present group showed dyspnea MMRC grade 2 scaling, and in the BOG scale, majority of the patients showed a slight dyspnea. In patients previously treated for pulmonary tuberculosis, recurrence of tuberculosis, sputum positive status and smoking were found to be statistically significant. Gender of the patient was statistically insignificant. A definitive link was observed between smoking patterns and PIAT occurrence in a study. Patients with microbiologically confirmed TB in the past were more prone to develop PIAT than those who had clinico-radiological TB. Obstructive lung disease took precedence as the primary type of pulmonary dysfunction, comprising 35% of impairments. A significant correlation exists between recurrent TB and PIAT development. So we conclude that since more than 50% of individuals with tuberculosis experience a reduction in their lung function, this underscores the importance of conducting pulmonary function assessments after the conclusion of treatment. The national strategy should give top priority to addressing post-tubercular impairment in individuals receiving treatment through a holistic and integrated approach. It is imperative to include measures for efficient management of these outcomes within the framework of a national plan. Thank you.
Thank you, Dr. Steffi. I must congratulate you on your excellent study, which has real national implications as well as making all the people sitting here aware that only tuberculosis treatment is not important, to risk stratify that post-tubercular impairment, how much it is there, and integrated approach should start with treatment of tuberculosis so that post-impairment tuberculosis problems are decreased. So one line of integrated approach like pulmonary physiotherapy, etc., if you include one slide of that, so that will make this study excellent and complete. So I must congratulate you. This type of study should be done.
Thank you, sir.
Definitely great. Thank you very much.
Thank you.
Thank you, sir.
This is an announcement for the owner of car number PB03AE7178. This car is parked on the wrong side of the road outside. Please get it parked in the parking. Thank you. The next presentation will be by Dr. Vijendra Patle from GMC Chandigarh.
Good morning everyone. I am going to have an oral presentation on the topic of electrocardiographic and echocardiographic abnormalities in chronic alcoholic patients. Introduction. Ethanol is the most commonly abused drug worldwide. WHO states that about 2.5 million of deaths happen annually due to the alcohol abuse. Patients with acute alcohol intoxication often present with a pathological ECG changes. Chronic alcohol intake is known to cause cardiac dysfunction, most notably as a congestive cardiomyopathy. Alcohol damage to the heart is evident if the alcohol consumption exceeds 90 to 100 grams per day. This study was undertaken to study the electrocardiographic and echocardiographic abnormalities in chronic alcoholic patients and to correlate the findings with the duration and severity of alcoholism. Cardiovascular effects of alcohol are directly proportional to the amount of alcohol consumed. Heavy alcohol consumption leads to increased risk of sudden cardiac death and cardiac arrhythmias. Patients who are consuming more than 90 grams of alcohol per day for more than 5 years are at risk for development of asymptomatic alcohol cardiomyopathy, which is clinically expressed as impairment of the left ventricular function, non-symptomatic stage. Hence, this study was planned to assess the systolic and diastolic function of the left ventricle in chronic alcoholics. Now, the effects of alcohol. Alcohol causes myocardial damage via direct toxic effects as under. It causes the uncoupling of the excitation contraction system. It causes reduced calcium sequestration in the sarcoplasmic reticulum. Alcohol causes inhibition of the sarcolemmal adenosine ATPase sodium potassium pump. Reduction in the mitochondrial respiratory ratio. Alcohol causes altered substrate uptake. It increases the interstitial and extracellular protein synthesis. Now the aim is to study the electrocardiographic and echocardiographic abnormalities in chronic alcoholic patient. The objectives of the study is to determine the ECG abnormalities in chronic alcoholic patient, to determine the echo abnormalities in chronic alcoholic patients, and to compare the electrocardiography and echocardiographic abnormalities in chronic alcoholic patients. The study design, it is an observational cross-sectional study, and the study processes all the demographic data, detailed history, clinical examination, ECG and echo was done with other relevant investigation of a collected or pre-designed semi-structured profile. The study population, it considers case group and control group. In case group, there are total 100 patients were enrolled for this study after excluding an inclusion criteria. The inclusion criteria is the chronic alcoholic patients with daily alcohol intake of more than 80 grams per day for more than 5 years and who are more than 21 years of age. And those populations are excluded from the study are the patient with overt cardiac disease, congestive heart failure, hypertension, patients having type 2 diabetes mellitus, patients with immunocompression states like HIV, and females. And the control group, where we have taken 50 patients without history of any alcohol intake in lifetime and without history of any known cardiac disease. The results of this study are a significant number of chronic alcoholics had non-specific ECG changes. There is no significant correlation of the ECG with duration and severity of alcoholism. Left ventricular and systolic diameter and left ventricular and diastolic diameter have a significantly increased in group A than that in group B, and the difference was highly significant. Ejection fraction was significantly decreased in group A than that of group B, and the difference was highly significant. Posterior wall thickness, left ventricular and systolic diameter, left ventricle and diastolic diameter were increased in cases that had consumed alcohol for more than 150 gram, and these were statistically significant. As the duration of alcohol consumption increased, posterior wall thickness, left ventricular and diastolic diameter, interventricular septum thickness, left ventricular and systolic diameter were increased, whereas ejection fraction was decreased. The first figure shows the echo changes in a group A and group B patient, where the left ventricular and systolic diameter and left ventricular and diastolic diameters and shows a significant increase in group A patients, and the ejection fraction is decreased in group A patients. The second figure shows the daily consumption of alcohol variation with the echo changes. It shows that posterior wall thickness, left ventricular and systolic diameters and left ventricular and diastolic diameters are increased, and the ejection fraction is decreased if the alcohol consumption is more than 150 gram per day. This figure shows the echo changes with the duration of alcohol consumption. It shows the posterior wall thickness, left ventricular and systolic diameter and diastolic diameter are increased if the alcohol consumption is more than person consumes alcohol for more than 15 years, and the ejection will decrease, but this is not that much statistically significant. Thank you.
Any sort of all these patients you excluded ischemic heart disease?
Yes, we have excluded all the patients who have any cardiac disease, or we have also excluded females in this study. Sir.
Basically, and the ejection fraction probably you just mentioned, and correct and the other way around you say. And how about the difference was there in the ejection fraction in alcoholics and in non-alcoholics?
Sir, depending in group A patient who consumed alcohol, the ejection fraction is around 53.3 plus minus 4, and then group patient who have never consumed alcohol is 60.16 plus minus 3.75. So difference is nearly about 7. So it is statistically significant also in this type of patients.
So you mentioned about the thickness of the walls, not mentioned about the wall motion of abnormality. Was there any wall motion of abnormality in the echocardiography in your college?
No, sir. We have initially excluded all the patients, this type of patients who have any valvular abnormality.
The reason for the increased thickness of the left ventricle and posterior wall, was it direct effect of alcohol or something else?
So it is on the basis of this, it might be the direct effect of alcohol which is causing the dilatation and causing the systolic and diastolic dysfunction in the alcoholic patients, sir.
Alcohol.
Sorry, sir.
How much alcohol you permit daily?
Sir, in some states, the legal alcohol which is allowed in India is 0.08 gram per deciliter, or in some other states it is only 0.04 gram per deciliter.
It is not by state; it is by medical condition. Medical thing that how much alcohol do you permit health-wise. Gujarat has a total abstinence, Punjab has Patiala pact. So it is.
What message you want to give to this?
So basically, by this study, we want to confirm message that if the alcohol consumption is more than 90 gram for a duration of more than 5 years, it can have a significant effect on the systolic and diastolic dysfunction of the alcohol. Sir.
But how do you define chronic alcoholism? What is the definition of chronic alcoholism? Your study is, go to the title of your study. So it is chronic alcoholic patient. What is the definition or criteria with which you selected the chronic alcoholic patients?
So in our study, we select the patient who consumed alcohol of more than 80 grams per day for a duration of more than 5 years.
So that is not a definition of chronic alcoholic patient. Chronic alcoholic patient may be taking 30 grams per day and still he may be labeled as chronic alcoholic patient. So I am asking you the definition of chronic alcoholic patient. And it has nothing to do with the amount of alcohol. It has to do with social, educational, the lifestyle which is hindered by intake of alcohol. Alcoholic is a very dangerous term, Intake of alcohol is different from chronic alcoholic patients. If you write electrocardiographic and echocardiographic abnormalities in people taking alcohol, then you define it 30 or 90 or 150. Okay?
Yes.
So, read your textbooks about chronic alcoholic patient. You will find ingredients of social work hindrance, educational work hindrance, life being disturbed, and it will not mention the amount of alcohol because that can have 30 grams also and may not have at 150 grams also. To please change your heading to either chronic intake of alcohol.
Yes.
Okay?
Yes, sir.
So alcoholic patient, you need to interview the patient to label him as alcoholic. It is a good study. Mind you, only problem is in title.
Yes.
So chronic intake of alcohol rather than alcoholic patient. आपको पता है पेशेंट ने केस कर दिया था कि the doctor has labeled me chronic alcoholic patient. Intake of alcohol doesn't mean chronic alcoholic patient. And second, I want to suggest you that this study will become more productive if you compare it with, like we are from Punjab, genetically different races or other part of India or with Western population. In Western population, similar study, the wall thickness was less, in our it was more. Because Indian, Asians are genetically different. We are having disease at a younger age, hypertension at younger age, heart rate is more. So that may predispose to all these abnormalities as compared to other populations. Right?
Yes, sir.
So it is a good study, productive study, useful study. Only thing is, change the title. Or you have to give the criteria for selecting the patients as chronic alcoholic patients. Good study. Thank you.
Thank you, sir.
Thank you, sir. Our next oral presentation will be by Dr. Anurag Khara from GMC at Chandigarh.
Good morning everyone. Today I am going to present an oral presentation on procalcitonin guided antibiotic therapy in community acquired pneumonia. The introduction: community acquired pneumonia. It is the most common cause of hospitalization and the related mortality and morbidity associated with it is among the highest. There is a significant overlap between the bacterial and the non-bacterial causes. Antibiotic therapy, I would like to emphasize on one point that more than 85% of the people are being given excessive antibiotics which are not even required. So I would like to discuss in this oral presentation about optimal duration, as the optimal duration has implication in not only reducing the antibiotic resistance, it would also have significant impact over the financial conditions over the patient. For this, we use biomarkers in the biomarkers for the antibiotic therapy. CRP is one of the unspecific biomarker which is elevated in both bacterial as well as non-bacterial causes. Procalcitonin is secreted by the parafollicular cells of thyroid and the neuroendocrine cells of lung and intestine. It is secreted in response to a pro-inflammatory stimulus, and the normal value is less than 0.1 microgram per liter. It has an additional benefit in terms of prognostication and alternative diagnostic clue which is given to a physician in case the value is lower, so a physician might think towards another cause. And the latest rule has been discussed in the surviving sepsis guideline, where serial measurements of procalcitonin has been used to guide the duration of the antibiotic. The aim of my study was to use procalcitonin as a guide of duration of antibiotic therapy, whereas the secondary aim was to correlate procalcitonin with the curve 65 score, clinical response, complications of community-acquired pneumonia, rate of recurrence and readmission. It was a single-centered, hospital-based, randomized, stratified, placebo-controlled, intervention-based and single-minded study which was conducted by the Department of General Medicine in collaboration with Department of Biochemistry in GMCH Sector 32, Chandigarh. The inclusion criteria, it included patients above 18 years of age who were diagnosed as community-acquired pneumonia and gave consent for the study, whereas the exclusion criteria include the immunocompromised individual, patients having in conditions which can falsely elevate procalcitonin, active pulmonary tuberculosis and patients with complicated pneumonia. Minimum of 40 cases were selected, about which 20 were in the control group and 20 were in intervention group. Procalcitonin level were done in both the groups at day 0, 3 and day 5, where the treating physician was blinded about the procalcitonin values in the control group, and procalcitonin values less than 0.2 microgram per liter was an indirect indication where the antibiotic therapy was stopped. The power was assumed to be 90% and level of significance 5%. The qualitative outcome was measured during the mean and standard deviation. The main outcome, which was the days of the antibiotic therapy, was compared using the Mann-Whitney test, and data analysis was done using the SPS software. These are the outcome. As we can see, the highlighted part, the antibiotics on the day 5, in the intervention group, only the 8 people were being given as the antibiotics, where one was upgraded, where 5 people had already been stopped, which was a significant. The days of antibiotic therapy, the mean days of antibiotic therapy in the intervention group was 6.5 plus 3, and whereas in the control group it was 8.6 plus minus 3, which was significant, and duration of hospital stay was also a significant difference. In these bar charts we can see the comparison between the antibiotics given to the control as well as the intervention group on day 3. Day 3 in control group, almost 100% people were still receiving antibiotics, whereas in the intervention group 30% people have already stopped antibiotics. By day 5, among that 70% who were receiving antibiotics, 57% were still receiving antibiotics, one who had to be upgraded as per the clinician decision, whereas another 35% also stopped antibiotics. In the third bar chart, we can see compare the mean duration of antibiotics, which is 6.4 and 8.7 among the two groups, and it is significant. To discuss, there was no significant difference among both the groups on the basis of age, gender and comorbidities. There was no correlation of the procalcitonin values with the curve 65, but there was a significant difference among the two groups on the basis of the days of antibiotic therapy. There was no significant difference in the saturation, heart rate, respiratory rate, temperatures, systolic BP. That means every clinical parameters was not having any significant difference on all the days, and there was no difference among the complication outcome and the readmission rates. The limitation of my study was it was a small sample size. At times the clinical parameters and the decision of treating physician played a role in terms of upgrading antibiotic and stopping of the antibiotics, and it was conducted during the COVID pandemic, so only RT-PCR negative patients were enrolled. It was a single blinded study and was prone to some bias. With conclusion, I would like to tell that with my study there was a significant impact among the reducing the duration of antibiotics and hospital stay, which do have significant impact in the financial implication and in terms of clinical decision, like it might play in future reducing the antibiotic resistance in the population. And thank you. I would like to thank my guides, Dr. Mahek Trayan and Dr. Preetam Singh, for this. Thank you.
Thank you very much. It's a good study, another marker for information. And like I said, the commonest we are using CRP. I think unfortunately, see, this in this part of the, or in India, otherwise not in the Western certified culture, the antibiotics are underused and rather overused or rather misused.
Yes, sir.
And we find it very difficult to use procalcitonin as a marker for all those patients when we are already underusing or overusing or misusing antibiotics. Probably in those cases, even general factors or practical purposes, maybe so right in a sort of a institute or maybe sort of where you are working, in general population or otherwise you see in practical problems, I think it is difficult to do procalcitonin to just judge the inflammation in a patient who is taking antibiotics. Suppose after 5 days the procalcitonin level doesn't decrease. Do you suggest to change the antibiotic or you want to continue the antibiotics?
Yes, sir. If the procalcitonin level was not decreasing, the antibiotic was being continued in the intervention group, and the upgradation of antibiotic was the decision was taken by the physician in terms of the clinical condition of the patient, whether the respiratory distress was worsening, oxygen requirement was worsening, persistent high grade fever, the worsening of lab parameters. All these came into the play when the upgradation of antibiotics were required. Whereas in the control group, the physician was blinded about the procalcitonin values, so it was just a clinical decision whether to stop antibiotics if the patient is AFib, if the counts have decreased, if the patient oxygen requirement has decreased. So to stop or upgrade antibiotic in control group, it was a clinicians and the physical condition of the patient that guided us to give the antibiotic therapy. Whereas in the intervention group, it was entirely based on the procalcitonin. At times, the patient might have been on the oxygen. We were still decreasing the oxygen, but since the procalcitonin value started decreasing, so that it was a point where the antibiotic was stopped at 0.2. It was the cutoff.
What is the cost of this procalcitonin to the patient? And your study advocate doing procalcitonin one at the beginning and then at what time?
Sir, in our institute, for the study purpose, the procalcitonin for all the patients, it was done free. But otherwise, if we get a regular procalcitonin done for a normal patient in GMCS 32, it does not cost more than 100 rupees for that patient. Also, in this study, we did procalcitonin values at day 0, which was before the start of antibiotics, at day 3 and at day 5. And also, we every 1 to 3 months we had seminars regarding the procalcitonin, in which we discussed about whether if there are any new guidelines or there are any other new implications, if the method has been changed from the biochemistry, that the cutoff values are being revised or not.
What is the WHO criteria for diagnosis of community-acquired pneumonia?
So, for the community-acquired pneumonia, we have used this criteria as new onset infiltrates in the chest radiograph plus one of the following, in which there are 3 parameters. One is the cough, shortness of breath and associated with expectoration. Another is fever, which is core body temperature more than 38 degrees Celsius, along with the abnormal clinical findings like bronchial breath sound. And the third was the leukocyte count less than 4 or more than 10,000 per millimeter cube.
Excellent. I must appreciate your knowledge about, because that is worthwhile of studying if you know the WHO criteria. And by prescribing procalcitonin, you are adding to the criteria which is not advocating procalcitonin levels.
Yes.
Right? And why it should be not required in Indian setup?
So, as far as this study is concerned, this is less studied in Asian population and much more studied in the Western countries like ProReal, ProHosp. Such trials are already been there. In Indian scenarios, like one of the difficulty which I would like to mention in our hospital, at times, like this was a part of studies when we used to get the result within a day. First of all, at times it is costly. One thing, when we send procalcitonin, by the time the value of procalcitonin is available in our government setup, the clinical condition of the patient might have already been changed. So that is a difficulty, and one I would like to mention that in Indian Asian population we might face because of lack of resources.
So that you should mention in this study.
Sir, but for the study we got it on the same day.
No.
Yes,
You must write limitations or in Indian setup because there are 2 things. One is academic part. Other is that academic part should be reflecting in the social as well as clinical utility by the patients.
Yes, sir.
So India is a low income, middle to low income group country, and most of the patients who are going to you are, from the deprived section of the society, poor patients. So calcitonin maybe, it is free or less costly in your, but your study is going to reflect to formulate the guidelines or to motivate other consultants to use pro-calcitonin level for rational use of antibiotics.
Yes.
But rational use of antibiotics should not depend upon pro-calcitonin levels. It should depend upon your intelligence and the guidelines.
Yes, sir.
If they mention that community-acquired pneumonia should be treated with level 1 antibiotics, then you should escalate to level 2 and then you should escalate to level 3. So I have seen patients, straightway consultants are going in imipenems or tazobactam and not using the ampicillin or gentamicin or depending upon the the culture sensitivity or the antibiotic level of that institute. Right?
Yes, sir.
So you should differentiate between an academic study and the study which is going to have implications on clinical and the patient outcome.
Yes, sir.
And one slide you add, this study will become a worthwhile study as an academic study.
Yes, sir.
Right? So good study. So last 3 studies are real good studies, and I should encourage students to go in for such studies rather than studying the already established facts.
Yes.
Great. Thank you very much.
Thank you, sir.
With this, we are done for the oral presentations of the day, and now I would like to invite our first speaker for the day, Dr. Parvinder Singh, HOD, Department of Endocrinology from DMC Ludhiana, on his talk on the topic Gestational Diabetes, Diagnosis and Management.
So, very good morning to all of you, and I must congratulate Dr. Professor Vitull for arranging a meeting and completing almost 10 years, a decade of MAPICON. And this is lovely, auditorium, lovely place to be here. And I must say, this is a boon for the Bathinda as such. Lovely place. I liked it so much that I was so impressed by the building, by the structure, and this auditorium. Great. It's not there even in Ludhiana. So, very nice. So, I will be talking about GDM. That's a, quite common. We discuss it so many times. And I think I will be clearing some matters on GDM in my own style and my own manners. So, what is GDM? So let's talk. What is GDM? GDM is impaired glucose tolerance. It is not diabetes. It's a impaired glucose tolerance. So this is should be very clear, because we always think GDM is synonymous with diabetes. It is not so. In fact, it is a impaired glucose tolerance which is occurring in pregnancy. So if blood sugar is more than 126 fasting and more than 200 in pregnancy, we call it a diabetes. So we don't call it GDM. So this should be very clear. Number one, GDM is impaired glucose tolerance characterized by an increased risk of large for gestational age, birth weight, and neonatal and pregnancy complications, and an increased risk of long-term maternal type 2 diabetes and abnormal glucose metabolism in the offspring. So what it anyway says is that impaired glucose in pregnancy can lead on to changes in the imprinting in the offspring. He will get diabetes with the in later age, as well as there are complications, perinatal complication like microsomia and fetal distress and all those things, which I will be talking later on. Now, these associations were with maternal oral glucose tolerance test. Results are continuous. There is no cutoff value. The lower value is better. If you go to the higher value, even in the impaired glucose tolerance stage, even in the higher ranges, there are chances. So there is no cutoff value that at this value there is no complication, at this value there will be complication. This is a continuous type of thing. Higher the values of glucose, higher is the complication rate. This is just to, although this is not part of GDM, but just to say hyperglycemia in pregnancy, because many times you are not aware what to label this patient. So the recent classification is you divide into two parts. One is pre-gestational diabetes. That patient is non-diabetic. She may be type 1, type 2 or other types of diabetes. That is pre-gestational diabetes. Then comes the hyperglycemia in pregnancy. Now, hyperglycemia in pregnancy means blood sugar high in pregnancy. So, it can be, diabetes in pregnancy. When the blood sugar crosses the limit of, diabetic, it comes into diabetic range. That means more than 126, fasting more than 200, plus symptoms of diabetes. This is a diabetes. So, diabetes in pregnancy, or WHO used to call it previously as over diabetes. And another is GDM, that's gestational diabetes. Now, gestational diabetes, when glucose tolerance test shows that blood glucose are raised in the impaired glucose tolerance range. So, it's further subclassified now, early GDM and late GDM. Late GDM is occurring at 24 weeks plus minus, right? That's the time when there is increased insulin resistance. And early GDMS, there are studies which show that glucose tolerance test done in the first trimester, it also raises the risk of maternal as well as fetal complications. Although there's no studies till date for the early GDM, but this term, the fact is that higher the glucose values in the first trimester, more the chances of fetal and maternal complications. So what we are talking today is standard GDM. That's a standard GDM which occurs in the close to end of the second and start of the third trimester. So what happens to glucose metabolism in pregnancy? Now, early pregnancy, estradiol and prolactin stimulates beta cells. So there is a proliferation of the beta cells. Insulin sensitivity, same, but peripheral glucose utilization, there is a fall in the blood glucose levels because of insulin going high, there is more of insulin present. But in late pregnancy, what happens in late pregnancy? Fetoplacental unit extract glucose and amino acid. Fat is used mainly for fuel metabolism. Insulin sensitivity decreases progressively up to 50 to 80%. So late pregnancy is characterized by insulin resistance, right? Early pregnancy is insulin sensitivity. Late pregnancy is insulin resistant state. And this insulin resistant comes from the fetal placental unit hormones as well as maternal hormones. Variety of hormones are implicated in that. Human placental lactogen, placental growth hormone variant, cortisol, prolactin, and of course estradiol and progesterone. So these are the hormones responsible. This is the diagram I want to focus. Now, if you see the dotted line, what it says, normal insulin, pattern, what happens? In pregnant female, insulin resistance remains almost, or it becomes lower in the first trimester of pregnancy. Up to 20 weeks, it is almost the same. There is a dip in the insulin resistance at 12 weeks, at 3 months. Thereafter, there is a rise in insulin resistance. You can see dotted line over there, which tells us that there is insulin resistance, and it increases to 2 to 3 times normal. By the time we come to 35, 34 weeks, 36 weeks, it is 2 to 3 times of the normal. So thereafter stabilizes and after delivery it falls down abruptly. So that's what happens. So just think of it that if one has a beta cell dysfunction, this 200 or 300 times production rate will not be there. It can't counter the insulin resistance. So one will develop the impaired glucose tolerance. So this is a relative insulin deficiency which occurs in patients of GDM. So initial phase is that is a good insulin secretion. This is normal pregnancy, and later on there is insulin resistance. If beta cells are quite robust, or they are secreting, they have enough numbers and secretory functions normal, they will overcome this resistance and glucose profile will be normal. But if they have some dysfunction, then what happens is we have impaired glucose tolerance. We call it a GDM. So complication of hyperglycemia during pregnancy, what happens to mother, what happens to child, and the perinatal complications of child in the newborn is macrosomia, hyperbilirubinemia, in offspring, neonatal hypoglycemia. For mother, it is a eclampsia, cesarean section, risk of stillbirth, shoulder dystocia, and preterm delivery. And later on in life, child may have obesity, diabetes, delayed motor development, and for the mother, there is type 2 diabetes and premenopausal breast cancer. So these are the long-term complications. So when you are treating a mother, you are treating two individuals at the same time, right? The offspring will get the benefit if you treat GDM appropriately in the mother. So this is one of the Patterson hypothesis. What it says is that, see, fetus have no mechanism to stop the intake of energy. Whatever comes from the placenta, it has to take. So it can't refuse. There's no refusal. So if you give more glucose or more free fatty acid to the fetus, it will take them. There will be increased insulin from the fetal, pancreas, more of the growth, and there will be macrosomia. So if you can decrease the glucose part, decrease the even fatty acid part, less energy will be going to the fetus and growth will be normal. And similar thing will happen if you give less calories to the mother, then we have small for gestational age. So in starvation you have small for gestational age, and diabetes because nutrient supply is more to the fetus and he can't refuse. So he or she can't refuse. So more of intake and more of growth and more of macrosomia. So this was the Patterson hypothesis. So what the macrosomia does is it leads to iatrogenic preterm delivery and respiratory distress syndrome, and because of a decreased lung surfactant and shoulder dystocia, brachial plexus injury, then hypoxia, stillbirth, and polycythemia, hyperbilirubinemia, and irreversible sometimes cardiomyopathy. All these things can occur with macrosomia. Now, how to diagnose GDM? We have talked about what is GDM, it is a glucose intolerance, what are its complications, why it occurs, we know. And we know from this point that those females who have some abnormal beta cell function or already having insulin resistance, they will be theoretically more prone to get GDM. Like obese person with diabetes history, person with previous GDM history, they are more prone, right? So how to diagnose GDM? There are risk factors for GDM like history of microsomia, previous pregnancy GDM, ethnicity, polycystic ovarian syndrome, essential hypertension, history of spontaneous abortion, unexplained stillbirth, family history of diabetes, obesity, age group more than older than 25, persistent glucosuria, although this is it's a questionable kind of thing. But at least 50% of patients may not have that classical risk factors for GDM. So ADA recommends as such that we should have a selective screening, but in the Indian context, it should be the universal kind of thing. So all female should be investigated for GDM in the Indian context, because as ethnicity, as race, we are more prone to get it. So GDM. So these are the criteria for GDM. You can see there are so many modifications, so many recommendations, starting with O'Sullivan, who started it. In fact, O'Sullivan started it to predict the diabetes in the mother, not for other things, not for perinatal mortality. He has done this for the predictive value of glucose tolerance done in the pregnancy for the future diabetes in the mother. Then you have NDDG, then CNC, EST criteria, ADIP criteria, WHO, IADPS criteria, then we have DIPSI criteria. So this is the criteria which we are talking. I'm just pointing out 3: WHO criteria and IADP SE criteria and DIPSI criteria. DIPSI is a homegrown kind of thing, and they have Dr. Shreya has done a lot of work on it, and DIPSI criteria is currently, or WHO criteria currently we are following. So it's a WHO criteria says fasting OGTT with 75 grams of glucose. If 2 hours glucose more than 140, it's GDM. DIPSI says any time of the day. Alright? Nothing that patient should be fasting. Any time of the day, you give 75 grams of glucose and do blood sugar at 2 hours. If it is more than 140, it becomes GDM. IADP SC criteria is with 75 in the fasting state, more than 95 as fasting, more than 180 at 1 hour, more than 153 at 2 hours. Any of the one value, if it's significant, it called for GDM. So this is the criteria. So question comes, why in India we have separate guidelines for screening? The point is clear, as I already discussed, that Indian females are 11-fold, have 11-fold increased risk of GDM as compared to the Caucasians. Prevalence is 16.55%, and anything more than 10% requires a universal kind of thing, right? Single blood glucose measurement after glucose tolerance test, right? This is economical, feasible, can be done in one visit, and there is no need of fasting. That's the beauty of the DIPSI criteria. So it is adopted, and we are currently doing it, but many centers do take WHO criteria. You take any criteria, but the point is, if it at 2 hours it is more than 140, it's a GDM. What are the management issues? When you have diagnosed GDM, that mother has values which are 160 or 170, we have diagnosed. What are the management issues? Number 1 is patient education. Number 2 is medical nutrition therapy, then pharmacological therapy. We have glycemic monitoring, how do you do it, and fetal monitoring, and what should be the plan on delivery. One by one. Glycemic targets, target recommended by the 5th International Workshop. Fasting glucose should be less than 95. 1 hour postprandial should be less than 140, and 2 hour postprandial should be less than 120. That's the goal to achieve when you treat the patient. Now, medical nutrition therapy, we have to achieve the normal glycemia, and this is the first thing we do. And remember it, that any dietary therapy will show its results within 1 or 2 weeks. That's the 2 weeks are required for its effect. So pregnancy is a short period. You are diagnosed at 24, 25, 6 weeks, and there's a little time. So 2 weeks are good enough. Don't wait for the response beyond 2 weeks. Start the therapy, pharmacotherapy. So what is medical nutrition therapy? Right, is the food plan should provide adequate calories intake to provide fetal and neonatal and maternal health, and achieve glycemic control goals and promote weight gain. The recommended dietary reference intake for all pregnant people is a minimum of 175 grams of carbohydrate, or 35% of total energy intake a minimum of 71 grams of protein and 28 grams of fiber. The nutrition plan should emphasize monounsaturated and polyunsaturated fats while limiting the use of saturated fat and avoiding the trans fats. Oh, there was confusion whether it should be 35% or 55% or 60%. There was a confusion. But 47% of the total energy take should come from carbohydrate. That's the kind of middle path. It does not, increases the chance of large for gestational age and does not increase the chances of small for gestational age. So 47% of total energy intake should come from the carbohydrates. Liberalizing higher quality nutrient dense carbohydrates result in controlled fasting and postprandial glucose, lower free fatty acid, improved insulin action and vascular benefit, and may reduce excess infant adiposity. So if you decrease carbohydrate intake, then probably you will be supplementing it with the fat. Fat is also bad, right? So if you increase carbohydrate too much, then you will be increasing the load, glycemic load, and thereby more of glucose and blood sugar will go high. So it's the compromise is 47% of the carbohydrate component should come from carbohydrates. Now, fasting urine ketone testing may be useful to identify those who are severely restricting carbohydrate to control blood glucose. Remember, ketone bodies in pregnancy, they are not good. In fact, they inhibit the trophoblast activity. Trophoblastic transfer of glucose is decreased and trophoblast may die, and there may be, abruptio placenta also at one point of time, because trophoblast growth is inhibited by the ketones. So simple carbohydrate will result in high post-meal excursion, so avoid the simple carbohydrates, should take complex carbohydrates. Then comes the physical activity and weight gain. A systemic review demonstrated improvement in glucose control and reduction in need to start insulin or insulin dose requirement with an exercise intervention. Many exercise interventions have been tried, aerobic, anaerobic, also strength training, yogic exercises, all these things have been tried, and there's no single study that compares one exercise with the other, but recommendation is to have a exercise component to GDM. What about weight gain? Gestational weight gain of 5 to 9 kg in women with class 1 obesity and less than 5 kg in class 2 obesity, and no weight gain in class 3 obesity. Minimized combined risk for large for gestational age, small for gestational age, and cesarean section. This is a recommendation from Institute of Medicine. Now, gestational weight gain less than recommendation is better in GDM, and it is protective for LGA and did not increase SCA. So, majority of the patients who have GDM, they fall into the category of obesity. Of course, there is no data for the Indian BMI. This is the Western data, but certainly weight gain should not be that high. More weight gain means more of insulin resistance. When to consider pharmacotherapy? So you 90% of the patient, they will be happy with or they will be controlled with nutrition therapy and with exercise. Remaining 10% will require pharmacotherapy. So immediate insulin therapy is required in those patients who have overt diabetes or they have pre-existing diabetes. After a trial of lifestyle modification for 1 to 2 weeks, if blood glucose target are not achieved or there is evidence of macrosomia on ultrasound, one should start the pharmacotherapy. What for pharmacotherapy? Treatment of GDM with lifestyle and insulin have been demonstrated to improve potential perinatal outcome in 2 of the large randomized studies. All right, and insulin is the first line agent recommended for the treatment of GDM, while individual RCTs support the support the limited efficacy of metformin and glyburide. So, in fact, insulin is the only treatment should be given. That's the number one choice for the many of the organizations. Furthermore, in separate randomized clinical trials, glyburide and metformin failed to provide adequate glycemic outcomes in 23 and 28% of participants with GDM respectively. So this is what is in nutshell I have brought. And metformin, there was a even GDM treatment guidelines from the Ministry of Health. They say that metformin is there in that segment. But metformin is it is notorious in the sense that it gives, although it gives a small for gestation age babies, but later on they become obese and fat also, and they develop type 2 diabetes. So this was a study which we talked about metformin in gestational diabetes, the offspring follow-up study, that's a MIG TOFU study. This is the analysis of 7 to 9 year old offspring. The 9-year-old offspring exposed to metformin for the treatment of GDM in the Auckland cohort were heavier and higher waist to height ratio and waist circumference than those exposed to insulin. So this difference was not found in the Adelaide cohort. So this was a MIG study was done in the Australia and New Zealand. So one cohort showed that those patients who are exposed to metformin after 9 years of their birth, they showed adiposity. They were obese, having waist circumference which was more than those who are treated with the insulin. Now, in two recent randomized controlled trials of metformin used in pregnancy for polycystic ovarian syndrome, follow-up of 4 years old offspring demonstrated higher BMI and increased obesity in the offspring exposed to metformin. So there is a imprinting in the womb that those who are exposed to metformin, they become obese later on in life. A follow-up study at 5 to 10 years showed that the offspring had higher BMI, weight to height ratio, waist circumferences, and a borderline increase in fat mass. So recent meta-analysis concluded that metformin exposure resulted in smaller neonates with an acceleration of postnatal growth, resulting in higher BMI in childhood. There was another point. The patient who is polycystic ovarian disease becomes pregnant, she is on metformin, whether she should continue throughout. The randomized double-blind controlled trials comparing metformin with other therapies for ovulation induction in individuals with PCOD have not demonstrated benefit in preventing spontaneous abortion or GDM, and there is no evidence-based need to continue metformin in these circumstances. So patients who are on metformin, polycystic ovarian syndrome, becomes pregnant, you should stop after say about whenever, in the first trimester you can stop. There is no increased chances. There was one study which says that if you continue further, you can decrease the spontaneous abortion, but it is not proven now. So you can stop metformin. What was the sulfonylurea? Sulfonylurea in the meta-analysis, they don't provide anything, so should not be given. Then comes insulin. The physiology of pregnancy necessitates frequent titration of insulin. So you should give insulin. That's the only thing which many of the organization has said that insulin is the proper therapy. Now, when to initiate insulin? That's the American College of OB. Insulin is often added to nutrition therapy when fasting blood glucose are persistently more than 95, 1 hour more than 140, and 2 hour more than 120. And IDFE says little bit lower, fasting plasma glucose of more than 90, remaining rest is the same. And DIPSI is more stringent, and it says 90, and PPG more 20 after 2 weeks of medical nutrition therapy. Now this is the recommendation by various organizations. ADA recommends a first line insulin, second line metformin and glyburide in those patients. Glyburide is glibenclamide. in those patients who cannot safely take insulin. So American College of OG of scanning, it's insulin and metformin for women who decline, cannot safely take insulin or cannot afford insulin. That's the thing. And what about NICE? They say metformin only if mild fasting hyperglycemia and no complication, and alternative first line insulin, and diabetes Canada is insulin, and similarly DEPSI is insulin. Now, how to give insulin? Of course, this is a specialist kind of job. It has to be done by a trained person who is dealing with GDM, or some physician who is routinely dealing with GDM, or endocrinologist, whatever. So, which insulin? That's the point. Any insulin can be given. No insulin, because insulin does not cross the placental barrier. So it does not cross placenta, so any insulin can be given. The only thing is we should give insulin those insulin who have randomized controlled trials. So there are insulin in the market which are there, can be used. There's nothing of that sort that one cannot give this insulin or that insulin should be given because it is. So only thing is what we say is that insulin which have studies with it, probably that's better. But there is nothing that this particular insulin is bad for pregnancy, nothing of that sort. So you can use Aspart, Lispro, regular insulin, NP insulin, Datamar insulin, Degludec, even Glargine also. Although there is no study, that's the problem. Glargine can be given. There's one study which says Glargine can be safely given. So any insulin can be given. Why I'm saying it? Because insulin does not cross the placental barrier. It is not affecting the fetus, so it can be given. So how to assess glucose in pregnant ladies? What about the HbA1c? Role of HbA1c? What is the role of fructosamine? What is SMBG? What is the best thing? The best thing is here SMBG. Why I'm saying so? Because of the HbA1c is because of rapid cell turnover in female, RBC turnover, HB will be lighter, it will be low as compared to the non-pregnant female. So target here will be as less than 6%. If you want to see the response, it should be less than 6%, and it should be done not 3 monthly, it can be done every month. Because HbA1c, if you see, it indicates almost 40 to 50% of the contribution in the HbA1c result is coming from the last 1 month. And the first month, that is the of the 3 months, last month has the largest contribution, middle month has 30% contribution, only 10 to 20% contribution comes from the first month. So one can do one HbA1c every monthly to assess the response to the therapy. Fructosamine is the one thing which assesses the control over the 2 weeks, but it's not validated that much. So one can use it, but validation is not there. SMBG, how frequent one can do, one should do. SMBG, ADA recommends more than 3 times a daily. Those who are insulin probably require more than 3 point also, sometimes 7 point also. And disadvantage, of course, frequent pricks. And currently what we are doing is we are applying CGMS devices to the pregnant ladies and sensors also. So we come to know, although that's not the ultimate, one has to check blood sugar with glucometer also. But one of the methods where the pricks are less and you assess the glucose by a reader also. So CGM devices have come in handy at this point of time. So what is the optimal time for postprandial glucose measurement rated according to clinical outcomes? It's not 2 hours. Surprisingly, it is 1 hour. So based on the practical experience and dietary recommendation, authors prefer a 60-minute interval as patient can calculate this more easily and can have more freedom to eat the recommended number of snacks. And in one of the studies, which I am not quoted here because of the time constraints, 1 hour in glucose is more predictive of perinatal complications and mortality as well as morbidity. Now, outcome of GDM treatment, what happens? A recent Cochrane review including 8 randomized controlled trials in GDM treated with diet and insulin reduced composite outcome of perinatal morbidity by good 68% compared to routine antenatal care. Treatment was also associated with reduction in microsomia, LGA, that is large for gestational age, and preeclampsia, but increase in the intensive care need. That's the only flaw. Now, fetal monitoring from 26 weeks, every 2 weeks we have to see the liquid volume, abdominal circumference to know whether the patient is developing macrosomia. And intrapartum attention to labor pattern, as phallopelvic disproportion may indicate fetal macrosomia. If steroids or beta agonists are given for the lung maturity, then we have to increase the insulin doses. Skip morning insulin on the day of induction of labor. Usually there is no need of insulin while labor. Early blood glucose monitoring during active labor with insulin drip if necessary. Notify pediatric person a patient has poorly controlled blood sugar, antepartum or intrapartum. What about the postpartum? For all GDM patients, perform 75 grams 2 hours GTT to know the to rule out the pre-gestational diabetes. And most common recommendation is for primary care physician to repeat it. And if normal, 2 hour OGTT every 3 years should be done. Metformin and glabelloid are secreted in breast milk, are therefore contraindicated. Breastfeeding plus insulin therapy may lead to severe hypoglycemia when the patient is breastfeeding at that time. Preventive measures are reduce basal insulin and give carbohydrate intake prior to breastfeeding. For babies, start early breastfeeding, commencing at 1 hour, and check blood sugars. Anything less than 44 is considered as hypoglycemia in the neonate and treat accordingly. Who will progress to diabetes? GDM patient, who will progress? Those who have a large waist circumference or BMI, autoantibodies, diabetes at earlier gestational age, gestational requirement of insulin quite high, and higher FBG and higher blood glucose on OGTT, neonatal hypoglycemia, recurrent GDM, all are candidate, and who will progress to diabetes later on. So in conclusion, this is a graphical abstract of the conclusion that there are preconception risk factors like obesity, ethnicity, nutrition, physical activity or genetic predisposition which is there, which predisposes to GDM. And in pregnancy what happens, there is increased glucose, triglyceride, free fatty acid, gestational weight gain further accentuate these things, and there is increased maternal insulin resistance mediated by epigenetics, placental hormones and cellular inflammation. What are the short-term maternal and neonatal complication is preeclampsia and obstetric interventions more often required in female. And for the neonate fetus, it's a CI stillbirth, congenital malformation larger for gestational age, preterm birth, birth trauma, hypoglycemia, hyperbilirubinemia and respiratory distress syndrome. And long-term maternal and offspring outcomes are there is dysglycemia, type 2 diabetes, cardiovascular disease as well as obesity in mother as well as the offspring. So with that, I finished my lecture here. Thank you for the patient hearing. Thank you.
Thank you, Dr. Pravinder, for an excellent talk. And I would like to extend your talk for 5-6 minutes and to apprise our audience about the utility of pre-pregnancy counseling for prevention of diabetes. Since we have time, we want your intellect and your orator skills to apprise our audience about the utility of pre-pregnancy counseling in prevention of gestational diabetes.
Just to add to that, you see, this use of metformin in pregnancy, as you mentioned, this Auckland study and then this Australian study, I think this is something new to me, at least I never knew about it, you see. And thank you for that. Yeah, but the implication of that, I think in the future, probably all those ladies, so in the reproductive phase, I think probably we should avoid using metformin in those patients, those ladies.
See, so first, Dr. Vitull's point that we should pre-pregnancy counseling of the patients, right? It's a deficient at this point of time, right? And probably what happens after marriage, there is a, partying and all those things. Every female tend to gain weight unless one is very conscious about the weight. So weight gain is a major determinant. Increasing in BMI is a major determinant of, dysglycemia in the pregnancy. And we should, in fact, those patients who have a family history, those patients who are obese, if they are coming to, obstetrics for their consultation, or for that matter, if they are coming to you when they are married, but they are coming with their, father-in-law, mother-in-law, and you can comment upon them that please reduce your weight to have less chances of GDM during pregnancy. That's one of the things we can do as a social cause. And the remaining things about the, as Dr. Saab saying, is metformin, this is news to him. This study was, many times when this study came, mixed study when came, then metformin, many of us started writing metformin. But only then the follow-up data came that we came to know that probably it's not as good as we used to think. Still, presently also, NICE says that metformin can be given when fasting hyperglycemia is there, postprandial is good. Alright? So, NICE says that one can give. And even, Health Ministry, GDM guidelines have metformin still there. Although the major others, ADA and other things, they have taken off metformin as first-line therapy. And for them, it's a lifestyle modification plus insulin. That's the only thing.
So I think I must congratulate you, because now GDM is being considered to be the root cause of NCDs in the population. And we are providing, suboptimal care for GDM. So, I think for preventive part, that after a female is, diagnosed as GDM, the postpartum care is also important for prevention of diabetes and other NCDs in those ladies as well as in the offsprings. So thank you very much, Dr. Parminder. If you want to touch upon some points.
Just to add that probably our diet is, almost 70 to 70% of calories come from the carbohydrates. Probably that restriction has to be done. It has to be close to 47%, or you put it 50% if you want to remember from that account. So carbohydrate limitation will decrease the spike of postprandial glucose. And just don't have this idea that what I am talking is ultimate. Probably we are dealing with heterogeneous population, right? When we talk about GDM, we are focusing on postprandial. You see, all things are postprandial glucose, postprandial glucose. But there are many patients in whom the fasting will be close to 100 or 110 and postprandial is 130 only. So this indicates that there is a heterogeneous population. What I have talked is one single kind of population which is having the postprandial hyperglycemia. So don't forget that it's a heterogeneous population, and some patient may be having predominant insulin resistance, but later on in, historically GDM is an insulin secretory deficiency. It is a insulin secretory deficiency, because in every pregnancy there is 200 to 400 increase in the insulin resistance in every pregnancy. Only those who can't produce enough of insulin from beta cell, they develop GDM. So this is just in the society also we have impaired glucose tolerance as such. So impaired glucose tolerance, milder degree, impaired glucose tolerance, and pregnancy stress manifest it as GTM. So take it like that, and take it as it's a heterogeneous. Don't. My only problem with the DIPSI criteria always remain that it is a targeting on the postprandial. It's not looking at the. I have a favorable response to IAP criteria which has a fasting as component. So.
Any other question from the audience, please? So thank you, Dr. Prananda.
Thank you, Dr. Vitull, and for extending the invitation, and really nice to come here, and feeling very good. The place and the other things are so good. Thank you so much.
So it adds to the glamour of MAPICON when with your presence. So you are one of the first endocrinologists of Punjab, and we are really honored to have you with us. Thank you very much. Now I invite Dr. Arun Thapar, famous physician from Ludhiana, and is son of very famous Dr. Thapar. He was our anatomy teacher, excellent teacher, and nobody knew anatomy like him. So it is always great pleasure to host Dr. Arun Thapar, because we have double bond. He is physician and a friend to me, and son of our most important, humble teacher, Dr. Thapar. So he will be talking about sleep disorders. Thank you very much.
Thank you, Professor Vitull, for inviting me. It's an honor to be here. No words to thank you for giving such good words for my father. He was an awesome, excellent father and a teacher from all respects of life. God bless him. Thank you, sir. Let's start the talk. So, sleep disorders. I'll be touching the subtypes, the causes, and the management. I'd like to share a painting by a Russian painter. It's a world-class painting by Vitull. A phrase for sleep is a good laugh and a long sleep are the best cures in doctor's life. What's the definition? Sleep is a reversible behavior, a state of perceptual disengagement and unresponsiveness to one's environment. We can also define sleep as a period of rest for the body and the mind, during which volition and consciousness are in partial or complete abeyance and body functions are partially suspended. Sleep is important to a number of brain functions, including how nerve cells communicate with each other. Humans normally sleep in a supine position with eyes closed, and unusual phenomena are observed clinically, which could be sleepwalking, which I will be touching later, and sleep talking. The first question comes, is sleep active or a passive process? It used to be thought that it's a passive process. When one sleeps, you really don't know where you are, what happens to your mind, what happens to your body. But with much of the investigations now, we can prove it that sleep is an active process. The reasons, in fact, the brain and the body stay remarkably active while sleeping. And how to prove it? It is supported by PET scan and functional MRIs. You can see the red spots over here. The PET scan and the functional MRI shows that the red areas denote state of higher activity even during the rapid eye movement sleep, which is the REM sleep. And I've depicted a picture of a normal sleep also, but you can see in both the pictures, the red spots are there. So that means that there are definitely a higher amount of brain activity is going on even when you are sleeping. Another question comes, why do we sleep? What is the necessity to sleep? Because if statistically we go, 1/3 of our life is spent in sleep. Different theories have been put forward. I'll be enumerating mainly the 6 theories which are accepted worldwide. The first was it used to be a protective behavior adaptation, or it's a energy conservation. Some postulate it's a hormone regulation. It's memory consolidation, creativity or brain restoration, immune function regulation through natural killer cells, and the last is emotional balance and mood. I'll be touching briefly on every topic. Now first, few thought that it's a protective behavior adaptation because it was thought that during 24 hours the species and the animals need to protect themselves and they slept. But didn't hold true for all of them, because some sleep maybe for an hour and some sleep for maybe 16 or 18 hours, so it doesn't hold true for everybody. The second is energy conservation. It was postulated that in order to survive, body needs rest to conserve energy. But this theory has its own limitations. Few hormones have been associated with the sleep mechanism. The main hormones being melatonin, cortisol, growth hormone, and thyroid. Few more hormones have also come into play. They are acetylcholine, 5-hydroxytryptamine, norepinephrine, gamma-aminobutyric acid, orexin, or serotonin. Now for hormone regulation during sleep, it's a melatonin which is production starts well before we start sleeping, and the peak is there at the midnight, and after the midnight it starts falling. Cortisol levels are low in the night when we start sleeping, but they peak early in the morning. The normal time is 4 to 5 a.m. in the morning. Thyrotropin also peaks at night. Growth hormone also peaks at night. And the cerebral blood flow peaks during the midnight. The fourth theory which is being discussed is memory consolidation or creativity. Now, whenever we receive some information, it is stored in the brain just like a computer. And the specific formulation is there is an encoding of this, there is storing, there is followed by imprinting, and afterwards you can recall those things. We call it as memory. You met somebody, you meet in the next day, or maybe in the later life, you can recall the person's name, you can recall the face, or the textbooks, or the material which you guys are reading over here. So encoding, storing, imprinting and recall, that is the fashion in which the brain functions. Sleep plays a housekeeping role. Like we dust our house, we clean our house. Sleep removes the toxins and the metabolic waste, just like immunoglobulins or the proteins like beta amyloid, protein fragments from the interstitium of the brain through the lymphatic system. And how? Because these things, they build up during the awake state and they settle down during the memory. Now I'd like to touch a point over here that beta amyloid, non-clearance, if they're not cleared and get deposited, they pose a big risk factor towards Alzheimer's. The first is immune regulation or immune function regulation. Gets activated during night, especially increased production of natural killer cells. Now what are these natural killer cells? They are WBCs basically, which destroy the infected and the disease cells and thereby preventing the viruses and even the cancer cells from spreading. So they help in restoring the brain and preventing further infections or the malignancy in the body. Last, which carries a lot of weight, is emotional balance and mood. Sleep deprivation leads to excitation of amygdala lying next to hippocampus. If you don't sleep for a night, for 2 days, like we often have in our medical profession, we have duties, night duties and all. So if you don't sleep for 2 days, what happens is that the amygdala gets excited. Amygdala, the main functions of amygdala are emotional responses like happiness, fear, anger and anxiety. Excitation of amygdala leads to phase of irritability, anger and mood fluctuations. Now, it has been postulated because of this continent that amygdala excitation is one of the precursors for substance abuse also. In contrast, prefrontal gyrus, the cortex, exerts suppressant effect on the amygdala. Sleep plays an important role in maintaining the normal homeostasis of the body. Another painting is a world-class painting by The Night's Dream, which is a Spanish painter. Now, I'll be briefly touching the anatomy, the physiology, and thereby we'll touch the medical part, the diseases associated with the sleep. The anatomy of the sleep is that suprachiasmatic nucleus is the one which we'll be discussing for this part, which is situated in the anterior part of the hypothalamus. It is the central pacemaker of the circadian rhythm. The afferent tract, they start from the eyes, that is the retino-hypothalamic tract, and the efferents go to the pineal gland, which thereby secretes melatonin. Now, I've depicted a picture over here where the light is there, the retinal cells, the retinal ganglion cells get excited. The information goes from the retino-hypothalamic tract to the pineal gland, and thereby the cycle gets. It's a sleep-wake cycle which comes up, and you have arousal, then there's rapid eye movement. The timing and consolidations I'll be touching all briefly. The physiology of the sleep is that there's a dark room. In the evening, when you go to your room, it stimulates the suprachiasmatic nucleus. There is a release of norepinephrine. This norepinephrine acts on the pineal gland. There's a release of melatonin, which initiates the circadian rhythm. And this further, there's a release of prolactin, ACTH, norepinephrine, and further melatonin is secreted, and the cycle is repeated. Now, often a question comes, what starts the circadian rhythm? It is the melatonin, not a dark room, which starts the circadian rhythm. It's deficiency of melatonin. If there, then you don't have a proper sleep. The circadian rhythm will be disturbed. And what starts a sleep cycle, you need a dark room. You need a dark ambience. Regarding the physiology, I'll be briefly touching the two factors. One is factor S, other factor C. They play basically the role in the sleep part. Factor S is a homeostatic factor dependent on number of awake hours prior to the sleeping phase. And during the awake hours, you have accumulation of adenosine. You can see in the first block, the upper part, right from 7 a.m. there's accumulation of adenosine and one keeps awake. If the adenosine gets built up, you remain awake. And the other factor is factor C, which is a circadian factor, which is maintained by the suprachiasmatic nucleus. Adenosine gets dipped in the late evening and the sleep starts. And for circadian law, the biological clock we have, again, in the evening after 8 p.m., adenosine deficiency is there, blood levels get low, and the circadian factor gets in. A sleep-awake cycle in which both the process S and process C I have tried to show over here. The adenosine levels get up to 8 p.m. Alertness is there, and followed by the dip in the adenosine and the night sleep starts. And again followed by, in the morning, you have again a weakness. A brief word for the normal awake sleep cycle. Now, the sleep can be divided into two groups. You must be reading over there. The non-REM sleep and the REM sleep. Non-REM sleep is also called the non-rapid eye movement, and REM is rapid eye movement. Non-REM sleep can be further subdivided into different stages, stage 1, 2, 3 and 4. But currently, from 3 years back, we have only stage 3 because stage 3 and 4 are collectively now known as slow wave sleep, and we have just stage 3 and there is no stage 4. So N1, N2, N3 will be discussing in NREM. Now in the general awake and the sleep pattern, we have an awake pattern, we have an NREM pattern, and we have REM pattern. Different waves have come up. That's how we diagnose for the disease part. There are beta waves, there are alpha waves, there are theta waves, there are spindles, there are delta waves, and followed by again the beta waves. Now, in order to how to know that how these waves are there, there's a phenomenon which we have made it that the bats drink blood. You take the first word, BATS, D on the left hand side, you can see. Bats drink blood. The first is B, there's a awake state, the eyes are open and there are beta waves. It becomes easy to understand the disease and it becomes easy to understand the cycle. Then again, in the awake state, if you have the eyes closed, the alpha wave set in. That's the other part of the bat, A. For non-REM sleep, we have the first is N1, the theta waves. The T stands for theta waves, also called as positive sharp transients or post. N2, they're basically called, they have the sleep spindles or the K complexes, and the only disease associated in the N2 phase is teeth grinding or bruxism, which is very common. Often clinically you have patients with it. For N3, you have D, the delta waves, which are low frequency and high amplitude waves. And sleepwalking, night terrors are observed in this phase. Often bedwetting, if you come and try to have patients clinically, bedwetting is there and we use imipramine clinically because that's the only drug which decreases the phase N3. And this is abolished, you can absolutely cure the bedwetting part. So N3 stands for D, delta waves, low frequency, high amplitude, sleepwalking, night terrors are there. And the last is REM sleep or rapid eye movement. The B is there because the last word for the blood. Beta waves again set in. It's the dreaming part, dreaming sleep or the memory processing takes place over here. And if you arouse any person from the sleep and he or she is in the REM phase, they remember the dream. Otherwise, for non-REM, if the person is sleeping, you awake, he will not remember the dreams. Typically, sore throat appearances there. Now, these appearances are there on the polysomnography, which we do a test to. It's a full night test for 10 to 12 hours. We call the patient in the evening. He has his light dinner and sleeps till morning, and we have the cortex recordings, which we are doing in Ludhiana also. So for REM sleep, I'll repeat again, the beta waves, the dreaming and the memory processing takes place. You remember the dream if you get woken. Sort of the appearance is there. Now all your body muscles are paralyzed except extraorbital or the breathing muscles are there. And that's the only reason why you have the rapid eye movement, because of extraorbital muscles. Now often we clinically encounter issue that what is latency. Now a broad definition for latency means how long until. What is sleep latency? It's the time taken to fall asleep. Some take 5 minutes, some take 20 minutes, some take, you keep on tossing the beds, 30 minutes. And what is REM latency? The time taken to get into the REM phase after N1, N2, and 3. That time is important. How much time you take to go to the REM phase. Because now the disease, the clinical management will come now. Now in depression, I have taken the depression part basically. We have a number of diseases, but depression being one of the most common being encountered in our society. So what happens to sleep latency, what happens to REM latency, what happens to N3 delta, and what happens to REM density. So in depression, you have increased sleep latency while you fall asleep late. And REM latency, how much time you spend in REM, it is much more decreased. And N3 delta is again decreased, and REM density is much more increased. Now first REM in depression is always increased one. That's why you see on the polysomnography. If we give antidepressants or SSRIs, we suppress the REM sleep. That's the treatment part, how we do it. Now few conditions in which you encounter increased REM latency are restless leg syndrome, which is very common clinically, and older adults. Older adults, the sleep is too less. They have decreased REM. They sleep early. They get up around 11 in the midnight. They can't sleep. Then they sleep maybe around 2 a.m. and then again get up around 4 4 a.m. So they have very less sleep. And conditions with decreased REM latency are depression and narcolepsy. Now for a normal sleep pattern, there are 4 stages basically. Stage 1, 2, stage 3 and 4 are combined, and other is REM sleep. Now you see over here, we spend 75 to 80% of the time in non-REM sleep and only 20% of the time in REM sleep. Now out of non-REM sleep, the first, second and the third stage, mainly the stage 2 comprises 55% of the sleep part, NREM sleep. In stage 1, the body starts falling to relax and you start sleeping. Stage 2, the brain slows down, stable light sleep is there. You know what's happening around you. Somebody is opening a door, somebody is opening the cupboard, somebody has come, some bell is there. You are in stage 2. For stage 3 and 4, the body tissue restoration takes place. It's called as a deep restorative sleep. And the last is REM sleep. It's the learning and the memory consolidation takes place. We call it a dreaming sleep. Now we diagnose these things, or we observe this sleep pattern through EEG, electrooculography from the eyes, and electromyography, EMGs. They help in collecting different waves from different parts of the brain, like alpha, beta, theta, gamma, and delta waves, leading to differentiation in the different stages of the sleep. Slow wave sleep, considered as most restorative sleep, occurs in first half of the sleep, and 20% of sleep time is spent in this stage. This is important for few other diseases which I will be touching later. And there is increased vagal tone, there is a decreased sympathetic activity, which lead to decrease in the heart rate. It's like bradycardia is there. The decrease in the blood pressure and the cardiac workload also gets decreased. Now I'm showing here a sleep cycles. One cycle, sleep cycle is trying to understand, one sleep cycle comprises of one NREM and one REM sleep. Now this full cycle, one REM and one NREM, is around for 90 minutes, 1.5 hours. And we have 4 to 5 such cycles in a single night. You can see the initial part of the night, there's more of NREM, the dips are more. And as the night progresses, you have more of the REM sleep is there. So in the initial part of the night, there is a slow wave preponderance, and in the later part of the night, the REM sleep preponderance is there. You have more of the REM parts. Again, I'm trying to show something on the hypnogram. The initial part of the night, you can see the red circles. Slow wave preponderance is there, which are circled red, and the green circles being showing the REM sleep, and which is there in the later part of the night, which is circled green, or the blue bars. Again, polysomnographies are there. That's the graph which you get for 8 to 10 hours of the sleep, or maybe any number of sleep the patient is sleep over here, right from 7 hours onwards. So you have the waves coming from the eyes, from the brain, from the chin, and from other parts of the body. We calculate the SpO2, we calculate the pulse, we calculate the heart rate, and the continuous monitoring, video monitoring is there. In stage 1, you can see the slowing of the activity in the upper layers. In stage 2, you have the K complexes. I don't know if I can show you here. The pointer is not working properly. Anyway, pointer can you need pointer to anyway. In stage 2, you have K complexes, and for the REM sleep, this is the pattern which we observed. Certain physiological changes which take place in the awake state, in the REM sleep, and the NREM sleep. You have the maximum parasympathetic activity going on in the REM sleep as compared to the wakeful. And sympathetic activity is there in the wakefulness, less in NREM, or it's decreasing in the REM sleep. Same way is the heart rate, the blood pressure and the cardiac output, which stay normal in the wakefulness but decrease to some extent as there is an NREM sleep or the REM sleep. Now how this wake control mechanism works? There is an accessory pathway in the form of reticular formation goes to the thalamus and the cortex. Certain neurotransmitters are involved like norepinephrine from locus ceruleus, 5-hydroxytryptamine, dopamine and some cholinergic pathways they play in. Orexin or hypocretin is a neuropeptide which is secreted by the hypothalamus. It's a very important hormone. It regulates the arousal, wakefulness and the appetite. And if there is a lack of orexin, you have obesities and narcolepsies. I've tried to show basically the typical part, the flow in non-REM sleep. It originates at ventrolateral preoptic area, suppresses the activity of the wake-promoting substances and thereby initiates NREM sleep. And for REM sleep, it originates in the lateral and posterior pontine neurons, cholinergic in nature, and exert inhibitory neurons to spinal motor neurons to produce REM atonia. A flip-flop model showing a sleep-wake cycle. There is hypocretin or orexin. There is increase in the norepinephrine, histamine and serotonin, and you have a depressing effect on the adenosine, GABA, ghrelin and melatonin. So that's the reason why you remain awake. If the balance is shifted towards a greater activity, wake-promoting systems set in and the person gets up. Now, in the lower graph, you see, if the balance is shifted towards a greater activity, on the left-hand side, there's more of melatonin, ghrelin, and the sleep takes place, and less on the histamine and serotonins. Again, a sleep-wake switch is like a switch. If there's on one side the acetylcholine, histamine, 5-hydroxytryptamine, orexin, and norepinephrine, and on the other side, ventrolateral pontine, VLPO, and the sleep sets in. So it's a switch, it's a balance. If on one side you have the hormones, other side there's a depressing effect. Decreased REM is associated with synucleins. Now what are these synucleins? They are proteins associated with synapse in the brain, often seen in Parkinson's patients with Lewy bodies. Just a rough idea. Sleep durations for infants it could be 15 hours, for toddlers it could be up to 12 hours, for teenagers up to 9 hours, for adults up to 8 hours, for elderly maybe 6 hours or even less to some extent. Normal sleep is dependent upon the quality, quantity and timing. There is an international classification for the sleep disorders in 2014 which we are accepting now, ICSD-3. Is based on pathophysiology and the symptoms. We classify the sleep disorders basically into 7 criteria. Insomnia, you don't have the sleep. Sleep-related breathing disorders like obstructive sleep apneas. Hypersomnias, more of sleep. Circadian rhythm sleep disorders. Parasomnias. Sleep-related moving disorders like restless leg syndromes and isolated symptoms. I'll be touching briefly all these. Now the first is insomnia. As the word says, there is absolutely a lack of sleep. What will it lead to? It will lead to exhaustion, drowsiness, anxiety, depression, and certain cardiac and metabolic problems. Insomnia could be because of your stress, could be because of the medications, could be because of travel, some heavy meal you have taken the dinner part, excess of nicotine, and poor sleeping habits. You are on the phone, you are with the laptop, and you are awake till 2 or 3 in the morning. And what are the features? Despite the opportunity to have a time to sleep, that's the diagnosis, that's the definition. Despite the opportunity to have the time to sleep with good congenial environment, the sleep is not there. Most common disorders seen in the population, around 10% of the population, inability to initiate sleep is there. Getting up early with poor maintenance of sleep. It is associated with day headaches, body aches, mood changes like irritability, anger, inability to concentrate, and marked forgetfulness. Insomnia is of two types, acute and chronic, or short-term or chronic. Chronic is more than 3 months and more than 3 times a week. If you have the clinical part, you label the patient or the person as chronic, and short-term is less than 3 months. What's the treatment like? You follow a heart-healthy lifestyle, make bedroom sleep-friendly place, avoid caffeines and nicotine and alcohol in the evenings, avoid afternoon long naps, go to sleep and wake up around the same time. A regular physical activity or even a yoga will definitely help you. Eat meals on regular schedules, don't have late night meals, and meditation does play a big role for insomnia. Certain medications which we are using, classified into following, which I have mentioned over here. The benzodiazepines, certain benzodiazepine receptor agonists, melatonin receptor agonists, orexin receptor agonists, and tricyclic antidepressants. Normally we are using zolpidem, the benzodiazepine receptor agonist, which is pretty safe, or remeltron, which is the melatonin receptor agonist, which is a pretty safe drugs. Now the second is the sleep-related breathing disorders. Now what happens during sleep? The gravity and the muscle relaxation allows the tongue and the surrounding soft tissue to fall back into the throat, obstructing the airflow. The sleep-related breathing disorders are basically obstructive sleep apnea, which you see in adults, or pediatric. Central sleep apnea syndrome, there is an absolute absence of airflow and the effort also by the breathing muscles. Sleep-related hypoventilation disorders and sleep-related hypoxemia disorders, in which there is marked low oxygen saturation is there with raised carbon dioxide concentration. I will be touching only the obstructive sleep apnea, which is the most common. I have mentioned, tried to show over there that obstructive sleep apnea could be a mixed one, could be a central one, or could be a generalized. In the central apnea, the most important thing which you observe in the polysomnograph, that there is no airflow and the effort is also missing. On the top one, obstructive, is basically the tongue or the soft tissue has fallen back on the airflows. Effort is there, but the flow is not. What are the criteria of obstructive sleep apnea? You see, there is a large or obese patients with large size necks, complain of sleepiness during daytime, non-restorative sleep, fatigue or insomnia symptoms. Patient wakes with breath holding and gasping and choking. Basically, the bed partner reports the habitual loud snoring which is associated in these patients, and interruptions in the breathing, or even both. Snoring and interruptions could be both. Patient is often diagnosed with hypertension, cognitive dysfunction, mood disorders, or even coronaries, CVAs, congestive heart failures, diabetes, or atrial fibrillation. Now, treatment lies with lifestyle changes and certain therapies. First, we follow the lifestyle changes like loss of weight, regular exercise, quit smoking, quit alcohol, nasal decongestants, avoid anti-anxiety or sleeping pills. For therapies, you prefer non-invasive therapies over the invasive ones, like cognitive behavioral therapy and biofeedback. That's the latest which is there in the world market. CPAPs we are using, oral devices we are giving, full face mask is advised in certain situations, and if nothing comes up, surgery is advised. Third is hypersomnias. Now, hypersomnia means that there is an excessive of sleep. Its ability to regulate sleep-wake cycle that gets impaired. Hypersomnia is of the following types, but basically I will be discussing the narcolepsy one. Narcolepsy type 1, narcolepsy type 2, idiopathic hypersomnia, Kleene-Levin syndrome, very important. Hypersomnia due to medical or psychiatric disorders, hypersomnia due to medication or substance abuse because of lack of wake promoting substances, and insufficient sleep syndrome. Now, what is narcolepsy? It's a daytime sleepiness. There's catalepsy, Hypnagogic hallucinations are there. Now what is this? That one is falling. There is a false perception of sight, sound, smell, touch and taste. And there is a sleep paralysis. Catalepsy, there is loss of muscle tone. The treatment is gamma hydroxybutyrate or GHB. This is also known as date rape drug and salt is sodium oxidate. Person taking this drug when mixed with alcohol goes to sleep quickly. It's a banned drug now. Mechanism of action works through GABA B mechanism, whereas the benzodiazepines work through GABA A. Modafinil can also be given as it keeps the person awake. And narcolepsy is often associated with hypocretin system and orexin is deficient. Fourth is circadian rhythm sleep disorders or delayed sleep-wake disorders. In the circadian rhythm sleep disorders, you have delayed sleep-wake phase disorder. The person sleeps around 4 a.m. but the duration maintains that he sleeps for 7 to 8 hours. He doesn't get up around 6 or 7 or 8. He sleeps for 7 to 8 hours. Now, advanced sleep-wake disorder seen in elderly patients. They sleep early, get up early. There is irregular sleep-wake rhythm disorder, non-24-hour sleep-wake rhythm disorder, seen in shift worker disorders and jet lag disorders. Chronotherapy is being used or promoted. It aims to restore proper circadian rhythm pattern of sleep-wake cycle through adequate hygiene, timed light exposure, and use of chronobiotic medications like melatonin. Fifth is parasomnias. It's an abnormal behavior during sleep. You can have sleepwalking, sleep talking, striking or hitting people, or even nightmares. It is NREM related parasomnias. You can have NREM related parasomnias and REM related parasomnias. Now try to show over here that NREM related parasomnias, they include confusion, arousedness, sleepwalking, night terrors, and sleep-related sexual behavior. In REM-related, it includes REM sleep behavior disorders, recurrent isolated sleep paralysis, or nightmare disorder. Sixth is sleep-related movement disorders. Restless leg syndrome, which is very important, very common. Periodic limb movement disorder. Sleep-related leg cramps, bruxisms. Benign sleep myoclonus of infancy. Propriospinal myoclonus at sleep onset, and sleep-related movement disorder at sleep onset. Out of all, I'll be touching the restless leg syndrome, which you have so many clinical patients. It is defined as an urge to move legs accompanied by or thought caused by uncomfortable and unpleasant sensation in the legs. They begin or worsen during the periods of rest, such as lying down or sitting. Often relieved by walking or stretching the limbs, or as long as the physical activity continues, and occurs exclusively in the evenings or the night. You don't have these in the daytime. And the important part, if you have a case of restless leg syndrome, must check in your serum iron levels, because often these levels are low, and you just treat this iron part in the patient, and the patient is cured. Certain drugs are advised, like gabapentin, pregabalin, propinerol, pramipexole. That's what clinically being used. Certain sleep facts. The longest someone has gone without sleep is 11 days and 25 minutes. A brief word about Kumbhkarna. We all read in the mythology that the man who used to sleep for 300 days, or maybe close to 2/3 of a year, brother of Ravan, a devotee of Lord Brahma. It was basically that they requested Goddess Saraswati to help them because he was about to kill them. So, but clinically he suffered from hypothalamic syndrome, the Kleene-Levin syndrome. There is a bilateral ventromedial nucleus involvement and characterized by periodic episodes of somnolence, hyperphagia, along with behavioral cognitive difficulties. Different species sleep in different postures while sleeping, and different areas of the brains are activated. Like dolphins, they sleep in the upright position, and one hemisphere of the brain is active, other is sleep. Horses and giraffes sleep less than 3 hours, whereas Armadillo and Opossums, they sleep for more than 18 hours. Elephant sleeps much less than other animals. Tigers and elephants have almost the same amount of sleep. The key factor to sleep is 10 minutes. If you can sleep in 10 minutes when you are lying on a bed, that's a golden rule. Otherwise, you must take some efforts, some exercise, take care of your diet part. Few entities have come up. What is somnophobia? It's a fear of falling asleep. Orinophobia is a fear of nightmares and dreams. Clinomania is irresistible urge to stay cozy in the bed. And dysania is feeling when woken, don't want to get out of the bed. Few words about sleep hygiene. Bright screens like TV, video games, phones and laptops affect the circadian rhythm, should not be used late in the evening. Avoid alcohol for at least 4 to 6 hours before going to the bed. Avoid caffeine and nicotine usage in the evening. Avoid strenuous exercise also before going to the bed. Thank you so much. I'll entertain any questions. Gentlemen, the best drug? Yes. Drug is not there. There are other non-medical medications techniques should be used, like regular exercise, diet control, breathing exercises, long walks. They should be encouraged before starting a drug. Melatonin, which we are using, no doubt, but before starting these, a lifestyle modification, if advised, you can cure the patient to 90% well. Otherwise, all sleep-inducing drugs, they are habituating ones. Once put on, it will be difficult to take them off. Diazepam, that's a panic disorder. For panic disorder we are using. That's an indirect effect for the sleep, not a good drug for sleep. If the person or the patient comes to you with panics and all, only then the clonazepam we indicate, but not directly for the sleep part, no. Basically, we going for benzodiazepines. But even those, now the latest is that don't start medication immediately.
Thank you, Dr. Arun, for a enlightening talk. So next I invite Dr. Sonu Sharma. He's DM Cardiology at Delhi Heart Institute and Multi-Specialty Hospital. He will be talking about recent advances in cardiology and overview. So he's going to present all the recent advances in cardiology briefly. Thank you, Dr. Sonu, for coming and delivering this talk on recent advances in cardiology.
Good afternoon, everyone. Thank you, Dr. Vitull sir, for inviting me to present a lecture on the topic. So, as already discussed, the topic of my presentation is recent updates in intervention cardiology. So, before going to the various interventions, first start with the various drugs. We all know that earlier, and as a part of anticoagulation, the only drug that is available was acetron or warfarin. But now we have many anticoagulants like direct thrombin inhibitors like dabigatran, then direct factor 10 inhibitors like rivaroxaban, apixaban, and edoxabans. So these are known as NOACs. So the main indication for the use of NOACs are, first of all, they can be used in non-valvular AF for stroke prophylaxis, treatment of the pulmonary embolism, DVT, and prevention of venous thromboembolism post-surgical cases. The doses: dabigatran is 150 mg twice a day, apixaban is 5 mg BD, then edoxaban is 60 mg OD, and rivaroxaban is 20 mg OD for non-valvular AF, and for venous thromboembolism they have a different doses. then what is the limitations? We all know the advantages of NOAC. That is, they do not require recurrent PTNR monitoring. They have less chances of intracranial or major bleed. But what are the limitations? First is their cost. They are costly as compared to acetron, but now all cost of all these drugs have reduced significantly. Second major problem is the availability of antidote. Third is they are contraindicated in patients post-valvular surgery. This point has to be remembered. They are contraindicated post-valvular surgery and patients with severe MS. Now they are approved for MR, AR, AS and AR, but they are still contraindicated for severe MS and post-valvular surgery. Other contraindications are pregnancy and breastfeeding. While severe hepatic dysfunction and liver dysfunction, these are also limitations of NOACs. So advantage we already discussed. No lab monitoring, minimal use of drug-to-drug interaction, minimum chance of major bleeding, particularly the ICH risk is quite less as compared to acetron or warfarin, and they do not require bridging therapy before invasive procedures. Earlier we have to switch the patient to heparin before doing a surgery, but this switchover is not required once the patient is on newer anticoagulants. They have rapid onset and non-inferior efficacy with heparin. Then apart from anticoagulation, we move on to the lipid lowering drugs. Then we have, the newer guidelines have divided the patient into 4 groups in which we have to give the statins. They have moved from a value cutoff of LDL level towards the 4 groups that will benefit from lipid lowering or use of statins. So these groups are patient with having clinical atherosclerotic cardiovascular disease. That means patient having MI, stable, unstable angina, then coronary artery disease or peripheral vascular disease, TIA and stroke. We have to give these patients minimum moderate to high dose statin, whatever be the level of LDL. Even if the LDL level is less than 100, we have to give them atorvastatin minimum 40 mg lifelong or rosuvastatin minimum 20 mg lifelong. Similarly, the second group is primary LDL levels. If more than 190, we have to give them minimum 40 mg of atorvastatin and 20 mg rosuvastatin. Third group is diabetic patient between age group of 40 to 75. Even if they have LDL level between 70 to 189 and without atherosclerotic cardiovascular disease, we have to give them minimum moderate dose of statins. And the fourth group is patients with age group of 40 to 75 without atherosclerotic cardiovascular disease, without diabetes, with LDL level between 70 to 189 and estimated cardiovascular 10-year risk of more than 7.5%. Still, we have to give them minimum moderate dose of statins. Apart from statin, the newer these anti-lipidemic drugs are PCSK9 inhibitors. They are alirocumab, bocozumab and evolocumab, given as a dose of subcutaneous injection once in 2 weeks or once in a month. Indications are they are to be given patients statin intolerant or allergic to statins. Second is adult patients with heterogeneous or homogeneous familial hypercholesteremia, and patients on statin LDL level is not still not the newer drugs that are added in the heart failure treatment. The first drug, that is ARNI, that is valsartan and sacubitril combination. Now it is said that even in a patient of chronic symptoms of heart failure with reduced ejection fraction, class 2 or class 3 who tolerate ACE inhibitors or ARBs, replacement by an RNA is recommended to further reduce the morbidity and the mortality. So earlier we give ACE inhibitors or ARBs, they have almost equivalent effect on morbidity and mortality, but now the newer guidelines is change them to RNA because RNA is providing further 20% reduction in the mortality as compared to that given by the ACE inhibitors or ARBs. Now the second drug, that is class 2A recommendation, is ivabradine. It is beneficial to in patients who have symptomatic, or it reduces the heart failure hospitalization for patients with symptomatic heart NYHA class 2 and 3, EF less than 35, who are on guideline and directed medical therapy using beta blocker at maximum dose, but still they have a sinus rate more than 70. Then ivabradine will reduce the hospitalization in these type of patients. So this slide showing RNA is providing 20% further reduction in the mortality as compared to provided by ACE inhibitors or ARBs. The newer drugs, that is SGLT2 inhibitors, it is added in the heart failure treatment as class 1 drug. Basically it is an anti-diabetic drug, but it is now a class 1 recommendation to given in the patients with heart failure with reduced ejection fraction, whether patient is diabetic or non-diabetic. These both are approved to can be used as a class 1 drug, DAPA and empagliflozin. Then from drugs we move on towards the investigations. So first investigation is in cardiology is echo. So now we are moving from 2D echo to 3D echo. Basically 3D echo is giving us the depth knowledge also. Earlier we can only do in 2 dimensions. Now we can use the depth of the patient, depth of the cardiac tissue also. Particularly useful for cardiac interventions like mitral valve intervention or in ASD closure. These the 3D dimensions help in better judgment of the device. Now from we all know that angiography is the gold standard for diagnosing coronary artery disease. But now we have CT angiography. Like in other disease, CT can be done. It provides it can easily diagnose the stenosis at a particular level. The sensitivity and specificity of 64 slice MDCT is around 94 to 97%. It is particularly useful in our patient because most of our patients post bypass usually lost their records. कहते हैं डॉक्टर साहब 10 साल पहले bypass हुआ था, now they have no records. We don't know how many grafts are put and how can we do an angiography in these type of patients. So by doing CT angiography, we can easily define the various grafts and how many grafts are working, how many grafts are not working. So this is particularly beneficial in these types of patients. Other benefits in particularly young patient in which we know that there is less chance of blockage, but still patient is having doubtful TMT and doubtful of symptoms, then we can see easily do a CT angiography and diagnose whether he or she is having a coronary artery disease or not. Then from CT, now move towards the MRI. We all know that MRI is useful in various clinical settings, particularly in neurology, but now it is coming up in cardiology also. By MRI, we can easily define whether a patient with LV dysfunction, it is because of coronary artery disease or it is because of various other non-ischemic causes. Because an ischemic cause will have a subendocardial infarct, will cause a subendocardial late gadolinium enhancement or a transmural gadolinium enhancement. While non-ischemic will cause a mid-wall enhancement or epicardial enhancement or global endocardial enhancement. Because once there is coronary artery blockage, the ischemia travels from endocardium towards the epicardium. So, if it is because of coronary artery disease, there will be only a subendocardial or a transmural infarct. It can't be a global endocardial infarct. Particularly in diagnosis, if a young patient present to us with ectopics and having palpitation, we know that on ECG there is VPCs originating from RV. So whether this is a benign VPCs or it is a malignant VPCs. Malignant means patient is suffering from ARVD. ARVD is a cardiomyopathy which can cause death within 5 years of diagnosis. So it is very useful in young patients with frequent VPCs. We can diagnose ARVD and the treatment of ARVD is placement of an ICD. Similarly, young patient presented with complete heart block. So mostly the treatment of choice is a pacemaker. But if a young patient presented with a complete heart block and we do an MRI and there is this late cadaveric enhancement supporting of sarcoidosis, then we have to treat the sarcoidosis. And second thing is, we have to implant this ICD, not a pacemaker, because a sarcoidosis increases the risk of VT. So placing a pacemaker in these type of complete heart block patient will be deleterious to the patient. So ICD will be the treatment of choice. So these are the useful technology use of technology in cardiology. So from diagnosis, we move on to the intervention part. In the intervention, we all know that we do the ultrasound daily in our practice. Now we can do the ultrasound of the coronary artery, that is the intracoronary imaging. This is IVAS, that is intravascular coronary ultrasound. Like doing an ultrasound, we can easily define the walls of the coronary arteries into three, that is intima, media and adventitia. That can be beautifully seen with the intravascular ultrasound. So this is an example. The upper arrow and on the top right, there is the lumen is seen. There is no blockage. It is also seen in the angiographic view and also in the IVAS view. While in the lower image, there is a stenosis around 70 to 80%, which is not seen in the angiographic image. So, like ultrasound, we can do use the infrared rays to diagnose the various lumen stenosis or the various fibrous or calcium deposition inside the coronary artery, which are beautifully delineated with the help of infrared rays. Like the first image, there is fibrosis seen. Fibrous will show as a bright pixel, thick with which are finely defined and deep penetration. While the lipid rich stenosis, there will be a dark pixel that is black in color with low penetration and diffuse edges. While if there is a calcium, there is a sharp delineation with dark pixel and deep penetration. So we can differentiate whether the stenosis is more of fibrous type or lipid rich type of calcium type. Because if a fibrosis is of a lipid rich type, then the chances of MI is quite high as compared to that of a calcium rich stenosis. This is a classical example of thin cap fibrous atheroma. There is the yellow part is seen stenosis. In stenosis, the yellow part upper layer, it is quite thin, less than 64 millimeters. The chances of rupture is quite high, and this is the major cause of MI in young patients. So, if we diagnose a patient at that stage and give statins, then we can quite reduce the risk of MI in young patients. And these are the various thrombectomy catheters we use in our coronary cath lab to aspirate the thrombus from the coronary artery. This is how a thrombus after aspiration look like in an MI patient. Then for valvular diseases, we can treat almost every disease now without surgery with the help of minimally invasive techniques. Like for MS, we have balloon mitral valvuloplasty. These are the various instruments used in BMV, and this is how a BMV is done. First, we pass a catheter, then pass a guide wire across the interatrial septum, then pass a balloon over the guide wire, and just pull back the balloon and dilate the mitral valve, and the mitral stenosis is cured. Now for pulmonary stenosis, we have BPV, that is balloon pulmonary valvuloplasty. The patient is diagnosed with the help of ultrasound as having severe PS. On echo, there is RA-RV dilatation with increased gradient across the RVOT. So this is the angiogram. There is pulmonary stenosis. So after passing a balloon, just dilate the pulmonary wall. Then pulmonary stenosis is cured. Now from MS, PS, now we move towards the aortic stenosis. For aortic stenosis, there is TAVI, that is transcatheter aortic valve implantation. Now is generally accepted as a new standard of care for particularly symptomatic AS patients who are not a candidate for surgery. Around 1/3 of the severe AS patients in the real world are unsuitable for surgery. So in these type of patients, now TAVI can be done. It is minimally invasive and patient can be discharged next day. Now ongoing trials are comparing even moderate risk surgical patients whether TAVI is better than the surgical outcome. So in severe high risk patient, TAVI is better than surgical patient. In moderate upcoming guidelines, they are favoring towards the TAVI as compared to the surgically aortic valve replacement. This is how this valve look like. Then from AS for pulmonary for PS or PR, we can go for transcatheter pulmonary valve implantation. These are how a transcatheter pulmonary valve look like. Then for MR, we have a mitral clip. It is recommended to be used in significant symptomatic MR due to primary abnormality of mitral apparatus in patients who are being prohibitive or having a high surgical risk. Then we just go with a mitral clip and reduce the mitral regurgitation. This is how a mitral clip look like. Then for aortic, we have TAVI. For MR, we have a mitral clip. And now upcoming, there is transcatheter mitral valve implantation. This is how the mitral valves look like for transcatheter implantation. Now from valvular lesions, we move towards the various devices. So now there is a leadless pacemaker. Earlier we used to implant a generator below the clavicle, and the lead is placed inside the RV. Now there is no need for a lead to be placed or incision to be done. Just we can go through the femoral vein and place a pacemaker inside the RV. It is the size of around remote size battery, AAA size. Its life is around 7 to 10 years with no or minimal risk of infection, and can be done within 1 hour, and patient can be discharged on the next day. This is how a leadless implanted pacemaker will look like on an X-ray. Then we move toward the ICD. Earlier we used to place a generator below this clavicle and place the leads inside the RA and RV. Now we are moving towards a subcutaneous ICD. That is, ICD is placed and the leads are placed subcutaneously just parallel to the sternum bone. So there is no need to go transvenously. So lesser chance of transvenous damage or lesser chance of infection as compared to the transvenous. Now for LV dysfunction, the device which can increase the LVEF is CRTD. This is how a CRTD look like. There are 3 leads. One is this is CRTD is recommended for patients having QRS duration more than 150 milliseconds, LVEF less than 35%. These are the patients who will benefit maximum with the use of CRTD. Then apart from cardiology, the interventions are coming for prevention of stroke. So we all know that atrial fibrillation is the most common arrhythmia. It affects around 1 to 2% of general population, and presence of AF increases the 5-fold risk of stroke in a patient. And most of the strokes are 87% are thromboembolic, and in AF, that is more than 90% of thrombus that occurs in AF that cause stroke originates from left atrial appendage. So if we seal the left atrial appendage, we will 90% reduce the risk of stroke in AF patients. We know that warfarin reduces the risk of stroke by around 60% and all-cause mortality is around 26%. Antiplatelet do not reduce the risk of mortality. They only reduce the risk of stroke by around 22%. So this is a Watchman LAA closure device in which we just seal the left atrial appendage through the femoral vein route, pass through the anterior septum and place a Watchman device inside the left atrial appendage. And this will reduce the risk of stroke. It is now a class 2B recommendation to be used in a patient in whom we cannot, there is contraindication of anticoagulation. This is now approved in those patients only, but in upcoming years maybe this will be the line of or management of choice within 5 to 10 days once the things are refined. Now for PDA closure, earlier we used to do surgery, but now we can just close the PDA through the femoral route. This is how Emplart's PDA closure device look like. In the B slide, there is a flow is seen from aorta inside the pulmonary artery. After placement of in the C slide, there is a Emplant. This PDA closure device is placed, and there is now no flow going from aorta to the pulmonary artery. Now there is his bundle pacing. Earlier we used to place the lead inside the RV, but placing of the lead inside the RV in long run may lead to LV dysfunction. But so now they are coming with the his bundle pacing. This is basically the lead is placed at the his bundle, and the rhythm that is after placing the lead at the his bundle will be a normal sinus rhythm type of rhythm, and the chances of LV dysfunction will be minimal with this type of pacing. And now for PSVTs and for VTs with normal LV function, we can do EP study with RFA and we can cure the PSVT. This is how EP study and this RFA catheters look like. For carotid stenosis, what we can do is carotid stenting and reduce the risk of recurrent stroke. For peripheral artery disease, we can do a peripheral stenting. And for aortic aneurysm, what we can do is endovascular aortic repair. Like this is a graft, or what we can say a large stent that can be placed inside the aorta, and the aneurysm can be sealed without the use of surgery. We all know that aneurysm surgery is very high risk surgery. So with the use of endovascular aortic repair, we can treat the aneurysm with minimal risk. And this is renal artery stenosis, and this is how post stenting, how a renal artery stenosis. The major benefit for this renal artery stenosis is that this was an image of a patient who was mother of one of a medical student. She was on 4 antihypertensives, that is telmisartan 80 milligrams, chlorthalidone 12.5 milligrams, then amlodipine 10 milligrams, and prazosin 5 milligram BD. Even after 4 drugs, her BP was more than 150 every time. Sometimes it was 160 by 100, 170 by 100. But we did this renal Doppler and diagnosed the renal stenosis. Did the angiogram. There was bilateral renal stenosis, and on stenting both the arteries. Within 1 month, she was on just amlodipine 2.5 milligrams once a day, and her BP was 130 by 70, 120 by 70. So this is the major benefit of renal artery stenting. So thank you everyone for your patient listening.
Follow up clinically and investigation-wise in a patient who have been put stents in the heart, coronary arteries. What are the follow-up measures you recommend to the patient after how much time he should get any other investigation like CT angiography or anything else?
Post stenting for follow, first we said to the patient that follow a good lifestyle, healthy lifestyle to be followed. Okay. Now the use of other investigations, we just do the blood investigation, like we have to control the lipids, control the sugars, control the blood pressure on follow up, and give them antiplatelet drugs. If all these are controlled, now we have to just check whether our stent is doing well or not. For this, if the patient's EF is normal, what we can do is do a 6 month or 1 year do a treadmill test. If that is positive, then we will only go for any invasive or angiography. There is no need for doing angiography even after 5 years if patient is asymptomatic or his or her TMT is normal or there is no other complaints. There is no need for any angio, whether CT or invasive angio. So, thank you.
Any other question? Thank you, Dr. Sonu, for an enlightening talk.
Thank you.
So now I'll invite Dr. Mohanjeet Kaur. I am preponing her lecture because they have to go back to Ludhiana and weather is very bad. So I invite Dr. Mohanjeet Kaur to please come and start her lecture, which is really very important, tuberculosis preventive treatment, latest guidelines. Please.
Good afternoon everyone, and it is my privilege to share my views on very important topic, that is guidelines for programmatic management of tuberculosis preventive treatment in India. So friends, we already know that the burden of tuberculosis in India is quite alarming. India being the highest estimated, being the harbor of highest estimated cases of tuberculosis infection globally, with nearly 35 to 40 crores of Indian population having tuberculosis infection, of which 26 lakh are estimated to develop tuberculosis disease annually. So that is quite a big number, and the government of India in association with Ministry of Health Services is pledged to take very rigorous steps to combat this disease. And it is estimated that 5 to 10% of those infected will develop tuberculosis disease over the course of their lives, usually within the first 2 years after the initial infection. The risk of TB disease after infection depends on several factors, the most important being the immune status of the patient. And also it is believed that risk is increased more than 25 times among contacts of bacteriologically confirmed tuberculosis patients compared to the general population, and this number is again significant in patients who have concomitant HIV infection, and also the underlying immunocompromised conditions like diabetes mellitus and other immunocompromised situations, they increase the risk of developing tuberculosis by 3 to 4 times. So this is the burden of tuberculosis, and seeing all this data, the government of India has taken serious action, and a national strategic plan has been formulated. It was done in 2017 and it is proposed to carry on till 2025. The NSP proposes a strong detect, treat, prevent, build approach leading to prevention of tuberculosis disease by treatment of TBI, that is tuberculosis infection, which is a critical component of this project for ending TB in India by 2025. So this is a rigorous, expensive and accountable program which enforces TB contact tracing and investigation for secondary TB patient detection and treatment, coupled with active screening for tuberculosis, especially among high-risk groups, which we will be discussing later on, and also tuberculosis preventive treatment, which is the latest in DOT program guidelines, leading to total elimination of tuberculosis. So the pledge is tuberculosis-free India by 2025. So what is the multi-pronged approach? Actually, we are also running DOT center in our hospital, and we aim to provide multi-pronged approach through single window services. So what does the DOT center do? Number one is detection and tuberculosis of tuberculosis and MDR TB, then ensuring sample collection for AFB and CB NAT, HIV testing for all TB patients, providing antiretroviral therapy, providing tuberculosis preventive treatment, then chest x-ray screening of all household contacts, ensuring financial incentives to the patients, counseling and home visits. So these services are provided through single window scheme in all the DOT centers. So this is a cascade of TB case finding and TPT. First we select the target population, which I will be discussing in the next few slides. Then we rule out tuberculosis with certain signs and symptoms that I will discuss, and then role of TB infection diagnostic strategies with TST and IGRA, and then evaluating the patient for tuberculosis preventive treatment, and then starting the TPT. So this is the main algorithm. The cascade of TB case finding and TPT aims to reach out to all target population who are at risk of developing TB disease, and then they are screened for TB disease and provide TPT after ruling out the active TB disease. But let me tell you that not all individuals infected with M tuberculosis develop active TB infection, that I have already discussed. This mainly depends on the immune status of the patient, and there are no predictive tests to identify individuals who will progress to this particular disease. Tuberculosis preventive treatment is a continuum of care for routine program activities including acute case finding. See what active case finding. So what happens is when we take care of the high risk groups and we look for their symptom complex which are in close contact with the primary index case of pulmonary tuberculosis. This is one way of finding acute cases also. Like if the patient, the index patient is of pulmonary tuberculosis and the household contacts are screened for active tuberculosis, then there are much more chances of finding out the acute cases also. So that is a continuum of services leading to more and more number of active cases also. So these are the target population groups which are at high risk. So in this category, number one is patient living with HIV. That forms the target population for tuberculosis preventive treatment. Then all household contacts of pulmonary tuberculosis, individuals on immunosuppressive therapy, people with silicosis, people on anti-necrotic factor treatment, patients on dialysis, and patients who are preparing for organ or hematological transplantation. So this is a very important slide, and these category of patients should be suspected strongly, and we should always aim to follow up these patients very rigorously. So what important points we should keep in mind? Ruling out active TB is mandatory before initiation of TPT. Then in children under household contact under 5 years of age, TPT will be offered without testing for TB infection. I would like to clarify certain things here. TBI or tuberculosis infection, or what we know as latent tuberculosis infection, is if the patient has immunological evidence of tuberculosis but patient has no clinical findings of tuberculosis, or patient is not bacteriological confirmed case of tuberculosis, that is TBI or latent tuberculosis. Here this will be diagnosed only with the method of immunological testing, and in India there are two tests which we do, that is TST, that is tuberculin skin testing, and IGRA. So you all will agree that these are the two tests by which we can detect tuberculosis infection or latent TB infection. It is postulated that in children with HHC under 5 years of age, TPT will be offered without testing, and household contact with children more than 5 years, chest X-ray and TBI testing would be offered wherever available. But suppose if the chest X-ray or if immunological testing is not available, still we have to offer the contacts for TPT. See, like I am running DOT center in my hospital. So what we do is we don't do immunological testing for our contacts, whether they are of 5 years or more than 5 years. These are the guidelines which are given by WHO, but we are providing TPT to all the household contact patients irrespective of their age. Second point I would like to clarify is in TBI, like less than 5 years of age, it is mentioned that TPT will be offered without testing or without giving tuberculin skin testing or without going for IGRA, because it is postulated that BCG vaccination also plays some role in developing immunity against tuberculosis. So less than 5 years of patients, it can be eliminated. But for all practical purposes, I would like to reaffirm that we are not carrying out tuberculin skin testing or IGRA, and we have to take care of the financial issue also. One IGRA costing 1500 and then we have to wait for 1 week. That is practically not possible for tuberculosis contact cases. So what we are doing is we are screening the high risk population. And then screening is done, which I will be discussing later. Rule out active tuberculosis disease and start the patient on TPT. So this is the general guidelines which we are following in DOT center. So what we do, this is again, I have already discussed. Suppose there is a primary index case of pulmonary tuberculosis in the house. Look for 4 symptom complex for all household contacts. Symptoms are cough, fever, weight loss, and night sweats. This is the 4 symptom complex. Index case should be pulmonary tuberculosis. At present, TPT is not extended to extrapulmonary tuberculosis, but we expect that this will be done in near future. If complex positivity is there, then we do chest X-ray and sputum AFB, see for activity of the disease, and if it is there, start ATT. But if there is no active disease, then we start the patient on TPT. TPT is given irrespective of the age, and we have to rule out certain contraindication that I will delineate later on. So this was the household contact. Now coming to the second high risk group, that is people living with HIV and AIDS. It is believed that TPT reduces the overall risk of TB by 60 to 90%. That is a very impressive figure, and that further strengthens our effort to provide TPT in our population. So it is believed that adults and children more than 12 months living with HIV should be screened for TB using a 4-symptom complex, and then TPT should be provided to those without symptoms or after ruling out active TB. So these are very general guidelines which I have already postulated. Then TPT should be given to all these individuals irrespective of the degree of immunosuppression, that is irrespective of their CD4 count, whether they are on ART or not. So irrespective of the ART status, whether they had any previous tuberculosis infection and pregnancy. And let me tell you, pregnancy otherwise also is not a contraindication for putting the patient on TPT. And TPT should be an integral part of the care package of PL-HIV. So this is what I want to emphasize on the single window services. From the same dot center, patient is receiving all the necessary care. So then expansion to other risk groups. So the Government of India, Ministry of Health and Family Welfare is trying to extend these services to other risk groups also. So what are the other population with high risk group? People who are on immunosuppressive therapy, silicosis and anti-TNF treatment, dialysis, and patients preparing for organ and hematological transplantation. Now, I would like to clarify here that diabetes mellitus, malnutrition, smoking, harmful alcohol abuse, these people, they do not come under the category of high risk population as per the WHO guidelines. But one has to be extra careful while dealing with these contacts, and they should also be rigorously followed up and evaluated for developing active TB disease. Because we know that diabetes mellitus itself is a immunosuppressive condition. And then we have to identify high transmission setting also, like healthcare workers, prisons, mines, slums, tribal areas and migrant laborers. And the proper mapping should be done in these vulnerable areas, but this exercise is more for active case finding. So this I have already said for TBI infection, tuberculin skin testing and interferon gamma release IGRA, these are the two immunological tests. But my friends, I am again emphasizing that in clinical practice we are giving irrespective of the availability of these two tests. So this is for the comparison sake I have made this slide. The only point I would like to highlight is specificity of TST is very much low in BCG vaccinated individuals, and IGRA has a very high specificity in BCG vaccinated individuals. So this is one point we all have to be very careful about when we are offering these tests to the patients. So this is the algorithm. This slide is little exhausting, but I mean I would certainly like to highlight few things that in all the high-risk groups, we look for the symptom complex, and then if the patient is symptomatic, then we look for active TB, and then after active TB is ruled out, then we have to look for the contraindication for putting the patient on TPT, and if there are any contraindication, then we have to defer that particular contact patient for putting them on TPT, but in the meantime you have to keep following up the patient for developing any active disease because he is in contact with an index case. So and after then again on follow-up we have to re-evaluate the patient if that active contraindication is no longer there, that I will discuss later on, and then he is a suitable candidate for putting the patient on TPT. So what are the contraindication for TPT? Active TB disease is an absolute contraindication. Even when the patient is put on TPT, patient has to be followed up for developing the signs and symptoms of active TB disease during the course of TPT, acute and chronic hepatitis, concurrent use of hepatotoxic medications like nevirapine, then regular and heavy alcohol consumption, then signs and symptoms of peripheral neuropathy, that one has to be very wary about, and then allergy or non-hypersensitivity to any drug being considered for TPT. And friends, I am again emphasizing that pregnancy and previous history, like suppose the patient has completed his treatment in the past for tuberculosis and now he is living as a contact with the primary index case, even that person is a candidate for TPT. So this is the pre-treatment assessment, elicit information relevant to TPT initiation and continuation like LFT status, allergy, HIV status, ART, pregnancy status, birth control method and presence of comorbidity. So this is the pre-treatment assessment. So in individuals having abnormal baseline LFT, that is ALT over AST ratio more than 3 times upper limit of normal in the presence of symptoms and more than 5 times in the absence of symptoms, clinical judgment is required to determine that benefit of TPT is going to outweigh the risk of adverse events related to the therapy. So friends, this is a very important slide. I have really, made it very, very simple so that we can understand. So what are the TPT regimes which are presently available in India, and we are following the regimes. This is 6H regime, 6 months of daily INH. 3HP regime, INH and rifampicin weekly for 3 months. Weekly, I am again saying there is a individual tablets and fixed drug combinations are available. Patient is given weekly dose for 3 months. 1 HP is INH and rifampicin once a day for 28 days, and then 6 LFX, that is 6 months of levofloxacin, which is reserved basically for MDR-TBC. Out of these 4 TPT regimes, 6H regime, that is 6 months of daily INH, is the most popular. In our dot center, at present we have 55 patients which are on this particular regime. Then 3HP regime, INH and rifampicin weekly for 3 months. This is second most popular regime and we have started using in our patients. So at present I have 5 patients who are on this particular regime. See, we put these patients on particular regimes because we get the supply from the Government of India, and then it can be considered as a research purpose also, or novelty, or wherever isolated INH is contraindicated in certain patients, and there we would like to have an alternate regime, and we consider 3HP regime that I will discuss later on. So 6H regime and 3HP regimes are the most common regimes which we are giving to our patients in dot center. So this is again, I want you to just remember one thing, that HIV population, then household contacts, and whether it is less than or 5 year or more than 5 year, and then immunosuppressant category. So target population, here we are using 6 months of daily isoniazid and 3 month weekly isoniazid and rifampicin, depending upon the if there are any contraindication to INH alone or the availability of the medication in that particular dot center. So these are the 2 regimes which we are presently following in our high risk group. So this is the dosage schedule, 6 months of daily INH, monotherapy. It is dependent on age and weight band. If the patient's age is 10 years and older, it is 5 mg per kg per day. If age is less than 10 years, it is 10 mg per kg per day. So the maximum dose will be 300 mg per day. So these are the isoniazid tablets which are available in our center, 100 mg and 300 mg. And then at the bottom you can see dispersible tablets which are reserved for children less than 5 years of age. They can take the dispersible tablet. So that was 6H regime, and now I am coming to 3HP regime. That is 3 months of weekly rifampicin plus isoniazid. So that means that patient will take 12 doses, that is once a week for 3 months. So medicine formulation are isoniazid and rifampicin. These are the rifampicin tablets which are available in our center, and we are dispensing to our patients as a part of 3HP regime. So this chart basically shows the I don't know how to use the mouse, but anyways, this chart shows the comparison between these two important regimes. So what I want you to remember is interval is daily versus weekly, doses 182 in 6H regimes versus 12 doses of 3HP. We have to remember that. Then in pregnancy, it is safe for use. INH is completely safe to be used. And pregnancy, the data is still under consideration for 3HP. So this one. So data is still under consideration. So interaction with the ART regime, there are no restrictions in isoniazid, and if we consider 3HP regime, rifampicin is an contraindication for people who are on protease inhibitors, NVPs and TAF. TAF is tenofovir molecule, which is a prodrug which is actively used in patients with HIV. So my dear friends, 3HP regime, one has to be very careful. See, for household contacts we can use, but for people with HIV, we are not using. And then absorption, best absorb on empty stomach. Isoniazid 3HP should be given with a meal. And then toxicity, one has to be very careful about the hepatotoxicity in 6H regime, which is not a major concern in patients with 3HP regime, hepatotoxicity. So accordingly, patients can be delineated. So this was regarding the regimes available, and now coming to the pyridoxine. See, we all know that peripheral neuropathy develops as a result of deficiency of vitamin B6, and that is common during TB treatment and infrequently with it is infrequent with standard doses of isoniazid during TB. This is recognized as symmetrical numbness and tingling of the extremities, and it is usually reversible upon withdrawal of INH and giving high dose of pyridoxine in therapeutic doses, that is 100 to 200 milligram per day. So in clinical practice, what we are doing is we are giving in the dose of 10 milligram per day to children and 25 milligram per day in adults, and this dose is further accelerated in patients with HIV, that is 50 milligram per day. But let me say, TPT should not be withheld, and TPT should not be stopped if pyridoxine is not available to the patient, because the fixed regimes from government, they do not come with the pyridoxine. In that setup, we can always co-prescribe pyridoxine, and maybe patient can take some simple vitamin complex containing pyridoxine. Then there was another issue, whether there is an emergence of drug resistant following TPT. That was another important question when Government of India started the TPT, but there was no evidence of significant association between development of resistance to H or R with use of the drugs with TPT. Provided active TB is ruled out before TPT is initiated. This is very important point. And then again, once a patient is on TPT, we have to keep on following up the patient to look for whether the patient is developing any active TB disease, which is quite possible. And if the patient develops active tuberculosis, then rapid molecular DST, that is drug sensitivity testing, must be offered to all patients, whether if the patient develops TB during the course of TPT or post TPT. So these are few adverse effects. I will just highlight important points. Like isoniazid, we know that asymptomatic elevation of serum liver enzyme concentration can be there. Sometimes clinical hepatitis can occur, then peripheral neuropathies, skin rash and sleepiness. Rifampicin can lead to GI side effects and cutaneous reaction and discoloration of body fluids. And rifampicin, again, similar drug reactions can occur. But management of various adverse effects, that depends on the severity of the side effects. Suppose patient is developing acute liver failure, or elevation of serum transaminases is more than 5 times of upper limit of the normal, or more than 3 times upper limit of the normal with symptoms, then we have to stop all drugs till the jaundice is subside, and then we have to reassess the patient and try to restart the patient as soon as possible, which might take up to 3 weeks. If skin reactions with rash, we can offer symptomatic treatment to the patient and then try to continue TPT. And pellagra, again very important side effect of isoniazide. High dose nicotinamide is offered to these patients, but patients should be encouraged to continue with TPT. Peripheral neuropathy, I have already discussed. GI, again we have to take care of the symptoms symptomatically. Maybe antiemetics are given, and then patient can be restarted on TPT. And then lethargy and other mild side effects, they need reassurance. So this I have already discussed. So these are the special situations where TPT has to be given in certain coexisting clinical situations like women and TPT. Women pregnancy does not disqualify any patient. Otherwise also, or in HIV, I mean if the woman is living with HIV patient, so they are eligible for receiving TPT. However, we have to consider that pregnant women living with HIV are at a higher risk for tuberculosis during pregnancy and postpartum period. So TPT can be started during antenatal or postnatal periods, taking due care. Isoniazide and rifampicin are considered safe for use in pregnancy. There is no evidence to show an association of TPT with adverse pregnancy outcome like fetal neonatal death, prematurity, low birth weight and any congenital anomaly. Pyridoxine supplementation should be given routinely to all pregnant and breastfeeding women. Then contraception. Since rifampicin and rifampicin interact with oral and hormonal contraceptive, there might be a risk of decreased contraceptive efficacy that one has to be careful of. And if the patient is receiving oral contraceptive, then we have to use an alternative method, or maybe like high estrogen dose may be offered to the patient. Then liver disease, I think we have discussed quite in detail, but I just want to highlight few things which are not covered in the initial slides. That 6H, that is 6 months of daily INH, is well tolerated among individuals with chronic hepatitis B virus or C. So if the patient has previous history of hepatitis B or C, that does not rule out that patient from putting him on TPT in later years. Acute hepatitis, definitely one has to defer TPT until the acute hepatitis because of any reason has resolved. Rifamycins, including rifampicin, are not recommended for use together with many of the direct acting ARV drugs like tenofovir, so they can compound side effects, so one has to be very careful of, and we can use alternate regimens. So the healthcare providers have to be very, very careful in these patients. Renal failure, isoniazide and rifampicin are eliminated by biliary excretion, so TPT can be given in standard dosage to individuals with renal failure. Here, by these group, what I meant is patients with renal failure who are in contact with the primary case also, and they are in contact with the index case of tuberculosis. So, among the drug users, again, these patients should not be deprived of from the benefit of TPT if there is an indication of putting them on TPT. So, people taking 3 HP or 4R with opium substitution therapy should be closely monitored for signs of opiate withdrawal and other adverse effects. 6H is safe to use among people who are drug abusers, so we can safely offer them TPT. So, next few slides are the management of missed doses. So, suppose patient is on, I'm giving one example and then you can always build up your information on that. Like patient is on 6H or levofloxacin or 4H. These are the daily regimens, And here what we do is we see whether the patient has missed less than 2 weeks or more than 2 weeks. If the patient has missed less than 2 weeks, then we will resume TPT. If the patient has missed more than 2 weeks, then we will consider re-initiation of TPT in those cases. But friends, in 3HP, which is a weekly schedule, here the management will be different because the drugs are given on weekly basis. So if the missed dose is remembered, like if patient was supposed to take on Monday, but on Wednesday he remembered, so he can take on that particular day. But if the missed dose is remembered after 2 days, then patient can take, but then he can change the weekly schedule accordingly. And then if the more than 3 weekly doses of 3HP, then we have to consider re-initiation of TPT for another 3 months. So the treatment outcome or treatment completion. See, one has to be very careful, and a number of end points are proposed that could be used as a review of person on TPT, like 6H, 3HP, 6LFX and 4R. So here we know that the total duration is different, expected doses are different. So we all can see expected number of doses are different. So what we do is we see whether the patient has taken 80% of recommended doses in the stipulated time, or extra 33% additional time is given to the patient to complete the remaining dose. And if that target is completed, then we consider the patient completing the TPT. My idea of showing this slide to you is that so much paperwork and so much counseling, so much follow-up and home visits are done to ensure, the government of India is taking such a strong step to ensure that patient completes his TPT. So these are the treatment outcome goals. 80% of recommended dose consumed within 133, I have already discussed. 133% of the bonus time is given to the patient. And in 3HB, 90% of the recommended dose is given in 133% of the duration, and for 4R, 80% of the recommended dose. If the patient has completed, then we can say that patient has completed his TPT. So these are few definitions. Treatment failed, patient initiated on TPT who develops active TB during any time while on TPT and then died. Then lost to follow-up, TPT interrupted by person for 8 consecutive weeks or 2 months. Then we say lost to follow-up, and we locate the patient and restart the patient again on TPT, but before that we again rule out active tuberculosis in such patients. TPT discontinuation due to toxicity and not evaluated, maybe the patient records are lost, or maybe patient is transferred to another health facility. So this is the prescription pad which we are also using. This is patient ID. See, this is the patient ID, and then contact details like household contacts, and then we take all the data and screening and the date of TPT initiation and the coverage. So this is the prescription pad we maintain in our dot center. This is our TPT team with dot provider and one person from civil hospital. And the 3 gentlemen in the picture, they are from the Nikshe team. Basically, there are many private sector. This is basically both public and private sector project. And many private sector people have taken hand in hand with Government of India to achieve the pledge. So, Nikshe, Jeet project and TB Alert. These are few private sector organizations which are helping us. So this is Nikshe Setu. This is an app which the healthcare worker, the TPT team and the patient will load on their phone, and it is just like COVID, like app which helping them in locating the patient and taking care of their pills and everything. So this is Nikshe Setu. Setu is support to end tuberculosis. So this is the recognition by Ministry of Health and Family Welfare, TB Mukt Bharat pledge. So hoping to achieve this goal by 2025 and making India a better country to live. Thank you so much.
Something on trigger or test.
Pardon?
Some brief on the IGRA.
Sir, IGRA is what is equivalent to tuberculin skin testing. The only difference is in tuberculin skin testing we are giving intradermal injection like 5 units or 10 units of tuberculin protein depending upon the age of the patient and underlying condition, and IGRA is the immunological test which is done with the serum of the patient. But we look for the antibodies. It is believed that in immunologically active patients or immunologically reactive patients, basically we are looking for the delayed hypersensitivity reaction. We believe that patients who are exposed to tuberculosis, they will have some immunological reaction and they will have some antibodies in them, and this immunological test aims to detect those antibodies only in serum of the patient. So this is equivalent to skin testing. That is done over the skin and this is done in the serum. I am not getting you, sir.
Any change in the regime of ATT?
Pardon?
Any change in the regime of ATT treatment?
ATT in which category, sir, you are asking?
Just now in pulmonary, say, tuberculosis.
For primary tuberculosis?
Pulmonary
tuberculosis. Sir, basically we have to see whether the patient is in standard cases we are giving what is prescribed by the government of India, that is RHEZ for 2 months, and then for the next 4 months total is 180 days of ATT which is prescribed by the DOT center, and MDR TB that is depending upon whether the patient has rifampicin resistance, and then they have to go accordingly. So I didn't prepare that topic because it was not in the jurisdiction of this particular topic.
Thank you so much, Dr. Mohanji, for such an elaborative session. I have 2 questions. First, like you told us the 4 regimes that you follow for the TPT, and do we have any outcome data like one is better than the other? And the second is rifampicin is used.
Rifampicin is
used as one of the regime. So, like, what is your experience with these regimes? What kind do you really encounter hepatotoxicity? Because rifampicin we know it's a hepatotoxic, and I don't know about the rifampicin whether it's really that hepatotoxic as.
So actually that is the the 6 monthly INH regime is the most popular even at present also. So if I talk of my center, we have 50 patients at present on INH prophylaxis and we have just 5 patients. Actually it is all postulated by WHO, it is as per guidelines, and it is more for research actually, Dr. Prerna, that we are evaluating other regimes also. For their, and then I have already discussed that like in many patients one particular regime may be contraindicated, like INH in severe peripheral neuropathy or coexisting hepatic diseases, cirrhosis and all, it may be contraindicated. So in those patients rifampicin will be useful, and we recently received 5 boxes of rifampicin to start in our patients, and we started in 5 of our patients. But that is very, very recent, and we are still evaluating and the result, and we are moving as per directions which are given from the government of India. And I mean, it is a country-wide statistics which will keep on pouring in few months, and we will know which regime is better than the others, and we will have more strong and consolidated data, and then maybe we can talk more confidently about the efficacy of different other regimes which were postulated. Maybe it will take 6 months to 1 year. Coming to rifampicin, yes, rifampicin is very, very safe drug to be used in patients where INH safety is a question, like in patients who are suffering from chronic liver disease or cirrhosis patient, they can be given rifampicin. So the results are much, much more promising, and also it is a weekly dose, so that is another added benefit. So patient can always be evaluated for developing the deterioration in liver enzymes in patients with underlying liver diseases.
patients who are having CKD 5 or even early stages of CKD, if we are using levoflox for any other indications like for UTI or for respiratory indications, so we usually modify it, ma'am.
No, I think in my slides, the levofloxacin I have not mentioned in renal failure.
Ma'am, actually I read a slide in which you told that 6 days levoflox is recommended.
See, let me clarify. I am not very confident about this. Is one regime which is a very recent development, and I have not started in any of my patients so far. In a civil hospital also, I think maybe there they have started. We have levofloxacin tablets with us, 250 and 500. These two strengths are available, and at present 6 months of daily levofloxacin is restricted to patients who are the contacts of multi-drug resistant tuberculosis index case. So this levofloxacin is categorically reserved for those patients only.
But ma'am, what we do for the modification of levofloxacin is either we give it every 48 hourly, that means we give it for alternate day, even for other indications of.
Okay.
If we are using it in patients of any.
So maybe yes, definitely. Why not? Maybe when we have more and more work going on this particular point, yes, definitely we can have more data in near future.
Ma'am, we can reduce the dose by 50% and we can give it daily also.
Maybe yes. There are no set guidelines. See, I am telling you, levofloxacin and MDR-TB contact tracing is a very recent thing, and we haven't received any definite guidelines for this regime so far. I have mentioned it here just for the sake of documentation and completing my presentation. So, I can't really comment on the the extensive use and extended use of levofloxacin. So maybe next time when I come back, maybe I can answer more confidently.
Thank you very much. Further discussion can be held off stage. So I invite.
So our next speaker will be Dr. Prerna Goyal, Deputy MS and Senior Consultant Physician at RG Stone and Super Speciality Hospital, Ludhiana, and she has been the Vice President of WinCars, and she will deliver her talk on the topic renal denervation in resistant hypertension.
A very good afternoon to everyone. Thank you so much, Dr. Vitull, and all the organizers for giving me this opportunity. So I will be talking about renal denervation as a treatment modality for resistant hypertension. Though this strategy is quite new, but let's explore. The purpose of my talk will be twofold. First, to provide and to navigate through all the clinical evidence which we have for renal denervation. And the second is to provide you guidance about the clinical utility in our practice. Arterial hypertension, we know that is a big problem. According to International Society of Hypertension, the data is very old, that shows that in 2010 approximately 1.39 billion people were suffering. That accounts for approximately 31% of our adult population, and it accounts for more than 10 million of deaths at an annual rate. And majority of this population is from the low to middle income countries. Why we are so much worried about hypertension? Because we all know that systolic hypertension is one of the leading cause for cardiovascular mortality and morbidity. And it has been found that even 5 to 10 millimeter reduction in the systolic blood pressure can lead to improvement in our cardiovascular outcomes. That's why we have hundreds of pages of guidelines from different societies, be it European Society or American College or Asian Societies or Indian Society or International Society of Hypertension, and number of organizations and consensus statement, and they keep on revising the guidelines, what should be the targets to be achieved. But in spite of all these guidelines and with the availability of so many antihypertensive drugs in the real world, only BP control is achieved in suboptimal number of the patient, that is approximately 32.8% at a global level. This slide is very interesting. I introduced it because I was surprised to know that the treatment for the hypertension dates back to only 1950s. And before 1950s, it was considered an essential malady with almost no treatment. With the advent of thiazide diuretics and subsequently the whole range of the antihypertensive agents were added. Now coming to the definition of resistant hypertension, we all know resistant hypertension is labeled when the person is not having in control blood pressure as per the target with the use of 3 or more than 3 classes of antihypertensive agents, and one of them should be a diuretic. But resistant hypertension should be labeled after excluding pseudo-resistance, that is by ambulatory blood pressure monitoring. We have to rule out white coat hypertension, and the second is to rule out the secondary causes of the hypertension which may be causing a resistance pattern. The other important thing is the drug adherence and drug compliance. Many of the patients, they are not truly adherent to the drugs and they will not be taking in the proper dosage and combination. So that is one of the major reasons for the resistance. So after ruling all these conditions which can be contributing to the resistance, these patients should be evaluated and then labeled only after excluding these causes. Then coming to the refractory hypertension, which is another extreme phenotype as has been nominated and given terminology by American Association, when the patient's BP is not controlled even with the use of 5 or more than 5 groups of the antihypertensive agents, that is called as a refractory hypertension. But as the number of antihypertensive agents increase, maybe 1, 2, 3, 4, 5, we have seen that the rate of the compliance decreases. And also the hypertensive patients, they all have other comorbidities also, like statins and anti-oral hypoglycemic agents, so that will also add the pill burden. So in that way, with increasing doses and with increasing number of antihypertensive agents, the compliance is always poor. So this was about the antihypertensive agents. If the patient is not still controlled after following all the lifestyle modification and antihypertensive agents, so what will be the other options for these kind of the patients? So here comes the role of device-based therapies, and out of all the device-based therapies, renal denervation is one thing that is very close to the clinical application. And the basic idea of renal denervation originated from the fact that there is an evidence of increased sympathetic drive in a patients with a hypertension, especially in the patient with resistant hypertension, which is contributing to the pathophysiology. And it has been shown by the increase in the sympathetic nerve activity in various other metabolic conditions also, like we can see in hypertension, obesity, obstructive sleep apnea, congestive heart failure, metabolic syndrome and renal failure. And it has been found that as the intensity of the hypertension increases from mild to moderate to severe, the degree of sympathetic nerve activity also increases. So that's why we are now more focused on how to decrease the sympathetic overactivity to have a good blood pressure control. For that, the aim is to suppress the renal sympathetic nervous system. And if we look at the anatomy of the renal sympathetic nervous system, there are two pathways. One is the centrifugal pathway, which is going from the brainstem through the hypothalamus to the lateral column of the spinal cord, goes to the renal cortex, and then goes to the kidneys, where it supplies, where it affects the renal tubules, the renal vasculature, juxtaglomerular apparatus, and stimulation of these efferent fibers lead to release in the renin, increases the sodium ion reabsorption, causes vasoconstriction, and thus causing hypertension. The other pathway is the efferent pathway, which starts from the renal cortex, and the receptors are present in the pelvis in response to any kind of the painful stimulus, like suppose there is increase in the pressures or increase in the because of any renal colic, any pain, that leads to stimulation of these receptors. Efferent signals they get stimulated, and the pathway is from the cortex to the dorsal horn and then going to the brainstem, and which in turn further increases the efferent outflow of the sympathetic nervous system. And these afferent and efferent nerves, which are causing stimulation of the sympathetic drive, these nerves they are located along the course of the renal artery. So it's very important that these renal nerves are easily approachable if someone can intervene through the lumen of the renal artery. The renal artery originating from the aorta, if any kind of endovascular approach can be approached to ablate this renal nerve through the lumen of the renal artery, in that way we can decrease the sympathetic drive. And it is important to know that these renal nerve they course along the renal artery. But here is one difference. As the renal artery is starting from the aorta, the renal nerves are little farther away from the lumen, as you can see in this figure. They are further from the lumen in the proximal part, but as we go distally, in the distal part the renal nerves are going quite close to the lumen. So any kind of ablation procedure, if it has to be very much successful, we have to focus on the distal part of the renal artery where they are more close to the lumen and very easily accessible for the ablation. Apart from this, in 30% of the patients, we have found that there are accessory renal arteries, and these accessory renal arteries are also accompanied by the renal nerves. So, for renal denervation to be successful, not only the main artery but the accessory artery nerves, they had to be ablated so as to have a complete response. Now, the pathophysiology which has been described, how RDN leads to the better control. In fact, it leads to the 24-hour control of the blood pressure. It is because ablation of the efferent nerves decreases the central sympathetic activity, which is the leading cause for the morning BP surge. So in that way, it decreases the morning BP, and the ablation of the efferent nerves leads to more of sodium excretion, more of renal blood flow, and it changes. So the pattern changes from the non-dipper to the dipper pattern, which leads to the nocturnal BP control. So by controlling morning and early morning and nighttime BP and also in the daytime BP, it leads to the perfect 24-hour BP control. Now coming to the techniques how RDN is achieved. RDN can be done by three methods. One is the radiofrequency catheters, second is the ultravogue based, and the third is the chemical, that is with the alcohol mediated renal denervation. The first one to be introduced was the radiofrequency. In that, what was done, there was the catheters which was introduced to the renal artery lumen, and there is a transmission of the radiofrequency waves to ablate the nerves which are present in the adventitial layer of the renal artery. And this was the radiofrequency catheters. In these catheters, they were first introduced, and since their introduction and advent, there has been a remarkable change in the design. Initially, they used to be the flex catheter. Then came the spiral catheters, which was easy to navigate through the lumen. And the initial catheters were the unipolar, that is capable of ablating one point at a time. Then came the multipolar, having six electrodes, and the 4 electrodes, which were capable of ablating at multiple points at the same time. Then ultrasound based renal denervation is basically an ultrasound device which is mounted at the tip of the catheter, and this is placed inside a balloon, and inside the balloon there is a coolant fluid which circulates so as to prevent the injury to the endothelium of the renal artery. The ultrasonic waves ablate the renal nerves present in the adventitial layer, and the circulating fluid will prevent the endothelial injury. Alcohol mediated renal denervation, there are few trials, is still in evolving phase. The trials which are non-randomized, they have shown that there is reduction in blood pressure, but we need a more sham controlled trials, and they are already on way with the name of target on med and target off med trials, and the data is yet to be released. Now coming to the trials for the radiofrequency and ultrasound based RDN. Looking at these trials, we can divide all these trials. A lot of trials has been done since 2009. The first trial was Simplicity Hypertension 1 and Simplicity Hypertension 2. These were done with the first generation catheters, and they showed that there is a remarkable decrease in the office blood pressure to the range of like 15 to 20 millimeter of mercury at 3 to 6 months of intervals. And these trials, the drawback was that they were not randomized trials. They were not sham controlled trials. Then came the first sham control largest trial with the name of Simplicity Hypertension 3 trial. And in that trial, they showed that the remarkable reduction shown in the Simplicity 1 and 2 was not shown in the Simplicity 3 trial. A number of confounding factors was found that they said that adherence of the medication in all these trials was not addressed. Because the patient in the sham group were quite adherent, they were quite vigilant during the trial process, so that's why they had good control of the blood pressure in the sham group also. Another thing was the procedures and the centers where they have been done, the operators were not very much experienced. So a lot of procedural variability could have contributed to the unfavorable outcomes in Simplicity Hypertension 3 trials. So because of the conflicting results of 1 and 2 versus 3 trials, there had been a change in the trial design. For all the further trials, it made mandatory that should be sham controlled, and they kept the primary endpoint as ambulatory blood pressure, not the office blood pressure which was kept in 1, 2 and 3 trials, because ambulatory blood pressure has less day-to-day variability, and we know that ambulatory blood pressure is a more predictor of cardiovascular risk. So any trial who is showing the efficacy of RDN has to be taken as a primary endpoint as ambulatory blood pressure, not the office blood pressure. And also the treatment adherence part needs to be addressed, like if the patient is on medicines, whether they are regularly taking with the usage of like drug testing, molecular testing, biochemical testing of these drugs. And the other thing is to check off medication also. To have a subset of the patients off medication, maybe mild to moderate hypertension, who can be made without drugs for at least 4 weeks and 2 months, and to see the effect of RDN in drug-naive patients. So this was the change in the design, and then forwards later on we have a lot of trials with the main names of the spiral trials with the use of spiral catheters, and then we have radiance trials with the use of ultrasound based radio ablation. Spiral trials were basically divided into 2 major groups: spiral med-off and spiral med-on. Spiral med-off was done with the patients of antihypertensive agent to see the effect of RDN in the patients of antihypertensives. And spiral med-on trial was done on the patients who were resistant hypertension already on 3 or more drugs. The same way was the ultrasound based trials with the name of Radiance Solo without medication, Radiance 2 with the 2 medication, and Radiance Trio with the 3 medications. And these are the results of all these trials. It was remarkable to see that in all these trials, spiral hypertension known of spiral med, pivotal trial, Radiance Solo and Radiance Trio, there is a remarkable decrease in the office blood pressure as well as the 24-hour ambulatory blood pressure. But here you can see the degree of reduction in the blood pressure is to a modest degree. Like in office BP, it's only 9 to 10 millimeter, and 24-hour ambulatory BP is only 5 to 7 millimeter of mercury. But this trial has shown that in spite of the modest decrease in the blood pressure, these patient RDN can have a control in the blood pressure even without the medication. And all these trials, they also address the change in the medication post RDN, and it has been found that there was no increase in the medication dose post RDN. Apart from the daytime control in the blood pressure, the nighttime blood pressure and the early morning blood pressure were also decreased to a significant level in the RDN group as compared to the sham group. So they said that RDN demonstrated always on effect, which means that by the time when the antihypertensive effect goes off in the night time, in the early morning time, before the next dose of the other antihypertensive agents, the effect of the RDN is always on. That is, lasts for 24 hours a day. Looking at the medication burden at 1 year, 2 years and 3 years, the medication burden in terms of the number, in terms of the dosage and in terms of the classes was lesser in an RDN group as compared to the sham group. Now this was the Global Simplicity Registry, which gave a very long-term data of 3 years of RDN patient. This included almost 45 countries, 196 centers and 3,000 patients, and the largest database has been achieved. And they showed that the effect of the RDN not only lasted for 6 months, but as the years progressed, at 1 year, at 2 years and 3 years, there is a progressive fall in the blood pressure, whether it's office systolic blood pressure or ambulatory systolic blood pressure. So the effect of RDN is long lasting. It's not like the renal denervation effect goes after 1 year or 2 years. And in this registry, we analyzed a subgroup also, like the patients who were diabetic, the patients who were heart failure, and elderly patients more than 60 years, the patients having atrial fibrillation. All these patients, they had shown that there is a decrease or incremental effect in the lowering of the blood pressure subsequently. This is a recent data which has been published in Feb 2023, which shows a 9-year follow-up data of the RDN patients. And in fact, there was these RDN were the patients of the initial trials. They followed them, and they found that the BP reduction was even persistent at 9 years as compared to the baseline. And also they found that there was no detrimental effect on GFR. These patients, their kidney function test remains preserved even at 9 years. Now coming to the role of RDN in Asian population, we all know that Asians are more likely to have increased early morning BP and morning surges as compared to the black and whites. And also we know that Asians are more salt sensitive as well as they consume more salt as compared to the Western counterparts. And looking at the effect of the beta blockers, the Asians are twice as sensitive to beta blockers as compared to the whites. So it has been postulated that the Asian population, because of all these basic phenomena, they will be more responsive to RDN as compared to the Western counterparts. And if we look at the safety data, no patient in the spiral trials and one patient in the radiance trial had received a renal artery stent following RDN over 3 to 6 months of follow-up. The majority of the thrombosis or need for the stent occurred within 1 year of the procedure. And a meta-analysis showed that the pooled incidence rate of stent implantation following radiofrequency RDN was only 0.2%. And the global simplicity registry gives the safety data of up to 3 years, which shows that it is quite a safe procedure. So, in nutshell, the safety and efficacy of the RDN off-med trials showed that RDN is having a scientific evidence of efficacy in lowering the blood pressure. And if we look at on-med trials, that showed that the scientific evidence of efficacy is there in a clinical relevant population when the patient is already on the antihypertensive agents. And the global simplicity registry showed a large data set including multiple subgroups, providing a longer duration of the effect and longer duration of the safety also in a real world settings. Now, which patients are more likely to benefit from RDN? Because the effect of RDN is not homogeneous. If we see the success rate of RDN, only 4 out of the 5 patients will respond, 1 patient will not respond to the RDN. So, how to pick up the responders versus the non-responders? The various postulated theories are like, look at the individual's hypertensive pathophysiology. To what extent their sympathetic nervous system is contributing to their hypertension. If there is a more of sympathetic drive which is causing hypertension, so there may be chances that these patients will more respond to the RDN as compared to the others. Then looking at the individual's anatomy, what is the diameter of the renal artery? What are the number of accessory renal artery? How feasible is to reach the distal part to have a successful ablation? So all these will define whether the RDN will give you a good outcome or not. And the third is the operator's expertise. If the RDN is done at the center where the operational techniques and expertise is good, then obviously we can have a good successful data. So identification of the right candidate and trained operator is very important if we want to have a good response for the RDN. Now coming to the indications for the RDN is already discussed: uncontrolled hypertension or resistant hypertension, or if the patients having increased sympathetic drive. There is no such objective evidence how to calculate in which patients will be increased sympathetic drive. Either patient could having a resting high ambulatory heart rate. The data has shown that the heart rate of more than 74 beats per minute, these patients are more likely to respond to RDN as compared to the other person. Similarly, if you can measure the noradrenaline spillover in the kidneys, or if you can measure the renin levels. If the renin levels are high, this means these patients they are more likely to responsive to RDN. And the other things where the sympathetic overdrive is contributing to hypertension is the early morning hypertension, nocturnal hypertension. So these patients are going to have response with the RDN. The third one is the sleep apnea syndrome. Though it is a secondary cause of the hypertension, but in sleep apnea at the time of hypoxia in the night time, there is a neurogenic activation, so which is a kind of sympathetic activation and contributes to the nocturnal rise in the BP. And if the patient is having orthostatic hypertension, obese patient they have increased sympathetic drive with high heart rate, younger adults as compared to the elderly where arterial stiffness is on the higher side. So whether the increased arterial stiffness patients, they will be more responsive to RDN, that needs to be explored more. But in global simplicity registry, which is a 3-year data, they have shown that the patient even with the isolated systolic hypertension, they have a good response to the RDN. So with the success of all these trials of the RDN, so there has been a change in consensus statement. In 2018, European Society said that it should be used only for the research purpose. Then subsequently all the trial results came in 2021 and 2023. There has been a change in the guidelines. I will be highlighting only few consensus statements. Asian Consensus Panel recommendation says that RDN can be a way to reduce blood pressure, either alone or in combination with medication for the Asian population when the blood pressure targets are difficult to achieve, provided there is a proper procedural training and expertise is available. And always look at the patient's cardiovascular risk. Suppose uncontrolled hypertension with high cardiovascular risk, already having the cardiovascular factors, these patients should be prioritized for the RDN if they have uncontrolled blood pressure. Similarly, if the patient is having uncontrolled blood pressure in the form of nocturnal hypertension, masked hypertension, or some kind of intolerance or some kind of problem with the adherence, these patients should be prioritized. And always the patient preference should be kept in mind. Thai Hypertension Society says that refractory hypertension is class 1 recommendation. Resistant hypertension with high cardiovascular risk or high hypertension mediated end-organ damage, which is 2A recommendation. Resistant hypertension with evidence of drug resistance or drug adherence problems, 2B recommendation, but routine use for the blood pressure control is not recommended. This is a major change in the European Council statement in association with the percutaneous cardiovascular intervention, which says that RDN can be used as a treatment option in uncontrolled resistant hypertension, provided we are ruling out the true pseudo-resistance and in patients who have fully compliance with the lifestyle and medication. But that should be done in a shared decision-making process. The person should be informed about the risk and the benefits of the procedure, and also the patient's global cardiovascular risk and end organ damage should always be examined. Apart from this, these RDN trials, they have been indicated only in the persons with GFR more than 40. Below GFR 40, it is not recommended, and in the absence of evidence, it is not recommended to perform in kidney transplant recipients in severely impaired kidney function requiring hemodialysis, or the persons who are having untreated secondary hypertension and fibromuscular dysplasia. Patient education is very important. If they are going for RDN, they should be informed that they will not be free from antihypertensive patients. One RDN will be equivalent to free from one antihypertensive patients, but might be chances they will be having 1 or 2 drugs in the future. And the patient should expect to see the results not immediately after RDN. It will take time, maybe 4 to 6 weeks time for the effect to come, but they can be ensured that this effect will be more incremental as the time will pass. But still many open questions are there because it's a new modality. We don't have much data in India. How to identify a responder, how to pick the responders, which patients should undergo RDN, what are the procedural endpoints, how we can get to know that the RDN has been completed. This is the last slide. How to have more complete and circumferential ablation of the renal nerve. And RDN in patients with comorbidities, how reduction in blood pressure can be translated to have a good cardiovascular outcomes. Safety in patients with lesser GFR, and what is the effect of the RDN in Asian population, and the potential role of RDN in patients with other conditions having high sympathetic drive, like patients having obesity, metabolic syndrome, heart failure, atrial fibrillation, etc. And if one patient is unresponsive to RDN, whether there will be benefit of repeat RDN in the same procedure. And the other important thing is denervation of organs other than the kidneys. Will it be helpful for the resistant hypertension? So coming to my last slide, after years of decades of research, RDN has now come of age with good efficacy and safety data. It can be considered in patients with treatment-resistant hypertension and also in patients with masked hypertension, poorly-controlled early morning and nocturnal hypertension, poorly-controlled hypertension with high cardiovascular risk, especially with where we have issues of poor drug adherence and intolerance. So maybe in the coming times, RDN may earn the title of third option in the armamentarium of antihypertensive treatment in resistant uncontrolled hypertension, but in appropriately selected patients, and that too on shared decision basis as a part of structural treatment strategy, and that too in the hands of a well-trained interventionist. So at least RDN has gave a hope that after the medication, when nothing is left, this can be a tool which can get a recommendation in the coming guidelines too. Thank you so much for your patience for listening.
Thank you, ma'am. For the next speaker, I would like to announce Dr. Anurodh Dadarwal, Consultant Cardiologist at IV Hospital Bathinda, to deliver his talk on the topic Management of Heart Failure in 2023.
Very good afternoon to all of you, and once again I would like to express my gratitude to Organizing Committee of MAPICON 2023 for providing this wonderful opportunity on this prestigious platform. In upcoming time frame, I am going to discuss about the management of the heart failure in 2023, focusing on the fundamental points in general clinical practice along with the crucial insights from the latest trials about the pharmacotherapy and important points which we should remember for the optimum management of the heart failure, including the heart failure with reduced ejection fraction and the HUF-PUF, that is the heart failure with period ejection fraction. So, is there any universal definition of the heart failure? Answer is definitely yes. We are having the universal definition. Why it's important? Because many trials which are providing the robust data about the management of the heart failure have used this definition. So it is very substantial and established definition which we should incorporate in clinical practice in OPD, emergency and IPD. So it's defined clinically heart failure as presence of the two major factors, two major criteria, or one major criteria along with the two minor criteria, and at least elevation of the natriuretic peptide along or and elevated of the feeling pressure and the objective evidence of the cardiogenic pulmonary and systemic congestion. So what are the major criteria? These are orthopnea, elevated jugular venous pressure, hepatojugular reflux, bilateral crepitation, presence of the S3, that is gallop rhythm, which we don't evaluate nowadays, acute pulmonary edema and cardiomegaly. And minor criteria are dyspnea on aggression, nocturnal cough, ankle edema, tachycardia with heart rate more than 120, hepatomegaly and pre-effusion. These criteria was asked by my examiner during my DM exit exam, and there was a long viva only on these criteria. So coming to the classification of the heart failure. Heart failure is classified by all the guidelines, whether it is Canadian, European Society of Cardiology or ACC guidelines. They have classified heart failure on the basis of the ejection fraction. Why it is important? Why this classification is important? Because different pharmacotherapy are having different impact across the spectrum of the ejection fraction. So if the patient is having EF less than 40%, it is labeled as heart failure with reduced ejection fraction. If the EF is between 41 to 49, it is labeled as heart failure with mildly reduced ejection fraction, and if the patient is having EF more than 50%, it is labeled as HUF-PUF in short, that is heart failure with period ejection fraction. But kindly remember, this is not a static phenomenon, it is a dynamic process. Patient who is having HUF-REF, that is the heart failure with reduced ejection fraction, may fall in the another category over the time frame. Like if there is improvement of the ejection fraction, he should be labeled at the heart failure with the improved, that is IM improved ejection fraction. Why it is important? Because these patients should continue pharmacotherapy. Patient is coming in your OPD and he is having EF 60%, totally asymptomatic. Previously it was labeled as HUF-REF. The pharmacotherapy should be continued. It is having class 1 indication with level of evidence A in the guidelines. And on contrary, if the patient is having HUF-PUF, he may fall in the category of the HUF-REF or the upcoming time if there is deterioration of the ejection fraction. European Society of Cardiology is also recommending the incorporation of the objective evidence of the structural and or functional deterioration of the left ventricle in the echocardiogram. That is the elevated feeling pressure, which is labeled as E by E prime in echocardiogram, and evidence of the structural alteration. Structural criteria are the increased relative wall thickness, increased wall thickness, increased LV mass in male and female differently defined, and increase in the LAVI, that is the left atrial volume index. Along with that, there should be increase in the brain natriuretic peptide. That is the essential criteria for the defining the patient for the HUPF, that is the heart failure with pulmonary ejection fraction. So there is objective scale, because we are clinician, we always believe in the objective phenomenon rather than the subjective assessment. So there is score, that is the S2 PUF score. Why it was incorporated? Because many patients of the HUPF who are having the obesity are having the normal natriuretic peptide, and along with that they are having the comorbidity like the diabetic CKD, CLD, which can also cause the dyspnea as well as the congestion. So how will we differentiate whether the patient is really having a HUPF or patient is having the HUPF mimics or non-cardiac mimics? So that score definitely helps. It was incorporated by the European Society of the Cardiology. It includes 6 clinical variables which can easily be assessed in the OPD and the point of the care echocardiography. These 6 variables are having different weighted score. Total score is expanding from the 0 to 9. And these variables are the high BMI, patient is on 2 or more than 2 antihypertensive, atrial fibrillation, pulmonary hypertension defined as pulmonary systolic pressure more than 35 in echocardiogram, advanced age, and the feeling pressure, that is E by E prime more than 9 in echocardiogram. So if the score is less than 2, patient is having low likelihood for the HUPF despite the presence of the congestion and the edema. Every patient coming in congestion with edema in emergency OPD is not heart failure. And if the patient is having score more than 6, despite the absence of the elevation in natriuretic peptide, which may happen in the obese patient, in obesity anti-proBNP is decreased. You should always remember. And most of the HUPF patients are having the phenotype of the obesity along with the diabetic and metabolic syndrome. So if the score is more than 6, the patient is having highly likelihood for the HUPF. So this is the importance of this objective scale. So I think risk factor, as we all know, for the heart failure, reduced ejection fraction and the HUPF are just similar to the CAD. In addition, the volume overload condition, myocarditis, valvular heart disease, they are causing the HUPF. And in HUPF, in addition to the obesity, hypertension, diabetes and kidney disease, systemic inflammation in any form, pulmonary disease and advanced age is independent risk factor for the stiffness of the ventricle, which causes increased filling pressure and the pulmonary congestion or the systemic congestion. So if we will talk about the Indian perspective regarding the risk factor or the epidemiology of the heart failure, there is a famous study, that is Trivandrum Heart Failure Registry, which was published in 2015 in the European Journal of Heart Failure, and it has shown ischemic heart disease contributing about more than 2/3, that is 70% of the patients of the heart failure. The study was including about more than 1,000 patients of the PSC and CSC in the Kerala. And the DCMP was contributing about 12% of the patient, rheumatic heart disease only 7%. But I think in real world scenario, the data is not like the same, because in our clinical scenario, we are having the diabetes and hypertension major contributor, at least for the HUPF. So how we will stage the heart failure? We are staging into 4 stages, and there is new nomenclature for the stage A and B according to American College of Cardiology. That is the at risk for the heart failure. They are directly labeling a diabetic patient that he is at risk of the heart failure, only to address us to be aggressive for the medication, for the lifestyle modification, for the risk factor modification. So they are directly labeling stage A, and then stage B they are labeling as a pre-heart failure. So it should be remembered, they are directly labeling pre-heart failure. So what is stage A? Any patient who are having a risk factor of the heart failure, for example, hypertension, uncontrolled diabetes, patient is having coronary artery disease without normal, with normal LV function, without any structural deterioration in the echocardiogram. So all of these patients are stage A. Any patient coming in your OPD with hypertension, he is having stage A of the heart failure. Stage B, if the patient develops structural alteration in the LV. What are the structural alteration? It's not always the decrease in the EF. Patient may have the increase in the LV mass, increase in the LV thickness, and increase in the LV volume index, which causing the atrial fibrillation and which prescriptively causing the increased hospitalization and the heart failure. So if there is any structural abnormality without any symptom, that should be labeled at stage B, and new nomenclature is pre-heart failure stage. Stage C we always encounter in day-to-day practice, that is the symptomatic heart failure. And stage D is advanced heart failure. If the stage C patient is not responding to GDMT and he is frequently hospitalized over the last months, and he is having persisting or worsening of the symptom, then it should be labeled as stage D heart failure, and it should be referred for heart failure specialist for the additional device therapy and the newer advance in pharmacotherapy and the proper evaluation of the etiology. That is very important. This is very interesting trial, that is STOP HF trial. A patient coming in the OPD of the risk for the heart failure, that is patient is having risk factor, they have measured the BNP level. If the patient is having elevated BNP level, then they advise them to come frequently in the OPD to aggressively modify the risk factor lifestyle modification. And what they have found by this strategy, they have reduced the incidence of the heart failure in comparison to usual care that we do in the day-to-day practice. So that's the important to targeting the population in stage A and B. So stage C heart failure is also not a static phenomenon, it's a dynamic process. Patient may have improvement of the symptom. Now we see in the advancement of the pharmacotherapy as well as device therapy. So if the patient is having complete resolution of the symptom and there is normalization of the EF, patient may be labeled as the reverse remodeling process. And there may be the worsening of the symptom for which we should refer the patient in the heart failure specialist clinic. In upcoming few slides, I will focus on the general practice tips which are very fundamental for the etiopathogenesis and which should identify the patient which we can progress for the stage C or D, and also we can reverse the process of the heart failure. So any patient who is coming in your OPD with the heart failure, we should always search out for the advancement of the stage, because we should focus, we should aggressively therapy, and we should be very cautious for the frequent OPD visit for the up titration of the GDP and the optimal GDP. We should do the 3-generation family history for the patient of the specifically non-ischemic cardiomyopathy, that is dilated cardiomyopathy. Because genetic variants have been implicated in 25 to 40% of the patient who are having the family history, and interestingly, it is also present in 10 to 30% of the patient without recognized family history. Specific cause of the heart failure should be evaluated by additional laboratory investigation where the patient is in OPD or IPD. And besides the CBC, RFT, electrolytes, LFT, we should also do the iron studies and the thyroid function test in all these patients, because they may provide you clue about the specific etiology. Why this is important? Because all of this etiology of the heart failure can be totally reversed with the disease specific therapy, which we definitely we will not use in the patient normally in the heart failure. So it is important to identify all these diseases. We are having the light chain assay for the amyloid heart disease. We are having the iron profile for the hemochromatosis. We are having the diagnostic MRI for the sarcoidosis. So cardiac MRI is having a very crucial role not only for the diagnosis of the specific disease phenotype but also for the prognosis and the risk stratification, specifically in the HCM, hypertrophic cardiomyopathy patient. By T1, T2 sequencing and the specific software protocol of the image acquisition along with the lead gadolinium enhancement, we can specifically diagnose, directly we can diagnose some disease phenotype like the sarcoidosis, in which we will find the subepicardial enhancement, patch enhancement, and amyloidosis, there will be the intraarterial thickening along with the valvular leaflet thickening, and there will be the subendocardial enhancement sparing the apex. And it will also helpful to diagnose the myocarditis as we have done in the COVID era. So are we having the focus strategy for the stage A and B? Yes, definitely. We are having very limited but definitely therapy for the stage A and B to halt the progression for the stage C and D. We are having the SGLT2 inhibitor, which is now having the labeling of class 1 indication with level of evidence A for the prevention of the incidence of the heart failure, specifically in diabetic patients. Optimum control of the BP, proper exercise, salt restriction should be done in the stage A. And in stage B, that is the patient who are having structural alteration of the LV in echocardiogram without any symptom. That is the asymptomatic stage. We can incorporate RAS inhibitor. ARNI is not approved right now for this, and I hope it will be approved in future. Beta blocker and definitely ICD. If the patient is having EF less than 30% without symptom, he or she is having indication of the ICD. And genetic counseling and testing should be done to identify the genetic variants, not only for the patient but also for the family members. It may be a matter of survival even. So we should do the early incorporation of the ICD in all these poorly prognosed patients. So this slide is giving overview, that is bird's eye view of the management of the stage C heart failure. There are 4 fundamental pillars of the management of the stage C heart failure, which are having class 1 indication after the robust data of the various pragmatic and the mega trials. And what are these 4 pillars? One is the RAS inhibitor in the form of the ARB or ACE inhibitor, and definitely the ARNI. Second is the beta blocker. Third one is the mineralocorticoid receptor antagonist, that is the eplerenone or the spironolactone, and fourth is the SGLT2 inhibitor. Diuretic is given not for the mortality reduction but for the morbidity reduction for decongestion as a class 1 indication, and that is approved as for the loop diuretics. If after incorporation of this therapy, patient is having persistent of the symptom, then he should be evaluated for the device therapy, that is the ICT and the CRT. And one drug is also approved with the class 1 indication, surprisingly, that is the hydrogen and dinitrate fixed dose combination in the stage C of the heart failure. If the patient is not responding or we are not able to incorporate all the GDMT, then we can start this. Although it was approved for the ethnicity of the African American, but we cardiologists have evaluated this in also our Indian population, and Asian are having very good response to all these drugs. There are also additional therapy which has been introduced in recent months for the stage C heart failure who are not responding to GDMT. And if patient still not responding, then we should refer the patient for the heart failure specialist for the evaluation of the mechanical circulation support and the cardiac transplant. So what are the additional therapy for stage C patient who are not responding to the classical fundamental pillars of the GDMT? These are the ivabradine, which is having class 2 indication, provided that patient should be in sinus rhythm with the heart rate of more than 70. And all other drugs, that is the vericiguat, digoxin, and polyunsaturated fatty acid and potassium binders, which is recently incorporated, are having class 2B indication. In the upcoming slide, I will discuss about the pharmacotherapy with the special insights from the recent trials. So loop diuretics are definitely having class 1 indication for the successful decongestion, because congestion is associated not only for the morbidity but also for the mortality of the patients. So successful and complete decongestion is mandatory before discharge the patient of any patient who is admitted with the acutely decompensated heart failure. And if patient is not responding to the sole therapy of the loop diuretics, we can add thiazide or thiazide-like diuretics. So this is the question which is often asked by the physician, which is the more efficacious drug, whether it is furosemide or torsemide. Usually torsemide is having the community-based preference for the loop diuretics. But we are having now the trial, that is the Transform HF trial, recently published in JAMA in 2023. So it's not having any difference in terms of the all-cause mortality. But the interpretation of the trial should be carefully monitored, because many of the patients are having many of the patients are not having good adherence to the therapy. There were robust crossover of the patients, and data was not sufficient for the follow-up. This is the interesting trial, that is the adverse study, which was published in NAGM in 2022. They have added acetazolamide 500 mg once a day IV form along with the loop diuretics for the decongestion, and they have found in comparison to placebo there was successful and complete decongestion in shorter duration during hospitalization, and there was no increased incidence of the metabolic acidosis or the hypokalemia, which was expected. Contrary, there was no increased incidence of the metabolic side effect. In contrary, there is the chlorotic trial which is recently published in 2023 in European Heart Journal, in which they have added hydrochlorothiazide along with the loop diuretics. They have found definitely and obviously the successful decongestion, but along with that, there was also increased incidence of the metabolic side effect in the form of the hypokalemia and rise in serum creatinine. So this is a very important slide and also the interesting, because as the patient is admitted with the edema and dyspnea, BP is okay, 90 or 100, heart rate is high, we usually discontinue GDMT. GDMT should not be discontinued until unless patient is having the hemodynamic compromise. And if there may be rise of the serum creatinine or altered renal function with the incorporation of the GDMT, there should not be worry about that. We should continue this, and we should start it as soon as possible, as evidenced by the trial. Few words about specific pharmacotherapy. Mineralocorticoid receptor antagonist should be used in a patient of the EGFR more than 30 with the potassium less than 5. And ARB and ACE inhibitor should be replaced with the ARNI. It's having class 1 indication and it can be started de novo. De novo means if any patient coming to the OPD or IPD with the heart failure, we can directly start ARNI without background therapy of the RAS inhibitor. And they should be started as soon as possible as per result of the transition and pioneer HF trial. But the Paradise MI trial is giving conflicting results because they have evaluated the superiority of the ARNI in comparison to Ramipril, that is ACE inhibitor, in the post-MI patient, immediately post-MI field. So it was the good trial with good population, with appropriate population, and the target was also achieved in sufficient number, but still the results were contrary. That is, it was not superior than Ramipril. But Roxana Meharan did very interesting post-hoc analysis. She found there was reduction in the coronary events by 14%. So it may provide future perspective for the ARNI in the use of the post-MI patient for prevention of the coronary events. After the result of the DEPA-HF and EMPEROR reduced trial, SGLT2 is having class 1 indication irrespective of the diabetic status. So whether patient is diabetic or non-diabetic, he should be prescribed for SGLT2 inhibitor in the heart failure and also for the prevention of the heart failure. Impulse and Solace trial has provided the robust data for the early institution of the SGLT2 inhibitor during the hospitalization phase even or after the post-discharge. So this is the interesting trial, Victoria trial. It was having the advanced heart failure stage patients, advanced NYHA class, advanced age in comparison to Paradigm HF trial patient population. So these patients are very moribund and we can start the vericiguate. This is the cyclic one-lead cyclase stimulator which is having the property just like nitric oxide, and it will increase the level of the cyclic GMP which is beneficial for the myocardial dysfunction as well as vascular dysfunction. So it has provided in decreased incidence of the heart failure hospitalization in the patient of the advanced stage of the heart failure. So if patient is not responding to GDMT, this is the good weapon against advanced stage. As we have discussed, genetic testing is important. It's having class 2 labeling and the endomyocardial biopsy can be done provided that it's going to influence the treatment, just like giant cell myocarditis which is having very poor prognosis. These are some clues in OPD finding, or by the simple testing you can define the phenotypes which should be evaluated further by the family history and genetic testing. Few words about the BNP and anti-pro-BNP. These are important not only for the diagnosis but also for the prognostication in the early admission phase as well as just before the discharge. And there are many known cardiac causes of elevation of the BNP. These are advanced age, anemia, renal failure, obstructive sleep apnea, pulmonea, basal pulmonea, artery hypertension, sepsis and burns. So iron deficiency irrespective of the anemia. There may be state that hemoglobin is normal but patient is still having iron deficiency. That is defined by the ferritin less than 300 microgram per deciliter and the transferrin saturation less than 20%. All these patients should be replaced with the iron by IV iron therapy in the heart failure patients. For obstructive sleep apnea, CPAP is having class 2 indication for prevention of the hospitalization of the heart failure, and all the patients of the HFrEF, that is the reduced ejection fraction patients, should be vaccinated for the infection of the influenza and the pneumococcal. Not only decrease the morbidity but also the mortality. So it's having class 2 indication. There are robust data by the many trials which are incorporating now the use of the IV iron for the treatment of the iron deficiency irrespective of the hemoglobin level, which is I think very common in our Indian subcontinent. So we have discussed about the hydrogen isosorbic dinitrate. These are the new incorporation about the potassium binders. These are act as a luminal sink in the colon. They will extract the potassium, bind it, and they will excrete it through the stool. So what is the importance of this? When we are incorporating RAS inhibitor or MRA, there will be rise in the serum creatinine along with the potassium and we will stop it, and patient will be deviated from the beneficial effect of the fundamental pillars. So it will definitely going to help us. In pregnancy, we should avoid the RAS inhibitor, MRA, ivabradine, SGLT2 inhibitor and vericiguate. So all the fundamental pillars except the beta blocker are not approved for the pregnancy. Among the beta blocker, metoprolol is the safest drug to use in pregnancy. And for breastfeeding and lactating mothers, we can use the ARNI, and safest drugs are the captopril and the enalapril. They can be used in lactating mothers. So ICD is having class 1 indication if the EF is less than 35% and patient is symptomatic. If patient is asymptomatic post-MI after 40 days, EF is still less than 30%. It's having class 1 indication. ICD means intracardiac defibrillator. And it will prevent the all-cause mortality. That's why it's having class 1 indication in all the guidelines. CRT means cardiac resynchronization therapy, which is instituted for the patient who are having the desynchronized contraction of the ventricles, because it will synchronize the contraction of the ventricles. Just only 2 slides. So few words about the mitral clip. It is advocated for the patient who are having mitral regurgitation secondary to the dilated left ventricles. So it will produce the clip between the 2 leaflets of the mitral leaflet, and it will iatrogenic produce mitral stenosis for prevention of the mitral regurgitation. And it's surprisingly having class 1 indication. So patient who is on GDMT with the dilated LV, who usually we see in the echo, patient is having severe MR, he can be sent for the mitral clip, because the result of the COP trial have shown, because it will decrease the all-cause mortality beyond the cardiovascular death. Just like mitral clip, we are also having the reduction of the tricuspid regurgitation with the transcatheter therapy, and it will incorporate in the future guidelines. I will just introduce 2 to 3 slides of the new recommendation in 2023 by the European Society of the Cardiology based on the recent trials. So what are the recommendations? SGLT2 inhibitor is now having class 1 indications for the prevention of the heart failure in the heart failure with pulmonary ejection fraction and heart failure with mild reduced ejection fraction. Now it's labeled as class 1 indications. And there should be up titration as well as early institution of the GDMT in the patient within 2 months after discharge or just before discharge, because it will decrease all-cause mortality. Guidelines are giving only class 1 indication when the trial, single trial or main trial is providing the all-cause mortality reduction. So it is very important strategy. And last but not least, Finninon, which is having very beneficial effects in the terms of the renal progression of the disease in the DKD patient and also in the terms of the cardiovascular outcome. So on the basis of these 2 trials, ESC has advocated it as a class 1 indication with level of evidence A for the prevention of the heart failure. And iron replacement is also upgraded from class 2A to class 1 indication. And these are some mimics which we should remember when we are interpreting the patient on day-to-day practice. So, finalizing the take-home message for the general practitioner, we should implement all the 4 pillars of the fundamental therapy for the heart failure with reduced ejection fraction. And if the patient has improved EF, even then we should continue that pharmacotherapy for the prevention of the mortality and morbidity. There are new recommendations regarding the amyloid heart disease, and the evidence supporting that increased feeling pressure should be essential criteria for labeling a patient of the HUF-PUF if the patient is having EF more than 40%. And there are new guidelines for the primary prevention as well as for the iron deficiency, CAD and atrial fibrillation. Thank you very much for patientful listening.
Thank you so much, sir. For the next talk, I would like to invite Dr. Arun Bansal from Civil Hospital Bathinda for his talk on suicide in young, causes and prevention.
So this is very important topic given the increased prevalence of suicide among young. So I invite Dr. Arun to talk on this rather important topic. Thank you.
Good afternoon. At first I would like to thank MAPICON organizers for giving me a chance to speak on a pressing issue that affects our society profoundly, suicide among the youth. It's a topic that may be uncomfortable to talk upon, but it's crucial that we discuss it openly and honestly, because only then we can work together to prevent. Suicide is 100% preventable. Suicide is a global public health concern, and young people are particularly vulnerable in India, where we have a youth-rich population. The problem is especially acute. According to NCRB, suicide is a leading cause of death among young Indians aged 15 to 39 years. This statistic highlights the urgent need to address this issue in our country. The NCRB released its finding on suicide rates in our country, recorded a total of 1,64,033 suicides in 2021, representing a 7.2% increase compared to 2020. This marked the highest number of suicides ever reported since the NCRB begins documenting such a data in 1967. In terms of suicide rates per lakh of population, India reported a rate of 12, indicating a 6.2% increase in 2021 compared to 2020. The states with highest number of reported suicides were Maharashtra, Tamil Nadu, Madhya Pradesh, West Bengal and Karnataka, collectively accounting for 50.4% of all suicides in the country. Family problems and illness emerged as the predominant causes of suicides as outlined in the report. Notably, the age groups of 18 to under 30 years and 30 to under 45 years comprised 34.5% and 31.7% of total suicides respectively, with a significant number of these individuals being students. In 2021, a staggering approximately 13,000 students lost their lives to suicide. The NCRB reports highlighted again family issues as a major factor in 33.6% of all suicide cases. Our neighbouring state, Himachal Pradesh, witnessed a concerning rise in suicide with the 46.7% increase from 2019 to 2020. It ranks as the second leading cause of death among individuals 15 to 25 years with unfulfilled expectations and ambitions, leading to impulsive behaviors and self-harm. Drug-related issues and relationship problems were identified as other significant factors contributing to suicide. Furthermore, the report highlighted that self-harming behavior and suicide thoughts and attempts reached an all-time high, with the notable presence of engineers, doctors, and PhD students among those affected. In medical colleges, despite the presence of psychology and psychiatry departments, students often struggle to prioritize their physical and mental health due to demanding schedules, long shifts, and challenges of hostel life. The issue is exacerbated by the incidence of ragging in professional institutions, despite a Supreme Court ban on such practice. Reported suicide attempt figures in India may not be entirely accurate due to local police discretion influencing the classification of death as suicide or otherwise, despite the decriminalization of suicide under the Mental Health Care Act. Furthermore, a significant number of students hesitate to report suicide attempts due to the pervasive feeling of guilt, shame, and fear of social stigma. This underscores the urgent need for a more empathetic and stigma-free approach to mental health care, particularly among students. Alongside legal reforms, comprehensive awareness campaigns, robust mental health support system, and educational initiatives are imperative. Factors underlying student suicide in India: academic pressure, high expectations, competitions, lack of mental health support, stigma surrounding mental health, peer pressure, in-person or cyberbullying, relationship issues, economic factors, lack of coping skills, substance abuse, pressure to choose career path. Let me brief up with some predominant causes of suicide among youths. Academic pressure. As you know, in India, pressure to perform well in board exams and entrance tests is immense, leading some to despair when they fall short of these expectations. Unemployment. High rates of youth unemployment in India can lead to feeling of hopelessness and financial instability. Arranged marriages. Cultural norms still in India often lead to arranged marriages. When young people feel pressured into marriages, they are not ready for it. It can result in emotional distress and sometimes even suicide. Gender issues. Gender discrimination and violence against women persist in many parts of India. Young women facing discrimination or violence may see suicide as their only escape from intolerable situations. Lack of mental health awareness. Stigma surrounding mental health is still widespread in India. Urban-rural divide. There is significant difference in availability of mental health resources and awareness between urban and rural areas. Now I am going to discuss some past incidents that have occurred in renowned institutions and cities. In the period since 2018, 33 students have tragically taken their own lives within the Indian Institute of Technologies. It's important to note that a higher proportion of self-harm cases occurs in the broader educational context in India. Suicide prevention should be ingrained not only in these institutions but also within the families of teachers, non-teaching staff, and also associated stakeholders across the educational sector in India. Raising awareness and fostering a culture of mental health and well-being are essential for creating a safer environment for students. Moving further, let's talk about quota. In a tragic turn of events, 2 NEET aspirants have lost their lives to suicide in a single day in Kota, and a staggering total of 22 deaths in a year. And the same story was published in the Tribune with the headline of Kota Deaths, Collective Efforts Need of Hour. And as per the opinion of Professor Dr. Vitull Gupta, which I totally agree, question is why Kota factory is in existence. I strongly feel that gradually over the years, classroom teaching has lost its importance and coaching culture has taken over because of increasing dependence on entrance exam. Moreover, rising aspiration, shrinking opportunities, neoliberal agenda, and more importantly, coaching culture and examination system has failed to judge the student real capabilities. Intelligence, innovation, analytic skills, knowledge, creativity, self-learning, and students' free will or genuine quality or ability, but has increased rat race to clear entrance examination. Again, pressure of perfection. My colleague from South has written in the paper, over the past 3 years, more than 26,000 have committed suicide across India. Majority of student suicides are caused by underlying suicide factors such as wise choices. Emotional turbulence. They may react strongly to situations, have trouble regulating their emotions, which can sometimes lead to mood swings. Influence of limbic system. The limbic system, the part of the brain associated with emotion and impulses, is in full gear during adolescence. This can result in teenagers making decisions based on the feelings and desires rather than well thought out plans. Peer pressure and social media. Teenagers are highly susceptible to peer pressure, which can be exacerbated by the influence of social media like platforms like Facebook, Instagram, etc. Copycat behavior. Adolescents often mimic the behaviors and attitudes of their peers. Emotion perceptions. Teenagers may perceive their emotions as being more permanent and significant than they actually are. Performance and perfection. Teenagers face increasing demand to perform well academically, athletically, socially. This pressure to excel can lead to stress and anxiety. Difficulty with future thinking. This can sometimes lead to feeling of hopelessness because they may not see their path clear ahead or understand how their current choices can affect their long-term goal. In summary, adolescence is a period of immense change both in the brain and in emotional development. It's marked by increased susceptibility to the peer influences, challenges with managing emotions, and a growing awareness of societal expectation. Understanding these factors is crucial for supporting and guiding teenagers through these transformative phases of life. Now, media plays a very important role in suicide prevention and suicide reporting. The negative role of media in suicide reporting can have a serious consequences. Contagion effect. Irresponsible reporting of suicide can lead to a contagion effect, wherever vulnerable individuals are more likely to attempt suicide or complete suicide after being exposed to coverage, referred to as copycat suicide. Glamorization, graphic or romanticized portrayal of suicide in media can glamorize the act, making it seem like a valid solution to a problem or a way to gain attention and sympathy. Detailed method describing specific suicide method in detail can inadvertently provide individuals with information they may use to harm themselves, especially if they are already in a vulnerable stage. Stigmatization, misrepresenting or stigmatization suicide in media coverage can deter individuals for seeking help or disclosing their own struggles due to fear of judgments. Simplification of complex issues. Media often oversimplifies the causes of suicide, attributing it to a single factor when in reality it is a complex interplay of multiple factors such as mental health issues, social pressures, and life circumstances. Sensational headline and images can grab attention but may not accurately represent the complexities of suicide or contribute to a better understanding of the issue. Lack of prevention information. Media reports often focus on event itself, providing limited information about mental health resources. Celebrity suicide. Highly publicized suicide of celebrities attract extensive media coverage, like represents the suicide of celebrity Sushant Singh Rajput. Inaccurate reporting, misreporting facts, failing to adhere to responsible reporting guidelines, ethical concern. In summary, the negative role of media in suicide reporting can contribute to the contagion effect, stigmatization, and increased risk of suicide among vulnerable individuals. It is essential for media outlets to adopt responsible reporting practices and collaborate with mental health experts to address this critical public health issue responsibly and ethically. And in assessment of suicidal risk, there are 3 stages of suicide: ideation, threatening, and attempting. And every person who attempts a suicide always gives a clue. It can be verbal, situational, or behavioral. And behavioral clues are giving away his valuable possessions, writing suicidal note, new purchase of weapons, non-compliant with treatment, if he is on psychiatric treatment, risk-taking behavior. Verbal clues: I can't go anymore. I wish I was never born. I wish I were dead. I won't need this anymore. My parents won't have to worry about me anymore. Everyone would be better off. I was dead. Nobody cared if I live or die. Situational clue: prior suicidal attempt, serious illness, rapid decline in functioning, social isolation. Next, suicidal inquiry. This is detailed psychiatric evaluation. It is vital to ask about suicidal risk and document the answers. The key is to ask questions in a clear, empathetic, and non-judgmental way. Instead of saying, "You are not thinking of suicide, are you?" It's better to ask, "Have you ever felt so low that you wished you were not there?" For patients dealing with issues like psychosis or depression, we should dig deeper into their feelings and thoughts to understand their emotional well-being better. This helps us provide the right support and care. When a patient denies having suicidal thought, we should consider whether they might be saying this because they think it's what we want to hear. If a doctor is seriously concerned that patient may not be telling the whole truth about their suicidal thoughts, they might need to talk to the patient's family, even without the patient's permission, to get a better understanding of the situation. In cases where a doctor believes the patient needs immediate hospitalization, it's crucial to have a responsible adult like a nurse, the patient's spouse, or a parent stay with the patient until they are admitted to ensure their safety. Our top priority is the patient's well-being, and taking these steps is essential to keep them safe and also to protect the doctor from potential legal issues, self-harm, or suicide were to occur. Factors that safeguard against suicide. Restricted access to lethal means. Reducing access to lethal methods of self-harm such as firearms pesticides or medication, healthy lifestyle choices, positive media and role models, empowerment, life skill trainings, sense of belongings, prevention, risk assessment, diagnosis of suicidal behavior are key to decreasing suicidal rates. Universal intervention, again, restricting access to means, media strategies for better reporting, suicide awareness campaigning, selective interventions, pharmacological interventions, general practitioner educational programs, development of treatment guidelines, indicating interventions or psychological interventions, social approaches, crisis service helplines. I am not going to detail. Intervention for suicidal ideation and suicidal behavior. In psychosocial intervention, cognitive behavioral therapies, dialectical behavioral therapies, and pharmacological interventions are lithium, ketamine, SSRIs. Now, this is very important part of this seminar. Preventing teen suicide, a guide for parent. Teen suicide is a deeply distressing issue, but it is preventable. Vigilance and awareness. Stay vigilant by actively monitoring your teens' peer group and their online activities, including social media. Quality time and engagement. Spend quality time with your teen and engage in their social and sports activities, showing support for their interests. Unconditional love and acceptance. Tell your teenagers that you love them, and not just with words, but through actions and gestures that demonstrate your affection. Balanced expectations. Encourage them to pursue their passions and interests. Communication is key. Maintain open and honest communication with your teen. Encourage them to talk about their thoughts and emotions. Setting boundaries. Be clear and consistent when setting boundaries, especially concerning drugs and alcohol use. Access to mental health services. Recognize the signs of emotional distress and mental health issues in your teenagers. By following these practices, you can create a nurturing and supportive environment for your teenager, significantly reducing their risk of succumbing to the pressure and challenges that can lead to teen suicide. Remember, your involvement, understanding, and love can make a profound difference in their life and well-being. Key components for ideal educational environment. Optimal learning conditions, ensuring a conducive teaching learning environment where students are motivated, engaged, and supported in their educational journey. Fair and effective assessment, implementing assessment systems that are fair, transparent, and geared toward gauging true understanding rather than rote memorization. Equity and inclusion, granting that every student is treated equitably, irrespective of background or circumstances, fostering an inclusive community of learners. Diverse activities, providing a wide array of activities both in academics and co-curricular activities to help students discover their talents and passions. Real-world connections, linking education with society and ecology through immersive experiences such as field training, job placements, educational tours, and summer internships. Student service centers, establishment of student service centers across institutions. This 5T model for mental health education in schools, talking about mental health, providing appropriate training for teachers and staff, incorporating mental health into teaching, providing helpful tools for students, taking care of teachers. In embracing these principles, we can lay the foundation for an educational system that not only impart knowledge but also equips students with skills, values, experiences they need to thrive in an ever-changing world. India has introduced its first National Suicide Prevention Helpline, KIRN, under the purview of Ministry of Social Justice and Empowerment. Accessible via the toll-free helpline number operates around the clock. Additionally, on World Mental Health Day last year, India launched the Tele-Manas program, officially known as National Tele-Mental Health Program. This ambitious initiative is designed to extend mental health services to individuals nationwide. Tele-Manas endeavors to establish tele-mental health facilities in each of the India state and union territories. decriminalizing attempted suicide. Prior to the enactment of Mental Health Care Act in 2017, attempted suicide was deemed a punishable offence under Section 309 of Indian Penal Code. However, the Mental Health Care Act effectively decriminalized suicide by introducing a significant exception to Section 309. Now, any person who attempts to commit suicide shall be presumed to have severe stress and shall not be tried and punished under the said code. At the end, I would like to conclude with that the suicide among youth is a complex issue with multifaceted causes. However, by raising awareness, providing mental health support, and implementing prevention strategies, we can work toward reducing its incidence. Let's create a society where young people feel understood, supported, and valued, ensuring that they can face life's challenges with hope and resilience. Remember, if you or someone you know is struggling with the thoughts of suicide, please seek help from a mental health professional or a helpline. You are not alone and there is a help available. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Madan Mohan, MD Medicine from Vitull, for his talk on the topic, Approach to a Patient of Acute Febrile Illness.
This is by far the greatest, by far the most terriblest fever. I'll start my talk with a case scenario. We had a 27-year-old boy who presented with a history of fever and headache for 2 days and had one episode of generalized tonic-clonic seizures and loss of consciousness 1 hour before presenting to the hospital. On examination, he was unconscious with minimal response to the painful stimuli. His blood pressure was 180 by 100, temperature of 101, and he had evidence of oral bleed due to the tongue bite. There was no pallor, icterus, cyanosis, scrubbing or lymphadenopathy. On CNS examination, his meningeal signs were negative. His pupils were bilaterally equally detecting to the light. There was no focal neurological deficit. His planters were bilaterally mute, and all the systemic examination was normal. A diagnosis of febrile encephalopathy with recent onset of seizures was made. He was started on supportive treatment, and with supportive treatment, his general condition started improving, and he was sent for MR examination as he has localizing signs in the form of seizures. Acute fever, if we talk of acute fever, we have two types of patients in our practice. One are the patients in which we have some localizing sign and symptoms pertaining to a particular system like respiratory system, gastrointestinal tract, urinary tract, skin and soft tissue infection and so on. While the other category is the most difficult to evaluate is acute undifferentiated febrile illness. So I will be more concentrating on acute undifferentiated febrile illness, which is defined as any fever of more than 38.3 degrees centigrade, lasting for more than 2 days and up to 2 weeks. There are a lot of guidelines for management of a fever of unknown reason, which we call as PUO. But there are very few guidelines for management of acute febrile illness. Recently, Indian Society of Critical Care Medicine and the Association of Physicians of India have recommended some guidelines and given us a roadmap for the evaluation of acute undifferentiated fever. I will be going according to that. So they have advised a syndromic approach and a stepwise care to patients of acute undifferentiated febrile illness. The first step I will be taking will be patient profile and to assess disease severity, then the localizing signs, and then identifying the clinical syndrome, and after that perform the first line and confirmatory test and initiate empirical therapy, and then after the diagnosis is made is about the specific therapy. So the patient's profile and disease severity, we should see the geographical area from where patient is belonging, his comorbidities like associated cardiovascular disease, diabetes, hypertension, and history of drugs, and if there is any immunosuppressive status or not. Immediately on presentation of the patient, we should see for some red flag signs whether the patient requires hospitalization or he can be treated on OPD basis. The important red flag signs are severe prostration, respiratory rate of more than 22, or patient is hypoxic with saturation less than 92. He has a hypotension, BP less than 90/60. He has altered mental status or presence of seizure, severe persistent vomiting, pallor, jaundice, or if there is a bleeding from any side. At this very stage, we should look for the sepsis, because sepsis every minute matters in the management of sepsis. Earlier we used to define sepsis with the search criteria and a localized site of infection. Now it has been taken over by the SOFA score. SOFA is Sequential Organ Failure Assessment Score, which is quite cumbersome to evaluate. So they have suggested is a quick SOFA score in which we take three things: the respiratory rate of more than 22, a GCS less than 13, and systolic blood pressure less than 90, along with the presence of a site of a localized infection. And if the patient has hypotension, requires a vasopressor score, we label it as a septic shock. All such patients require admission in the ICU. In the first hour, what they have prescribed is consider it as a medical emergency, and a 1 hour bundle, the first hour bundle has been advised, which includes starting IV fluids, taking samples for blood culture, serum lactate level apart from the routine samples, and administer broad spectrum antibiotics after we have taken the samples for blood culture. At least 2 blood culture samples has to be taken in all these patients, and begin a rapid infusion of fluids to improve the blood pressure. If the patient's blood pressure doesn't improve with the administration of fluids and crystalloids, we should start the vasopressor therapy so as to maintain a mean arterial blood pressure of more than 65 mm of mercury. Then I move on to step 2, that is localizing signs of infection if they are present in that particular individual. In these things of localized sites, we should do after a complete history, we should do a thorough physical examination which can give us a clue to the localization of the infection. Starting from the CNS, we should look for meningeal signs, history of any focal seizure or neurodeficit. Then in the throat, we should look for all tonsils, any pharyngeal ear discharge, any tonsil enlargement, and any lymphadenopathy in the neck. Moving on to respiratory system, a thorough examination of the chest, presence of any crepitations, and then we look for abdominal liver tenderness, Murphy signs, so as to diagnose hepatobiliary diseases. All these are important because we can plan our investigation, like a patient requires earlier chest x-ray or ultrasound modalities or any other amazing techniques as per the localization of the infection. Then that localization of the infection is treated accordingly. There are few signs which sometimes are helpful in the diagnosis. Like we can have a presence of Ascher and scrub typhus. It's very important to look for Ascher. This is almost, if present, is pathognomonic of scrub typhus. They should be looked at especially in the genitalia area, abdominal folds, breast folds, where it's quite common. And we can have a purplish rash of meningococcemia, sometimes ticky rash in dengue, and typical appearance of rash in varicella also. Then I go on to the syndromic approach which has been advocated in undifferentiated fever. So they have divided undifferentiated fever into 5 categories, 5 syndromes. Like you can have acute undifferentiated febrile illness with presence of thrombocytopenia with or without rash, along with jaundice, with renal failure or evidence of multiple organ dysfunction, and patients presenting with ARDS or patients presenting with encephalopathy. Most of the conditions, sometimes we see overlap of one over the two. So these things has to be taken in mind. The important causes of like thrombocytopenia with rash are dengue, chikungunya, rickettsia, meningococcal, leptospirosis, measles, rubella, and falciparum malaria. The patient presenting with ARDS, the common causes look for H1N1 and COVID if they are prevalent in the community, and sometimes patients of falciparum malaria and leptospira can also present with ARDS. Patient presenting with jaundice and renal failure, many diseases are common to have both liver involvement and renal involvement, like leptospirosis, falciparum malaria, and scrub, dengue, complicated malaria, you can have both, scrub typhus, you can have both, and macrophages activation syndrome is another entity in this. And very important is presenting with encephalopathy. Common cause presenting fever with encephalopathy will be meningoencephalitis, herpes simplex encephalitis, Japanese encephalitis. Cerebral malaria is very common to present as febrile encephalopathy. 5 common causes of acute undifferentiated febrile illness in India. The prevalence of these diseases vary from area to area in India. Like malaria in some of the areas it's up to just 5% and up to 50%. Arboviral infection, which include dengue and chikungunya, is from 5 to 19%. Enteric fever is again from 7 to 30%. And spirochetal and rickettsia infection, which were not earlier so commonly diagnosed, have a good prevalence of 10% in lepta and up to 49% in scrub typhus. I try to collect some data from the Punjab government data and also from the medical colleges in Punjab. And I found that the dengue is as common in primary care hospitals also. This is my hospital figure. We had 18% of patients of fever suffering from dengue, and in tertiary medical colleges also it's around 19%. In Punjab last year we have 11,000 cases, and this year because of the lot of rains and floods, already in 1 month we had 5,000 cases of dengue. Chikungunya is also very common, and this year also the Punjab government has figure shows around 500 cases in last 2 months. The prevalence of chikungunya in tertiary care hospitals is up to 6.5%. Lepto is also it's increasing. 68 cases have been seen in 2023 in Punjab, and so is scrub. It's increasing diagnosis of scrub and lepta, though it has rarely been diagnosed at periphery. Malaria is now decreasing trend we are seeing of malaria patients. We can rule out some common causes from some by diagnosis exclusion. Like if you have a rash and lymphadenopathy on clinical examination, we can rule out malaria and enteric fever. Similarly, if we have Escher, I already told you, we can diagnose scrub typhus. And if the patient is having fever more than 12 days and with combination of a normal tourniquet test and a normal leukocytic count, we can rule out a dengue. Then I move on to that we should perform first line and confirmatory tests if possible, and we should initiate the empirical therapy. So we have here first set of patients presenting with acute febrile illness without any systemic features and without any red flag signs. These are the patients presenting in OPD. They are not serious patients, no red flag signs are there. So first test we should do is a rapid detection test, CART test for malaria. For P. falciparum, HRP2 kits are available. This is histidine-rich protein which is specific for falciparum. If this is positive, this carries a good sensitivity and specificity. We can straightway diagnose that we are dealing with the patients of P. falciparum malaria, and that patient can be given artemether and lumefantrine in oral dose. And if the patient is negative, like his rapid detection test for malaria, we should do 2 CART tests 12 hours apart before labeling it as a negative for malaria. If it is negative and fever is less than 3 days, no specific treatment is given, no specific investigations are required at this time because we don't have any empirical therapy for this. So patient should be managed with just rest, antipyretics and supportive treatment. We should take care of hydration. But if patient is having fever for more than 3 days at presentation, then we should do all the investigations, which like complete blood counts, biochemistry, urine analysis, blood cultures, C-reactive protein, chest X-ray if required. Then specific testing for etiologies for dengue, lepta, scrub typhus, for enteric fever and so on. If and before we get results of any of these tests, we can start empirical therapy. For this empirical therapy advised is a combination of sulfexime along with doxycycline and dose of 100 mg BD. If doxycycline is contraindicated, then we can start empirical therapy of sulfexime with azithromycin. Now, the second thing is if we are having fever along with presence of thrombocytopenia with or without rash, with liver involvement, with renal involvement or with ARDS. Here if patient presenting with ARDS, if COVID or H1N1 is prevalent, we should immediately take samples for those. And other thing we should do again, malaria in these patients, as I have already told, such patients are admitted in the hospital and here we give injectable artesunate 2.5 mg per kg body weight at 0 hour, 12 hour, 24 hour, then every 24 hour and complete 5 days of treatment. In addition, we send all the investigations, like we send patients, I have already told you all the patients where fever is more than 3 days, even without thrombocytopenia or hepatic renal involvement, all the samples are to be sent in such patients. And empirical therapies again started in these patients. Antipyretics, use only paracetamol, avoid aspirin, IV fluids, oxygen therapy if it is required. Then we watch for bleeding, hypoxia, urine output and development of shock in such patients. Here we start injectable empirical therapy with ceftriaxone 2 gram IV once a day along with injectable or oral doxycycline. And same if doxycycline is contraindicated, because like pregnancy or in early lactation phase, we can give azithromycin. Specific therapy is started only once we get a positive result for any other infection. Here is like a few rapid tests or confirmatory tests. I like to highlight that serological tests which are antibody based. We consider these as confirmatory only on demonstration of 4-fold rise in titer of IgG or seroconversion in IgM in a paired specimen. A single specimen should not be considered enough for making a confirmatory diagnosis. The sensitivity and specificity of a malarial card test varies from 95 to 95% sensitive and 95% specific, especially from PFLC-PAM. The dengue antigen card has low sensitivity, but it is specific, it's positive. So better is to go for NS antigen ELISA in the earlier stage, and if patient presents after more than 5 days, we should go for antibody test. The same is for lepta, enteric fever and scrub typhus, that we should do antibody test in all these patients. The empirical therapy which I just told you, the rationale behind this therapy is that I have given a combination of ceftriaxone and doxycycline. Ceftriaxone is drug of choice for enteric fever, and it's also a drug very effective in lepta, and same is doxycycline, which is effective in leptospirosis and in scrub typhus. As per recommendations of the Association of Physicians of India, empirical treatment with doxycycline is clinically appropriate strategy for reducing morbidity and mortality in patients of non-malarial acute undifferentiated febrile illness. Now we have patients presenting with encephalopathy, acute febrile illness with encephalopathy. So immediately on arrival of the patient, we should assess the patient and spot ABC, that is airways, breathing and circulation. We should immediately, the first step should be to measure blood glucose level, that we may not be dealing with a hypoglycemia or a hyperglycemia with fever. Manage accordingly. All such patients should be started off for hydration and antipyretics. That should be the first step. And if patient has got seizure, immediate anti-epileptics has to be started. We see for features of raised ICP, because if we have focal signs or raised intracranial pressure, the first thing will be to start measures to lower the ICP, which is like IV mannitol or hypertonic saline, proper position, fever and seizure control, steroids wherever they are indicated. And all such patients, once the seizures are controlled and we have started decreasing ICP therapy, we should send these patients for neuroimaging. On the other hand, if we have focal signs absent, then we can go for lumbar puncture. Before going for lumbar puncture, all such patients should be sent for, we should do ABG, CBC, complete biochemistry in all these patients. Apart from the diagnostic test, specific test which I have advised in patients so far, simple AFY with thrombocytopenia or renal hepatic involvement. So CSF should be sent for biochemistry, cytology, gram stain culture, and also for viral PCR for herpes simplex. If available, biofire for CSF for biofire should also be sent. So all such patients should have malaria testing, and if malaria is positive, we should treat it as a cerebral malaria. And if the malaria is negative, all such patients should be started on empirical therapy, which is injection ceftriaxone 2 gram intravenously twice daily. This is a expected diagnosed meningitic dose, and because every minute matters in such patients, and we should also start with acyclovir 10 mg per kg body weight intravenously 8 hourly, because acyclovir is effective only in the first 48 hours if it started in a herpes simplex and simplex patient. So it is a part of empirical therapy. I have already told you specific testing for all enteric, dengue, scrub, lepta should also be immediately done. A few lines about biofire. Biofire test is a FDA cleared syndromic test. It is a PCR test, and which targets the 14 important pathogens, which include bacteria, virus and fungus, and these 14 are the most common causes of CNS infections. And this just 0.2 ml of CSF can give us a target the causative organism within 1 hour. This is available in now a lot of centers in India. In Delhi, it's available in many centers. Then, a few lines about empirical therapy in a patient of sepsis, which I said that we should give a broad spectrum antibiotics in the first hour of the sepsis bundle management. So we initiate empirical therapy in patients of sepsis and septic shock within first hour of presentation. The preferred drugs are, which have been described, is imipenem in doses of 500 mg IV 6 hourly, along with combination of micacin 15 mg per kg body weight once a day. And in addition, we can add vancomycin if we are suspecting MRSA. And if patient has already been antibiotics from outside, we can straightaway start with the teicoplanin in the prescribed doses. Alternative to imipenem, and we can use a combination of meropenem or piperacillin plus tazobactam. Daily treatment has to be considered on daily basis, and we can monitor sepsis with the help of procalcitonin levels. Procal is a good test to monitor the sepsis. Then I move on to specific therapy. Once we have diagnosed in this much time, we will get the reports of specific tests which I have already sent. Specific therapy for malaria, especially cerebral malaria, or especially if it's a falciform malaria. I already told you about drug of choice is artesunate. Alternative In cerebellum area, earlier we used to use quinine, especially in patients of pregnancy in the first trimester, but now artesunate has been approved in the first trimester of pregnancy also. In enteric fever, ceftriaxone in the doses of around 2 gram intravenously OD remains drug of choice. For scrub typhus, doxycycline is the drug of choice. And in leptospirosis, penicillin G is the drug of choice. While in dengue, we should maintain we should give isotonic fluids and keep a watch on the hematocrit level. It should be guided by the serial hematocrit determinations. Blood transfusion in dengue is done only if there is a overt bleeding or if there is a rapid fall in the hematocrit or the platelet count is less than 10,000. We should keep a watch in the vulnerable population, especially consider the comorbidities, like some of the patients of cardiovascular diseases may be on blood thinners or anticoagulants, and in many patients of fever presenting with thrombocytopenia, and if we find that platelet counts are below 50,000, we should immediately stop the blood thinners. We should keep patients of malignancy especially who are on chemotherapy. They are immunocompromised host, post-transplant patients we consider as a immunocompromised host. We should also keep a watch in old age, because some old age patients are not having fever, but they may be having underlying source of infection. Just 2 slides more. Then febrile neutropenic patients, I like to say that any oral temperature of more than 38 degrees centigrade, if it's sustained over 1 hour, or 2 consecutive readings of just 38 degrees centigrade for 2 hours, with absolute neutrophilic count less than 500, it should be considered as febrile neutropenic and should be very aggressively treated. So immediately these such patients should be preferably admitted and started on cefpoapride sulbactam along with amikacin. All such patients should be monitored every day, and if in the 48 hours no response is there, we should add vancomycin, and still if in 2 days no response is there, we should consider giving antifungal, and liposomal amphotericin B remains the drug of choice. We should also keep in mind some non-infectious causes of acute febrile illness like pontine hemorrhage, neuromalignant syndrome, and so on. Coming back to my case from where I started. So patient was sent for neuroimaging. All the routine investigations were normal except for leukocytosis. Patients all rapid car tests, malaria, dengue, typhoid, CRP, blood cultures were negative. His CSF examination showed PCR was positive for herpes simplex 1. His MRA did show subtle T2 and T2 flare hyperintensity involving bilateral medial temporal lobes, which is a confirmatory of viral encephalitis. This patient was already on acyclovir, started as empirical therapy, so that was continued for 2 weeks. And patient CSF report came on 3rd day. So that was the advantage of starting empirical therapy, that otherwise 72 hours would have wasted if we have not given the empirical therapy. So take home message is a stepwise syndromic evaluation of acute febrile illness should be considered. We should base evidence-based algorithm which can guide primary physicians or specialists to use relevant diagnostic modalities and initiate early empirical therapy based on the clinical syndromes for better management of fever. AIIMS New Delhi has designed a appropriate antibiotic therapy for all the localized site of infection conditions, and they have developed an app also. So for an appropriate antibiotic therapy, we can take help of that app, which will guide us for antibiotic therapy. Thank you so much for a very patient listening.
Thank you, sir. For the next talk, I would like to invite Dr. Altaf Mir, Head of Department of Burns and Plastic Surgery at AIIMS Bathinda, for his talk on the topic Surgical Site Infection and Overview.
Good afternoon, everyone. and Dr. Altaf, Associate Professor, Burn and Plastic AIIMS Bathinda. I hope I will not take much of the time in discussing an overview of surgical site infection. Before mentioning the definition of the surgical site infection, I want to mention here that 20% of all healthcare associated infection is the surgical site infection, and it occurs in 5% of the patients undergoing surgical procedures, and a most common nosocomial infection among the surgical patients is surgical site infection, and it increases the overall cost and the length of the hospital stay. And most important is that it is largely preventable. Since it is associated with the healthcare associated infection, it's largely preventable. What is surgical site infection? Surgical site infections occur near or at the incision site and or deeper underlying tissue spaces and organs within 30 days of the surgical procedure, or previously it was considered 90 days after the implanted prosthetics, but CDC guidelines have changed and now they include in the definition that within 1 year after the implanted prosthetics. So this is the schematic diagram showing that superficial incisional surgical site infection occurs in the skin and subcutaneous tissue, and deep incisional surgical site infection involves this skin, subcutaneous tissue and muscles and the fascia, and organ and space surgical site infection involves the cavities and the organs. Surgical site infection can be classified into incisional surgical site infection and the organ or space surgical site infection. Further, incisional surgical site infection can be superficial or deep, as described in the previous schematic diagram. And further, the both deep incisional and the superficial incisional, they can be primary or the secondary. Primary and secondary, here we can differentiate that if say for example we operate on the head and neck region and we take a flap from the leg or the thigh, so primary operating site here there is the neck and the secondary surgical site is the thigh. So accordingly, if infection occurs in the primary site, it is the primary surgical site infection or the secondary surgical site infection. So what are the risk factors for surgical site infection? So a patient's condition may be responsible for surgical site infection, or the staff of the hospital may be responsible, surgeon or the surgical procedures, and the theatre environment and the equipments, they may be responsible for the surgical site infection. And among the patient related, the age, advanced age may be a factor, nutritional status of the patient, diabetes, nicotine use, obesity, coexistent infections, colonization, altered immune response, long preoperative stay, and then among the preoperative and intraoperative risk factors, there may be an inappropriate prophylaxis given, infection at removed site not treated before the surgery, or shaving used for the hair removal rather than clipping, and improper skin preparation, improper hand antisepsis, environment of the room if it is infected, surgical attire and the drapes, surgical techniques involved, and if there is a long duration of the surgery. And then post-operative, among the post-operative factors, improper surgical site dressing may be the cause, improper hand antisepsis may be the reason, environment of the room may be the reason, and long preoperative and post-operative stays often lead to the infections. Surgical site infection is preventable since it is mostly caused by the healthcare associated infection. So it is grossly preventable. So surgical site, it is started, there is a project, surgical site infection prevention project, which has been started in August 2002 by the CDC, and it is based on the two facts that 40 to 50%, around 50% of all surgical site infections are preventable, and it is associated with the almost 40 to 50% of healthcare associated infections. So, and overuse, underuse, improper timing and misuse of antibiotics occur in around 50% of the cases of operations. So it is gross, it can be preventable in around 50% of the cases. That is the basis for the prevention. So if we take a proper precautions, so this surgical site infection can be preventable. So as discussed previously, that prevention of surgical site infection, there are the certain causes as preoperative, intraoperative and postoperative. So prevention is directed at these three levels. So there is a preoperative phase, intraoperative phase and postoperative phase of the prevention. So in preoperative phase, glucose monitoring is very important. So there should be a proper glycemic control in the patients. Oral antibiotic, proper antibiotic should be used. Sick-in preparation should be with the 4% chlorhexidine gluconate, and procedure basic patient education is very important. Intraoperatively, a proper antibiotic should be used either at 1 hour before the incision, or it should be repeated if the duration of the procedure is long, or there are the bleeding during the procedure like liver surgeries. And the trays, surgical trays, they should be handled with proper gluing. And then post-operatively, the removal of incision dressing on the post-operative day is very important. If it is removed late, then they may lead to the colonization and the surgical site infection. Daily showering with a 4% chlorhexidine gluconate is recommended. Emphasis on hand hygiene is very important to prevent the surgical site infection. And discharge home with the hand sanitizer and with the 4% chlorhexidine gluconate washes. So this is the prevention bundle for the surgical site infection. There is a preoperative bathing and showering, surgical antibiotic prophylaxis, proper antibiotics to be used, and hair removal by the clipping, not by the shaving. Surgical hand scrub and the preparation is important, and second antiseptic preparation with the 4% chlorhexidine gluconate. So antibiotic prophylaxis is very important in cases. So when it should be given, so ideally it should be given 1 hour before the incision or before tourniquet application. And now dosage is also important. Should we give 1 dose or should we repeat the dose? The additional doses should be given if there are prolonged surgeries, such as neurosurgeries, or if there is excessive bleeding like in liver surgeries, because their risk of the surgical site infection is more. So you can require a repeating of the dose as per the antibiotic dosages and duration. So 5 minutes hand washing is very important. So every surgeon and every health worker should follow this in separate. So these are the 6 steps. So rub palm to palm, rub palm over palm of the hand, fingers interlaced, palm to palm, fingers interlaced, and then fingers interlocked into the palms, and then rotational rubbing of the thumb clasped into the palm, and then rotational rubbing of the clasped fingers into the palm. So these 6 steps should be used, and for 5 minutes the ritual washing of hand is very important for the prevention of the surgical site infections by all healthcare personnel. What are the CDC guidelines for the sick-in preparation? So showering or the bath with an antiseptic agent the night before the operating day with the chlorhexidine gluconate 4% is recommended. Thoroughly wash and clean at and around the incision site to remove gross contamination before performing antiseptic skin preparation is necessary. Use an appropriate antibiotic for the skin preparation, antiseptic for the skin preparation, and preoperative antiseptic skin preparation is used in concentric circles moving towards the periphery. So the prepared area must be large enough to extend the incision or create a new incisions or drain sites. So diagnostic criteria for surgical site infections. Superficial surgical site infection as per the definition within 30 days, but the day 1 is counted from the day of the surgery, not from the second day of the surgery. So it involves the skin and subcutaneous tissue, and one of the below features should be involved. The purulent drainage from the superficial incision, organisms identified by culture or non-culture methods, superficial incisions that is deliberately opened by the surgeon, culture or non-culture basic testing is not when it is not performed, and patient has at least one of the signs and symptoms of the inflammation. or diagnosis by the surgeon or physician, or the physician designing, if their diagnosis is already there. So any one of them and definition, then it may diagnose the superficial surgical site infection. And then deep incisional site infection. As before, per the definition, it is within 30 days and involves only skin, subcutaneous tissue, fascia and muscle. But the patient should have one of the following. So if there is a purulent drainage from the deep incision that spontaneously dehisces or deliberately kept open by the surgeon or the physician, on culture or non-culture basis, if shows it is positive, or if it has not been done, then if their diagnosis is by the physician or the surgeon, and patient has at least one signs of symptom of the inflammation, or there is any abscess or other evidence of infection involving the deep incision that is detected on gross anatomical or the histopathological examination. Now, what is the diagnostic criteria for organ space surgical site infection? Within 30 days, and it involves any part of the deeper than the fascia or the muscle or the cavity or the organ. So patient should have at least one of the following: the purulent discharge, organisms identified on culture or non-culture methods, or patient has at least one of the signs or the symptoms of the inflammation, or there is an abscess or evidence of infection involving the organ or space that is detected by the gross anatomical or histopathological examination. Now, what is the management of the surgical site infection? For surgical site infection management, surveillance is very important. So surveillance starts from the hospital, and it continues for 30 days in case of an operations where the implants have not been used, and 1 year in where the prosthetic implants have been used. So once diagnosed by the surveillance, and then it should be managed, and the pus should be drained, and there should be a thorough debridement, and antibiotics should be used as per the culture and the sensitivity. And in case of implants are infected, and then implants should be removed as soon as possible. And then proper wound dressing at proper intervals is very important for the management of the surgical site infection. As I said, the surveillance is very important. 30 days in all cases of surgeries, and previously as per the CDC it was 90 days, now 1 year in case of the implant or the prosthetics when used. But it starts right from the beginning, right from the ward, and not only the doctors, and every healthcare personnel should be involved for surveillance. From nursing officer to the doctor, everyone should be involved. In the ward, it can be by noting the signs and symptoms, or as per the diagnostic criteria discussed. And once discharged, it can be these can be kept under surveillance by the frequent visits in the OPD or follow-up visits, or by the phone calls. What is the role of the medical profession in the wound care? So prevention is very important in case of an healthcare associated, because it is 40% of the cases are because of the healthcare associated infections. So if we take the proper precautions, hand washing, proper antibiotics are used, proper dosage is used, and hospital environment is kept aseptic, and proper cleaning is done, and proper and the surgical procedures are done properly, hemostasis is maintained, tissues are handled with care. So these surgical site infections are mostly preventable. And the surveillance is very important. As I said, once we have to keep the patient on surveillance right from the first day and even after discharge, and to achieve the diagnosis. Once the diagnosis of surgical site infection is achieved by the surveillance, so it should be reported. There should be registries in every hospital, and this should be reported to the hospital and hospital administration that there is a surgical site infection, and that should be properly managed. After that, there should be a proper management. After the wound management should be done, and then antibiotics should be given as per the sensitivity. And At last and but not the least, research is very important. How can we improve the preventive measures? How can we improve the surveillance methods for diagnosing these cases? And how can we manage these patients at different levels? How can we improve the debridement? How can we improve the dressing methods? Or how can we use the newer methods of the dressings to improve management of the surgical infection? And for the research, we should not, only the doctor should not, even the nursing officer should be included in such research projects or methods. Thank you.
Thank you, sir. For the next talk, I would like to invite Professor Dr. P.D. Bansal from Department of Psychiatry at GMCH Faridkot for his talk on the topic Diagnosis and Management of Anxiety Disorders.
Respected Dr. Vitull Gupta, Dr. Sonia, Dr. Meghna, my dear colleagues and students, a very good afternoon to all of you. Today I will talk on anxiety disorders, their clinical features and management. Anxiety disorders are very common. Studies suggest that lifetime prevalence of anxiety disorder is roughly around 20%. Means every fifth patient suffers from anxiety in his lifetime period, whereas point prevalence is 10%. Despite this huge presentation of anxiety disorder patients, a very few number of patients present for treatment. As most of the anxiety disorders are having onset during childhood or early adolescent periods. So most of these patients do not achieve optimally in education, occupation and economic spheres of their life. As you know, in psychiatry we have two major classification systems. One is ICD and second is DSM. The recent edition of these, they have incorporated many disorders, whereas excluded few of these. Today I will keep my talk on 5 important disorders, that is panic disorder, agoraphobia, specific phobia, social anxiety disorder and generalized anxiety disorder. First of all, I will talk about clinical features of panic disorder, agoraphobia and specific phobia, their cognitive behavior therapy, then social anxiety disorder, its cognitive behavior therapy, generalized anxiety disorder, its cognitive behavior therapy, and in the end, combined pharmacotherapy of these anxiety disorders. First of all, panic disorder. Panic disorder is characterized by recurrent unexpected panic attacks. Means for a patient to be diagnosed as suffering from panic disorder, there must be presence of at least 2 panic attacks. A single panic attack does not lead to a disorder of panic disorder. Panic attack is a discrete, that is definable period of time in which certain symptoms, they reach a peak within minutes and then gradually subsides. मतलब शू देने symptoms आते हैं फिर हौली हौली चले जाते हैं. These are the symptoms: palpitations, pounding heart, accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, chest pain or discomfort, feelings of choking, nausea, abdominal distress, chills or heat sensation, paresthesia, derealization, depersonalization, fears of losing control, fear of dying. Second important point is panic attack should be followed by persistent concerns about having additional panic attack. मतलब एक बार पेशेंट को पैनिक अटैक हो गया तो उन्हें बार-बार ख्याल आंदे भी मैनूं दोबारा ना हो जाए और देर अक्सर there is significant maladaptive change in behavior related to the attack. That is, behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. This disturbance should not be due to direct physiological effects of a substance, that is drugs, or certain medical conditions. As we know, certain medical conditions like hyperthyroidism and cardiopulmonary condition, they can also present with panic attacks. This disturbance is not better explained by another mental disorder. Means panic attack should not occur in response to feared social situations or in response to obsessions, dirt, as in case of OCD, or in the presence of traumatic images in case of PTSD, post-traumatic stress disorder. Then comes agoraphobia. Agoraphobia is marked fear or anxiety about two or more of the following situations. That is, using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, or being outside of the home alone. Individuals fear or avoid these situations because of the thoughts that escape might be difficult or help might not be available in case the patient experiences panicky anxiety. So these situations are dealt with extreme anxiety or with embarrassing features. These situations are almost always anxiety provoking, and these are actively avoided or require the presence of a companion. This fear should be irrational, that is out of proportion of the required situation. This fear, anxiety or avoidance is persistent and should last at least for 6 months. And importantly, like in other disorders of psychiatry, this should cause clinically significant discomfort in one's social, occupational and professional atmospheres. This disturbance should not be better explained by symptoms of another mental disorder, likewise OCD, PTSD or panic disorder. Agoraphobia was not a codable disorder in the previous editions. Means we were not classifying agoraphobia as a distinct entity, but in the recent one, agoraphobia is coded as individual disorder. The basic differentiating point between these two is in panic disorder, patient's concern is on his anxiety symptoms. That is, patient experiences increased heart rate, pounding heart, heart attack na ho jaye. Whereas in agoraphobia, his main concern is on the situations. भी जे ऐस सिचुएशन के विच मैनू एंजाइटी या पैनिक लाइक सिम्टम्स आ गए तो मेरी कौन सहायता करेगा और हाउ आई विल एस्केप फ्रॉम दिस सिचुएशन. Then comes specific phobia. Specific phobia is marked fear or anxiety about a specific object or situation. The phobic object or situation almost always provoke immediate fear or anxiety. We should also be able to differentiate between fear and anxiety. Fear is simply brain states associated with imminent danger, whereas anxiety is brain states associated with impending danger. For example, on seeing a lion, I became anxious, that is fear. If I am passing through a lonely place and is thinking about the coming of a lion, then this will be anxiety. Fear is imminent and has proximal stimulus, whereas anxiety is not immediate. It is pending, and here the stimulus is distal. This phobic object or situation is actually actively avoided or felt with embarrassing situation. Fear associated with out of proportion to the actual danger posed by the specific object or situation and is out of socio-cultural context. This fear is persistent, typically lasts for 6 months, and it should cause clinically significant impairment in one's social, occupational, and other important areas. Then coming to the instruments for assessing panic disorder, that is to assess whether patient is suffering from mild, moderate, or severe panic disorder or agoraphobia. We use physical sensation self-monitoring scale, severity measure for panic disorder scale, panic disorder severity scale, panic and agoraphobia scale, panic awareness or appraisal inventory, then weekly panic log, agoraphobic cognitions questionnaire, body sensations questionnaire, anxiety sensitivity index, and mobility inventory. With the help of these scales, we can classify whether patient is suffering from mild, moderate, or severe disorder, and accordingly we can plan cognitive behavior therapy. Then there are behavioral analysis of panic disorder. Nature, intensity, frequency, and duration of the symptoms are analyzed. Situations, triggers for the symptom, whether internal or external, they are analyzed. Feared consequences of the symptoms are analyzed. Factors that maintain the symptoms, history of any other mental illness or other physical illness in the family or patient of the patient, family or patient himself, that is noted. Then socio-cultural factors, relationships, support system, and expectations of the patient and family members from the treatment, they are noted. Attempts are made on individual basis to overcome the problem. Awareness regarding the problem and psychological interventions are told to the patient. Then coming to cognitive behavior therapy. Cognitive behavior therapy, it is based on cognitive emotion processing theory. It is a hypothesis according to which there exists a cognitive fear structure which represents stimulus, response, and meaning, and carries blueprints for the actions of escaping or avoiding the dangers. Means if the environmental stimulus is really harmful, then these structures, so-called hypothetical structures, they will react in a way which will be fruitful or productive for the person. If the stimulus is less harmful or it is wrongly interpreted, then these hypothetical structure, they get dysregulated, which results in anxiety disorder. So the steps, basic steps in cognitive behavior therapy are, first of all, patient's history is elaborative history is taken, his symptoms and concerns are noted, patient is psychoeducated about the disorder and symptoms, then the required cognitive restructural training in the form of improving cognitively wrong beliefs, they are addressed, behavioral modification they are done, and in the last result of all these things is noted, and wherever the drawbacks are present, these are redressed so that the problem does not occur in future. This looks simple, but in fact it is very time consuming. So the basic steps are, first of all, therapeutic alliance is made, patient is psychoeducated about the problem, presenting cognitive behavioral therapy formulation, format of therapy sessions are told to the patient. Patient is advised to self-monitor his symptoms. Cognitive restructuring is done in the form of verbal and behavioral methods. Cognitive restructuring means, suppose a patient is suffering from panic attacks. My heart is palpitations are there, heart attack hoga. He is told that these are duration based symptoms, these are not catastrophic. As these have come, these will go within minutes. Means these are not threat to one's integrity. Then modification of anxiety maintaining behaviors are done, homework for assignment are given, and patient is assessed periodically. Then comes generalized anxiety disorder. It is characterized by excessive anxiety and worry occurring more days than not for at least 6 months. Anxiety is about a number of events or activities. For example, one's daily activities, his work or school performance. Person finds it difficult to control the worry. This anxiety is associated with some of the following features, that is restlessness or feeling keyed up on the edge, being easily fatigued, difficulty in concentration, irritability, muscle tension, and sleep disturbances. This anxiety, it causes clinically significant distress or impairment in one's social, occupational, or other important areas. This should not be due to physiological effects of a drug or any other medical condition like hyperthyroidism or other mental disorder. If another medical condition is present, then the anxiety should be excessive, out of proportion. And one more feature is that this anxiety should not be explained by the symptom. Previously, it was not due to the mental disorder. Now, here it is due to the symptoms of another mental disorder. For example, anxiety should not be confined to specific phobia or situational type. Means the patient is suffering from dog phobia. Then anxiety should not occur only in the presence of dogs. GAD is assessed by GAD 7 scale, GAD severity scale, and Hamilton anxiety rating scales. Then the patient is again behaviorally analyzed for generalized anxiety disorder. Here nature, intensity, frequency and duration of the symptoms are assessed. Any deficits that contribute to worry, they are noted. Situations or triggers for the symptom, whether internal or external, they are noted. Feared consequences of the symptom, that is fear of losing control over thoughts or developing mental illness or physical illness like blood pressure and other health problems. Increased BP, vertigo, these are the general symptoms by which most of the anxiety disorder patient they present to the OPD. The factors that maintain the symptom, that is avoidance, reassurance, safety behaviors, beliefs about need for control and intolerance of uncertainty accompanied by family members. History of mental illness or any other physical illness is noted. Socio-cultural factors, relationships, support system and expectation of the patient and family from treatment is noted. Attempts made by the individual to overcome the problem, awareness of the patient and significant others regarding the problem and psychological intervention, they are noted. Then the cognitive behavior therapy is initiated. Again, the principles are same. First of all, therapeutic alliance is made. His sources of symptoms with the help of a diary, they are noted down. His cognitive coping mechanisms, they are noted. It is noted where these cognitions are at fault. Patient is taught about these abnormal beliefs, and then again the outcome of all these methods is noted. Then comes social anxiety disorder. Social anxiety disorder is characterized by fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. For example, during social interaction, where patient have to interact or perform some activities, individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. If the patient has to engage in these social situations, he will do so at the cost of anxiety symptoms or feel embarrassed. These social situations, they almost always provoke fear or anxiety. These situations, they are avoided or endured with intense fear or anxiety. This anxiety is out of proportion to the actual threat posed by the social situation. It is persistent, that is, it should last at least for 6 months so as to make a diagnosis of social anxiety disorder. It should cause clinically significant impairment in one's social, occupational or other important areas of life. This anxiety should not be due to any other drug of abuse or any medical condition or mental condition. If another medical condition like Parkinson's disease or disfigurement from burns or injury, then this anxiety should be excessive. Again, the steps involved are same. Basic difference in cognitive behavior therapy in all these disorders is cognitive restructuring. Means patient ਦੇ गलत विश्वास ਜਿਹੜੇ गलत belief है वो किस जगह ਦੇ बारे है, those beliefs they are readdressed. For example, see a patient who is showing anxiety symptoms in a crowded place. He can be a patient of social anxiety disorder. He can be a patient of PTSD. It is the explanation which patient gives. Those explanations, they are addressed, they are corrected. Generally, patient use overgeneralization. एक ने धोखा देता सारे जन ही धोखा देंगे या एक जगह पे मैं सफल हुआ कितने भी नहीं सफल होना. These cognitive beliefs, they are corrected. Then coming to pharmacotherapy. In general, SSRI are the treatment of choice. SSRI in the form of escitalopram, fluoxetine, paroxetine. These are started in low doses and then gradually increase till the desired results appear. We can use SNRI like duloxetine, venlafaxine, disvenlafaxine. Reversible inhibitors of MAO, that is moclobemide, it can also be used. If we are using moclobemide, then we should know about cheese reaction. At least 2-week interval, washout interval should be observed. We can use low doses of neuroantipsychotics like quetiapine. Anticonvulsants in the form of pregabalin can also be used. In severe cases, benzodiazepine can also be used, but these should be tapered off once patient becomes free from anxiety symptoms, as these have a abuse potential. Thank you.
Thank you, sir. And for the last talk of the day, I would like to invite Dr. Vipin Talwar, Director and Consultant Endocrinologist from Golden Hospital, Jalandhar, and President of RSSDI, Punjab, for his talk on the topic, Management of Hypertension in Diabetes.
So good evening, friends. The last lecture of the day, always a difficult one. People are tired. So I will keep my lectures short, to the point, and if possible sweet also. Today is a very special day. It is 23rd of September, and this day is called as equinox. Equinox is the day when the day and night are equal. 12 hours of day, 12 hours of night. So my topic today is regarding two diseases which are equally important, that is hypertension and diabetes. So this is like an equinox in the scenario of the metabolic diseases. And this is how we are going to proceed. We will go with some epidemiology of hypertension, what is pathogenesis, and what about some guidelines, and then some evidences regarding blood pressure targets and how do we manage this hypertension in a diabetic patient. So RSSDI is a research society for study of diabetes in India, and it has given guidelines last year regarding the clinical practice recommendation of management of diabetes and the component of hypertension and diabetes. I was one of the persons who was member of the committee who formulated those guidelines. Definitely hypertension, it is known to everybody that hypertension is persistent increase in BP beyond 140. But ACC, that is American College of Cardiology, has changed it recently to 130/80. But if we talk of Indian guidelines, still we say that hypertension is blood pressure of systolic equal to or more than 140 and diastolic more than 90. So India, we are still following 140/90 compared to the West, who have slightly gone down to 130/80. And why this combination of hypertension and diabetes is important? It is important because it is almost a deadly duo. Hypertension is the most common comorbidity in patient with type 2 diabetes, and prevalence of hypertension is quite high in diabetics. And once this combination occurs, there is increased chance of all the comorbidities. It may be CVD, it may be nephropathy, retinopathy, all are gone up. And this cartoon tells us regarding the hypertension and diabetes. And what happens when they are combined together? Diabetes, you know, presently it is almost 6% of world population having diabetes, and almost 25% of people all over the world are having hypertension. But once they are combined together, then we see that almost 40 to 80% of people with diabetes do have hypertension. And once hypertension sets in, there is more chance of getting microvascular disease, especially the kidney disease. 70% chance of getting kidney disease once hypertension is added to diabetes. 3 times more chance of getting heart attack, 2 times more chance of getting a stroke, and 2 to 3 times chance of getting a leg amputated because of the peripheral vascular disease. So you can see that this combination, once it comes together, is going to create havoc to many systems of the body. And if we talk of pathogenesis, this is interesting for the residents who are sitting in the audience, because this is usually asked as a question in their MD exam, that what is the pathogenesis of hypertension in diabetics? Hypertension has got many reasons, but insulin resistance is an important factor which can also lead to hypertension along with the diabetes. Insulin resistance, as you can see in this cartoon, through inflammation, through sympathetic nervous system stimulation, through RAS activation, and through ANP suppression can lead on to hypertension. So we can see that insulin resistance, which causes diabetes, can also cause hypertension. And if you talk of Indian scenario regarding hypertension in diabetic patients, it has been found that diabetic people, they have 1.5 to 2 times higher prevalence of hypertension as compared to non-diabetics, and 50% of diabetics in India, they do have hypertension also. And as we understand, there is more chance of micro and macrovascular complications if hypertension is present along with diabetes, and understandably so the old people, they are more at risk because of complication of this deadly duo. And do we have any data which tells us, yes, this hypertension and diabetes together, they do cause some trouble? Answer is yes. Birmingham study, I'm sure everybody in the audience is aware about this study. This study has shown very clearly that once hypertension sets in a diabetic patient, you can see the orange bars, there is more chance of getting all-cause death, more chance of CV death, any CV event, MI, stroke or congestive heart failure. So Birmingham data is clearly showing that hypertension in diabetics is going to give a lot of trouble. So dear friends, we have now discussed that hypertension is higher in diabetics and it causes a lot of troubles. But is there any evidence that there is benefit of treatment? Because then only we can tell our patient, dear, you take this medication, your BP will come down and you will have some benefit. For that we have to tell, or we have to show some data from the literature that yes, there is benefit of treatment. Couple of data I am sharing with you. And before I share that data, I give a statement that in diabetics, intensive BP control is even more beneficial than tight glucose control. So you treat glucose, you treat diabetes, you bring down the glucose, but if you bring down the blood pressure significantly, you are going to get more benefit. More benefit regarding stroke reduction, regarding reduction of death for any reason, diabetes, even microvascular complications and CVD. UKPDS, the study which is very popularly mentioned in all the literature every time, it has clearly shown, you can see the red and the blue arrows going down. Glucose control brings down MI, it brings down microvascular complication, but BP control decreases all these things much more emphatically. So you can clearly see that the red or orange bars, they are much deeper as compared to the blue bars. So UKPDS tells us that BP control is really important. SHEP study, which is systolic hypertension in elderly patients. Again you see, patient is a diabetic or non-diabetic. The right panel, if you see, risk reduction of blood pressure is significant in decreasing the micro and macrovascular complications. HOT trial. Again it confirms and shows that BP control reduces CV events in diabetics. You can see reduction is to the tune of almost 51%. It may be MI, may be stroke or any other CV death. And this advanced BP, which is a very popular study, again it has shown that there is a 14% reduction of the risk of death, that is the total mortality, if you control the blood pressure in your diabetic patient. So this brings us to the next part of the story, that how much blood pressure should be reduced. So now you have decided that you are going to treat your patient, but what should be the level of BP which you will bring your patient to? So answer is given here in few of the slides. Before that, some of the hypertension guidelines. We cannot go into details of this because this timeline of 1977 till today, we have got almost more than 20 guidelines which have come over. But just couple of studies regarding the target of blood pressure to be achieved. Accord BP, almost 5,000 patients. It showed that reduction of BP to the tune of around 120 compared to 133 was significant in decreasing various events. And most important in this study was reduction of stroke. Stroke went down by almost 41%. Sprint study, again, these were the non-diabetic patients, but they were at high risk. It again showed that getting the BP to around 121 compared to 136 was associated with 25% reduction of the primary outcome, which was mainly the coronary artery disease and stroke, and 27% less risk of getting death from any cause. Accord BP sub-analysis, again, bringing down the BP to around 120 or so compared to 135 was associated with reduction of both macro and the microvascular complications. And this is a compilation of the various trials which have shown that intensive treatment blood pressure brings down various micro and the macrovascular complications, which include MI, which include stroke, and which include all-cause death. But how down we can go? Can we go down to say 100 systolic or 110 systolic? Answer is no, because all these studies, when their data was analyzed, it was found that more down we went, there were more chance of getting the serious complications. Therefore, we have to reach a balance where the blood pressure is controlled and the patient is getting the most benefit. So what is that level? So this level is mentioned here in this slide, which is a cubic spline model. And if you see this slide, it shows a J-shaped curve. That you bring down the blood pressure to around 140, the hazard ratio of various complications becomes 1. That is, patient is getting complications similar to a non-hypertensive person. And this hazard ratio, it reduces, that the benefit appears once the BP is between 140 to 120. But if the BP goes below 120, hazard ratio starts rising again. This means the blood pressure should not be brought to less than 120. So based upon this data, AD has told very clearly that BP target should be individualized on all the patients. And what should be that target? Most patients of diabetes and hypertension should have BP of 140 by 90 or less. But in special individuals, that is those who have got more chance of getting CVD, then we can go down to less than 130 by 80. And what is this risk of ASCVD? ASCVD risk is calculated by a formulation or by you can say an app in your mobile phone. And if this 10-year risk is more than 15%, you bring down the BP of your patient to 130 by 80 or less. But if it is less than 15%, we are happy with getting it around 140 or 90. And RSSTI, it also mentions that we should bring down the BP of a diabetics to 130 by 80 as a general category. But in the elderly patient, we can be happy with less than 140 by 80. And they have given a very sweet example that BP should be checked at every visit. Many times, even if you're busy in your OPD, you forget to check your BP. Blood pressure should be checked every time in a diabetic patient once he visits your clinic. And you should try to analyze or assess the 10-year risk of a ASCVD event by using a calculator. And this should be done at least once in 1 year. So now we have discussed till now hypertension, its importance, it should be treated, and we should go down to what level. Now how should we treat our hypertension? So what should be the management of hypertension? So we have to select a therapy which should prevent mortality, it should prevent adverse cardiovascular events, and it should also prevent the progression of renal disease. And RSSDA, it gives a very clear indication or guideline that if the PP is more than 120 by 80, you start with the lifestyle intervention, which can be in form of control of weight, dietary approaches, and increase in the exercise. If BP is more than 140 by 90, then lifestyle intervention, and you need to give medications also. You will start with single medication and then you will titrate it to achieve the desired goal of blood pressure. But if the BP is more than 160 by 100 at first go, then you will start with two drugs simultaneously and will adjust the dose so as to achieve your target. And this is a very beautiful slide which compiles all of the non-pharmacological interventions which can be useful in prevention and treatment of hypertension. Need not to go into details of these because it itself is a big lecture, and I think next year Dr. Vitull is going to have one lecture on this lifestyle management of blood pressure also. Only thing what I will like to mention from this slide is the dietary sodium. Sodium intake has to go down to less than 1500 milligram per day. And anybody in the audience knows what is the amount of sodium in 1 gram of common salt? Direct price for that. So 1 gram of salt gives you 384 milligrams of sodium. So roughly 400 milligrams. So and physical activity, everybody knows that we should have more than 150 minutes of exercise every week and moderation of alcohol. And these are the RSSE guidelines from Indian point of view, that we should not mix salt in rice and other cereals like roti and puri. Avoid packaged mixes, canned soups or broths. Use fresh vegetables. Avoid salted snacks, fruits, pickles and pickled vegetables. Use little or no sauce. And if possible, if you are non-vegetarian, try to use fresh poultry and fish rather than canned, smoked or processed type of meats. If we talk of the various medications, we do have few groups of drugs which are well known to everybody. ACE inhibitors, then ARBs, diuretics, that is thiazide diuretics, then the dihydropyridine calcium channel blockers and the beta blockers. So out of these drugs, which are more important diabetics? Let's see in a few slides. First of all, this is the treatment with Ramipril in the HOPE trial, which everybody knows very well. That HOPE trial was the first one which showed that ACE inhibitors, they are responsible for reduction of blood pressure in diabetics along with the reduction of the stroke and MI. Then systolic hypertension in Europe trial, in which they have used a calcium channel blocker with placebo. Again, it showed there was significant reduction of mortality, CVD mortality, also the all CV events and stroke. That is, it shows that even calcium channel antagonists, they are good drugs. Then this is a very interesting study called as ALLHAT. It compared amlodipine with chlorthalidone versus lisinopril with chlorthalidone, and the result went in favor of lisinopril and chlorthalidone. Then irbesartan, again this is a ACE inhibitor. It was found that use of irbesartan along with the control of blood pressure led down to improvement or reduction of nephropathy. So this means ACE inhibitors are nephroprotector also. Renal trial using losartan versus placebo. Again, use of losartan in diabetics is associated with improvement of renal outcomes. Then the LIFE trial. This is a very interesting trial in which they directly compared losartan, that is ACE inhibitor, with beta blocker atenolol, and you can see all the pointers in the result, they are going in favor of losartan, may it be a CV death, stroke, MI or total mortality. Then accomplished trial, again it compared a combination of ACE inhibitor with thiazide versus ACE inhibitor and calcium channel blocker, and the result went in favor of ACE inhibitor with calcium channel blocker. It brought down the risk by almost 20% of all the CV events. Therefore, from all these studies, we can safely decide that first line drug for treatment of hypertension and diabetic is either ACE inhibitor or ARB, and we have to use the maximum tolerated dose before adding or another agent. And if one class of drug is not being tolerated, that is ARB or ACE inhibitor, you can interswitch. These are the few pointers which are going whether you will use ACE inhibitors or ARBs. The data presently is slightly more in favor of ARBs, but only thing is the last line of the slide which you should know, that both these drugs, they should not be combined in a single patient because renal toxicity goes up. And single drug is usually not very effective, and we do need to have multiple medications to achieve BP control in most of the patients, and it has been shown in almost all the trials where they have tried to use the different drugs. And RSSTI, what it tells us that what drug should be used. They say that ARB alone on in combination with CCB, that is calcium channel blocker, can be used for BP control in diabetic patients, and combination therapy of calcium channel blocker and ARB is recommended to be initiated in the patient for better BP control. reducing the risk of complication and better patient adherence. Statins, they do have value in all diabetic with hypertension. Target LDL should be less than 70 if the patient has got organ damage, or at least less than 100 if the patient has got uncomplicated diabetes. So you need to give statin to almost every diabetic patient. Then we should use those oral anti-diabetic agents which exert renal protection also. SGLT2 inhibitors and DPP4, they fall into this category. And combining SGLT2 inhibitors to ACE inhibitor or ARB, it reduces nephropathy complication, and also the use of SGLT2 inhibitor leads to reduction of systolic BP by 4 to 6 millimeters. So this is a simple algorithm or a chart which we can see how to start the treatment of hypertension in a patient with diabetes. If the initial BP is between 140 by 90 to 160 by 100, patient has got albuminuria, you should start with the ACE inhibitor or ARB. If there is no albuminuria, you can choose either of ACE inhibitor, ARB, CCB or diuretic. If the initial BP is more than 160 by 90, we have to start with the two agents. Albuminuria, yes, start with ACE inhibitor or ARB along with the CCB or diuretic. No albuminuria, you can use either two of these three drugs. And depending upon the blood pressure control of patient and our effects, we can add on another agent till we are able to achieve the desired BP control. Before we wind up, two important things which are to be remembered everybody, that the mask hypertension and the white coat hypertension. They can be differentiated by the ambulatory blood pressure monitoring. If the ambulatory BP monitoring shows high blood pressure at your home, it is mostly a mask hypertension. If it shows high blood pressure in your office but normal BP in the ABPM, then it is a white coat hypertension. So dear friends, in the last 20 minutes what we have discussed is compiled here, that patient with diabetes and hypertension should be treated to a BP goal of 140 by 90 or less, but we can go down to 130 by 80 in a specific category of patients. And early drug therapy should be lifestyle therapy, but if we think that we do need to give medication, please do start with ACE inhibitor or ARB, and individualization of therapy should be taken into consideration regarding patient characteristic, preference, potential and side effects. Titration is very important, and one should use antihypertensive agent that do not worsen pre-existing metabolic conditions. So thank you my dear friends, and if there are any questions or comments from the audience, I'll be happy to answer them.
Thank you Dr. Kumar for an excellent talk, and I think you have explained in such a simple way. People will fear asking questions because they may feel that it is already, if still there are doubts or questions are welcome from the audience. So if there are no questions, we are really grateful for your presence here all along, long way from Jalandhar in this weather. We are really grateful to you.
Thank you very much. And my best wishes to the residents who are going to present their paper in the next session. Thank you very much.
So we are finished with the guest lectures. Now we have one oral presentation. So I invite Noor Kaur to present his paper on prevalence of substance abuse among adolescent and young adults in rural Punjab, a cross-sectional study. So this is a really important study given increasing drug addiction in Punjab.
Good afternoon everyone. My name is Ankar and I'm a second Prof MBBS student in SGRD Amritsar. I would like to thank Dr. Vitull sir for giving me this opportunity. The topic for my presentation, oral presentation today, is the prevalence of substance abuse in adolescents and young adults in rural Punjab. Drug abuse, as we all know currently, is a very rampant, widespread and global phenomena. And according to the United Nations Office on Drugs and Crime World Drug Report 2022, there was a 26% increase in drug abuse in 2020 as compared to the previous decade. And the number was found out to be around 284 million between the age of 50 and 64 years. This could be a consequence of various environmental factors such as having an exposure to a peer group which encourages the same, or having a similar drug abuser family member. Similarly, we know that India has also been fallen to this prey to this malevolent happening, and according to the GDPI, which is Global Drug Policy Index, which is basically a very unique accountability tool that observes, measures and compares the various national drug laws. So it judges the national drug laws and how humane and health driven those are. And India ranked 18 out of the 30 countries that were studied, and it had a score of 46 out of 100, which categorizes India as a drug policy failure and is a sign for urgent measures to be taken. Around 13% of the people that are involved in drug abuse and substance abuse are below 20 years of age, according to the United Nations. And in the comprehensive national survey on extent and pattern of drug abuse, as we see in this paper, out of the 1.8 million alcohol abusers, 30 lakh of those were below 17 years of age. They were adolescents basically. Similarly with cannabis, out of the 3.1 million cannabis abusers, 20 lakh were again below 17 years of age. A similar cross-sectional study was also conducted in Jalandhar in 2017 around the villages of Jalandhar, and the prevalence of the substance abuse found out was 65.5%, and the most commonly substance abuse was alcohol at 41.8%, followed by tobacco at 21.3%. So my paper, the methodology for my paper, it was a cross-sectional study, and it was conducted in Talwandi Sabo district Bathinda. The study participants included adolescents and young adults between the age group of 11 to 40 years. Convenient sampling was used, and a total of 200 test subjects were studied in multiple private hospitals in Talwandi Sabo at random. A preformed semi-structured questionnaire was used to obtain the socio-demographic details of the individuals, and to study the severity of the drug abuse prevalent, we used a DAST questionnaire, which is a drug abuse screening test. It consists of those 8 questions. Each yes had a score of 1 and each no had a score of 0 except for question 3. And the result of this questionnaire was basically the sum of all these questions. If the subject scored between 6 to 8, he was a severe drug abuser, 4 to 6 substantial, 2 to 4 0, 2 to 4 low, and then 0 to 2, there was no drug use prevalent. The results of the study was that out of the 200 test subjects that we studied, 180 were males, 20 were females, and the prevalence was found out to be 73.2%. 146 out of the 200 test subjects, they were drug abusers. The most commonly drug abused was alcohol at 52.2%, followed by heroin at 28.7%. Another thing to note about the heroin drug abuse was that out of the 41 abusers, 19 of them, that is nearly half of them, were intravenous drug abusers. Other commonly drug abuse were tobacco at 13.1%, cocaine at 18.49%, tramadol at 15.9%, and so on. Out of the 146 drug abusers, 127 of them also reported to have abused more than one drug at a time. The other table that we see on the other side of the slide, it correlates socio-demographic details of the subject with the abuse of drug. A common correlation that was seen with drug abusers was that it was more common in the male gender, those who were illiterate, and those above 25 years of age. Out of the 146 drug abusers, 136 were males, and 51 of those were illiterate or only had primary level of education. 35.2% of the males scored between 6 to 8 on the DAST questionnaire, which suggests severe drug abuse, whereas only one female scored above 5. Another thing to note was that some subjects in this area reported using drugs as early as 14 years of age, and the causes were again closely correlated with having an abuser in the family, or peer pressure, or curiosity, or most importantly, that the positive attitude that surrounds drug abuse in this area. Recently, 8% of the subjects also reported using drugs in the past 2-3 years because of the easy availability of those and the unemployment that has been prevalent recently. Moving on to the treatment, 118 subjects responded by saying that they had talked to a family member or friend regarding their drug problem, whereas 83 of those were even specifically involved in a drug de-addiction program. To conclude this, as we just saw that 73.2% of the subjects were reported as drug abusers, we can say that nearly 3 out of 4 adolescents or young adults are currently hooked to drugs, which is an urgent issue that needs to be brought to the limelight. Also, the grave danger that the increasing number of intravenous drug abusers pose, because this could mean an increase in the diseases such as hepatitis C or HIV. Not only is drug abuse harmful to the abuser himself or herself, but they also carry a financial and psychological burden on the family members, especially on the children, because this could mean less academic opportunities and the feeling of being left out with the children themselves. And this could push the children into the vicious cycle of drug abuse again. Thank you.
Excellent study. I must compliment a MBBS student presenting a very, very good data. But I think 2 questions I want to ask, that whether it will be biased to have subject population from hospitals, and whether you are looking for the harmful effect, dependence or abuse among the drug addicts, the drug users.
So a convenient sampling was used, which meant that it could be easier for me as a student to actually find the drug.
Yeah, but that will create a bias.
Yeah.
So next time you don't go to the hospitals, right? Stand in a market or a public place, schools, public place, gurdwaras, mandir, and you can go and check the population. That will not create a bias. And second is, drug abusers, you must see for whether they were harmful effects, harmful use, or it is drug addiction, or it is drug use. So we must demarcate among these 3, you can say, the parameters. So, but anyway, I will give you a MD degree just now only.
Thank you, sir.
For this study, definitely. I have scrutinized or judged so many studies, but you are comparable to a MD student.
Thank you, sir.
Great.
Thank you, sir.
Thank you very much. With this, we come to the end of the scientific deliberations of day 3, and tomorrow we will have day 4 scientific session, and I request all the students to please come in time, because tomorrow again this is very important. We are having felicitation ceremony and we will award certificate to the student with maximum attendance. Even if there are 10, we are going to give them certificate on stage. Right?